is on her credit till date. She has more than 40 international as well as national publications till date. And she has a membership of ICS, NCCP, IAB, API, ISDA, ISSLC. She has prestigious awards like Gurukul Citation Award on International Women's Day in the year of 2013 for contributing highly in the field of pulmonology. Her areas of interests are psychological afflictions in respiratory illnesses. She has also participated in community outreach. I cannot read the next slide. Actress, I guess, sorry. Thank you so much. Ma'am, please do go ahead with the session. Thank you.
So good morning, everyone. Tuberculosis is a disease we always come across. Probably every day we see lots of cases, but still sometimes it becomes a dilemma, not only for diagnosis, but also for treatment purpose. Often we are in dilemma whether to continue treatment, what to do, whether really it is tuberculosis or not. So with this, we'll have a discussion on case-based discussion on tuberculosis. And I'd request Professor Supriyo Sarkar to come into dais. He's a keen academician now, professor and HOD in Sagar Datta Medical College. So I request Professor Sarkar to deliver his speech.
So we welcome Dr. Supriyo. He is MD Pulmonary Medicine and is the Fellow of Indian College of Physicians. He is presently the Professor and Head, Department of Pulmonary Medicine, College of Medicine and Sagar Datta Hospital, Kolkata. He has more than 50 articles in national and international journals to his credit. He has published a book on 101 cases in respiratory medicine and edited API monograms on tuberculosis and clinical approach to respiratory medicine. He is a regular speaker in state and national level conferences like NAPCON and EPICON. Welcome, sir.
Thank you, ma'am. Respected chairperson and delegates, and I will discuss a case on tuberculosis. A middle-aged lady presented with acute onset dyspnea and hypoxemia. A 44-year lady came to our outpatient department with dyspnea and hypoxemia. She was dyspneic at rest. She cannot move or speak, and her SpO2 was 68%. We admit her in our respiratory intensive care unit, resuscitate her. Her ABG with 5 liters per minute oxygen by face mask was pH 7.33, pH CO2 57 millimeter mercury, PaO2 231 with oxygen, and bicarbonate 29.1. Now, as the next session is on critical care, I should skip that part of the discussion. And what I want to say here, that in hypoxic respiratory failure, even in normal carbon dioxide is a danger sign. We must admit and manage it properly. And her COVID was negative. So with this introduction, I invite my first year PGT, Dr. Kunal Dhar, to present the case. And this presentation is at the time of discharge from RC, when patient was stable.
Thank you, sir. Good morning, all faculties and delegates. We took the detailed history and meticulous clinical examination on 1st of August. Chief complaint, her chief complaint was cough for more than 5 years and dyspnea for about 2 years. She was housemaid and cook by profession. On detailed clinical history, the history of present illness suggests the patient has insidious onset of cough for many years. Exact onset she could not tell. Cough had no seasonal and diurnal variation. Cough was sometimes associated with scanty mucoid to purulent expectoration and blood-streaked expectoration. Shortness of breath was insidious in onset, progressive, and finally that reached MMRC grade 4. It was not associated with wheeze and any variability. She was irregularly treated with bronchodilators and antibiotics. Her past history, she had pulmonary TB in her childhood. Details she cannot tell. She had also type 2 diabetes mellitus, which was detected 2 years back, irregularly treated with oral hypoglycemic agent. She had an abdominal hysterectomy and bilateral salpingo-oophorectomy 4 years back, detail of which we could not extract from the patient. Personally, she has no addiction, but allergic to egg and prawn. She had exposure to biomass fuel as she was a cook. Family history was not significant for any obstructive airway disease or any other disease. On general survey, she was dyspneic and there was clubbing. Other general survey finding is not that significant except pulse rate 96 per minute, blood pressure 128/76, respiratory rate 23 per minute, temperature was normal, neck vein and neck glands was not elicited. Saturation was 98% with 5 liters of oxygen by face mask. Examination of the respiratory system. Upper respiratory tract, including oral cavity, was normal. Further respiratory system examination, inspection. Shape of the chest was elliptical, symmetry, flattening of the left infraclavicular area, signs of respiratory distress present. Movement diminished on the left side, overlying skin, no abnormality detected, pulsation not visible, sternomastoid sign positive on the left side. Examination from the back, drooping of the left shoulder, winging of the left scapula, and scoliosis with concavity towards left. Further examination, palpation, no temperature or tenderness, movement decreased on the left, overall in the left hemithorax, trachea shifted to the left, apical impulse at 5th intercostal space in left anterior axillary line, vocal fremitus decreased on the left hemithorax but increased in left infrascapular area. Spino-scapular distance, spine and chest wall expansion we should measure, but we could not done in RICU setup. Percussion, right hemithorax was normal resonant. Left hemithorax in mid-clavicular line, resonant up to 4th intercostal space and impaired downwards. Mid-axillary line impaired, suprascapular area resonant, interscapular area impaired, and infrascapular area dull. On auscultation, right side, normal vesicular breath sound with normal vocal resonance, no added sound. Left side, breath sound, tubular breath sound in the medial part of left infraclavicular area, cavernous breath sound in the left infrascapular area, normal to diminished vesicular breath sound in other areas of left hemithorax. Vocal resonance increased in left infraclavicular area and left infrascapular area, other areas normal to decreased. Biphrasic crackles scattered over whole left hemithorax, more prominent in left infrascapular area. Examination of the other system is within normal limits. Sir.
So with this examination history and examination finding, what is your diagnosis, as the postgraduate students are not there? So I have to make the diagnosis. For the diagnosis, we must have the structural change first, then the etiological, and then if there is any complications. So the final diagnosis, left lung fibrocavitary disease as a sequela of tuberculosis presented with hypoxic respiratory failure. This is the final diagnosis. So next question that is coming, what are the points in favor of parenchymal fibrosis? So when this question is asked, we must include from the history. There is a long history of cough, expectoration, hemoptysis, and there was signs of volume loss on the left side. And as I am discussing yesterday, that lung diseases are classified into 3 groups, where mediastinum shifted to the same side, it is fibrosis or collapse. When it is shifted to the opposite side, mainly pleural disease, and when it is central, it may be consolidation or in bilateral disease like asthma, COPD, DPLD. And the point in favor of fibrosis is the heterogeneity of the findings. There are some bronchial breath sound. There are also the breath sound, somewhere it is diminished, somewhere it is increased. And the most important, the classical findings of parenchymal lung disease is the crepitation. If crepitation is not there and your diagnosis is fibrosis, then you must try post-tussive crepitation. So without crepitation, you cannot say it is parenchymal fibrosis. Why this is not a case of collapse? The collapse usually shorter history and the findings are homogeneous. Usual classical finding with volume loss is the absence of breath sound, but sometimes the transmitted sound may be found. Another important thing, if there is a long-lasting collapse as a foreign body aspiration of low-grade malignancy, in those cases, there may be associated fibrosis. And in that case, it is very difficult to differentiate fibrosis from collapse. What are the points in favor of cavity in this case? So cavity, the signs of cavity, if it is deep and surrounded by normal lung parenchyma, there will not be any sign. But the cavity is superficial, then classically we get the cavernous breath sound. Cavernous means it is low-pitched bronchial breath sound. And the low-pitched bronchial, there are sometimes examination, they are asked what are the signs of crepitation. They are crackpot rigidity, post-tussive crepitation, and post-tussive suction. Why this is not a case of pleural fibrosis? This will be asked in this case. The pleural fibrosis, that is a long history, maybe pleural effusion, empyema, hemothorax, this history will be there, and the breath sound, classically breath sound is diminished to absent and percussion note is diminished. So here, as there is diminished note and also diminished breath sound in the lower part, we cannot exclude the pleural fibrosis. So our diagnosis, maybe there may be associated pleural fibrosis, but we cannot say. Then next question will be, what will be your plan to investigate? So our plan to investigate, number 1, to establish the structural changes. And for that, we want the radiology, the X-ray, and CT. Then I have said it is a sequela of tuberculosis. So we must exclude active tuberculosis. And next, the plan of investigation should be why there is respiratory failure in this patient. So X-ray, there is heterogeneous opacity, trachea shifted to the left, and there are some, probably maybe have some cavity in this area. But more important than this X-ray, there is some lesions in the right side. We cannot miss it. Then investigation to assess the active tuberculosis. So when we must have the detailed past history of tuberculosis, but in this case, as the patient TB develops in her childhood, so detailed history is not available. So what we should do, we should examine sputum for CBNAT and AFB, not AFB and CBNAT, because in the recent NTP guideline, the CBNAT first, then smear. So we should start with CBNAT, and suppose the CBNAT report is negative and AFB smear is negative. What will be your impression? The impression will be that probably it is not active tuberculosis, but you cannot rule out active tuberculosis. And if there is a reasonable reason to believe there is active tuberculosis, then it should be the clinically diagnosed tuberculosis. Then AFB positive, CBNAT positive. It is a clear-cut case of tuberculosis. We call it the microbiologically confirmed tuberculosis. Then AFB negative and CBNAT positive. So CBNAT is more sensitive than the smear. So it is again the microbiologically confirmed tuberculosis. And last, if AFB is positive and CBNAT is negative, then again tuberculosis, the microbiological confirmed tuberculosis, but we should keep in mind the possibility of atypical mycobacterial infection. And so patient, the sputum should be sent for culture. Then the come is the rifampicin resistance. CBNAT has two roles. One is to diagnose tuberculosis, and second is to diagnose rifampicin resistance. So when the rifampicin resistance is not detected, in that case, we have to go for first line LPA. And if first line LPA detect INH resistance, then we have to go for second line LPA and the liquid culture drug sensitivity for detecting monoresistant or polyresistant tuberculosis. And if the INH resistance is not detected, then we have to continue with the first line medications. On the other hand, if the rifampicin resistance is detected, in those cases, we must go for first line, second line, LPA, and also the liquid culture drug sensitivity test. Now, next thing, why there is respiratory failure in this patient. So for that, we evaluated with the CT, and in the CT, we can, that shows that there are mosaic pattern in the right side. So what are the causes of mosaic attenuation? Mosaic attenuation means there is low density and high attenuated areas simultaneously. And if you can confirm it by expiratory film. So mosaic attenuation, please remember, there are three causes of mosaic attenuation. Number one, it is an indirect sign of small airway disease. And in that cases, the vasculatures are, there is a scanty vasculature within these black areas. And there will be, the black area will be more prominent by expiratory film. The second cause is obliterative vasculitis. And in obliterative vasculitis, again, but there will be no change with inspiration and expiration, and you cannot see the vascular structures within this low attenuated areas. And third is infiltrative lung disease like Gaucher syndrome, etc. In those cases, there will be no difference, and white area is the abnormal area, and their vascularity will be preserved. So there is underlying lung disease on the right side, and the respiratory failure is precipitated probably by infection. It is a common thing that infections precipitate the respiratory failure in this case. So thank you.
So thank you, Mr. Sarkar. Really, it was a journey when we come across with post-tuberculosis sequelae, but often have other diseases, maybe active tuberculosis or other problems. So if there is any question from the audience, from the PGTs.
Yes.
Do you consider that as active tuberculosis, or because CVNAT, we all know dead tubercular bacilli can be identified by PCR technique, because this is not RNA, it's a DNA test. If you go by RNA test, RNA is available but not available routinely in our country, and that can only tell you that this is active TB. So
Yes.
that is one thing.
Yes. So CVNAT may be positive by remnant DNA is present. So CVNAT is not used for follow-up. But TB occurs in childhood and along with symptoms. So clinical assessment is very important. And in these cases, as there is a symptom-free period, then patient presents with cough and expectoration, though there is no constitutional symptoms, as per NTEP guideline, we should take it as active tuberculosis.
I'll simply add to this point. Actually, CBNAT, though it detects the dead bacilli, but it is not like, as Suresh rightly said, that since there was a history of TB in the childhood. So I have discussed this with at the Central TB division also with people from WHO. So what they say is that if there is, say, exposure, like if like this is a long history, like the patient had TB in childhood. But suppose if the patient is having a history of tuberculosis, say 1 year back also, or even 2 years back, then also if the CBNAT right now is positive, like it is detecting the MTB, so we should not take that it is because of his history of exposure to tuberculosis 2 years back or 1 year back. So we have to treat the patient as a tubercular patient if the patient is having otherwise fitting into clinical radiological profile of being having an active tuberculosis. Normally, maybe when the patient is already on ATT, yes, within 6 months of finishing his ATT, if the CBNAT is detecting MTB, that is of no value. But usually after 9 months, 1 year, we have to consider it as a case of reactivation.
As chest physician, we are doing bronchoscopy every day. So we can get TB bacilli, and our immunity is quite high. So if you do bronchoscopy to me, you might get a CVNAT positive, AFB negative. And what I would suggest that you can start AT drugs, but wait for the culture report. After 42 days, if your culture is negative, I don't think that we should continue AT drugs, because many patients of mine I have seen, I didn't give any AT drugs because there is no clinical criteria for giving AT drugs. So what I have explained to them, and I said, if you get back these symptoms, then you can come to me. Then probably we'll have to start.
All laboratory,
this is one
yes.
fallacy
So
of
all
CVNAT.
laboratory data should be analyzed on the background of clinical setting. This is very, very important thing. And if the clinical setting, there is no symptom, no radiological deterioration or something, CVNAT comes accidentally. Because why we start anti-tubercular drug? Because sensitivity of smear is less than 50% and sensitivity of CVNAT is about 75%. So there is definitely a group where smear will be negative, the CVNAT will be positive.
And sir, it goes for sputum for AFB also. Sometimes what we see is that we have some patients who just incidentally come out to be sputum for AFB smear positive, but there is no clinical history which is suggestive of tuberculosis, or even radiology is absolutely normal. So in those patients, definitely we have to look for the reasons for false positive AFB, and we don't start these patients on ATT. So the same goes for smear positivity also.
Yes.
We might wait.
Yes, sir, because in CBNAT, we definitely classify the bacilli as very low, medium, high. So that is very low. There is no trace reporting in CBNAT. It is a very low reporting in CBNAT.
गर्मी बाया का होने देता
I just because whenever we are doing BAL, you have a CT scan, and in CT scan, if there is suspicious of tuberculosis, because you are doing BAL from segment, and that segment should have some evidence of tuberculosis, some nodule, something.
अरे थोड़ा
So
आवाज
if
कम
there is
भाई
evidence
किस
of
पे बोलता हूँ मैं हाँ मैं
and
बोलूंगा तब
CVNAT comes positive, you cannot ignore that.
Hello, pore.
Again, in that case, I would go for madam because
Hello,
if the history is long
pore.
back, then definitely there is chance of very low chance of having a positive CVNAT because of that old lesson. So if there is recent history of ATD intake for say 6 months or like that, then if there is no symptoms such, then I would ignore that test report. But otherwise.
And sir, you yourself saying that you have done the BAL because you are suspecting that patient could be active TB.
No. Valid reason.
Yes.
Madam, we are doing BAL not for TB. Clinician, we are critical care specialists. Many a times we have to go for VAP only. And then we want to identify the organisms, bacteria. And suddenly you got the CVNAT positive. You have got Klebsiella and also CVNAT positive. In that situation, what will do? You will give both TB and yeah. That is our experience.
Yes,
in a say year, I am getting these kind of patients, at least 4 or 5. And many a times I didn't start any anti-tubercular drugs, and most of the time probably I was right. So that's why that message I'm telling to the juniors.
Incidental diagnosis.
So the bacillary load is very important. It is indicated by the cycle time. And another important point is that we all should remember when the bacillary load is low, then rifampicin may be falsely resistant. So we should be very cautious in that case also.
And sir, when the patient is diabetic, like this patient was diabetic on irregular treatment, then though as per our national TB elimination program, this patient becomes a patient of key population. So his first line, as sir has said, is not sputum for AFB, it is his CBNAT.
So guideline is generally for general people. And for the special problems, we have to discuss between ourselves to decide before starting anti-tubercular drug. So thank you.
Thank you so much, sir.
So conclude this.
I just had a comment. If our pretest probability of positive is low, why in the test at all? Even if it turns out to be positive, we are going to ignore it. Then it is better avoid sending that test. That will avoid all the hustles we
So
have.
this is what we are saying now, that if you are thinking of BAL or TB, that's why you are sending
The gene
for
expert or
CBNAT.
CBNAT should be sent only if the pretest
Yes.
probability of TB is high. If the pretest probability of TB is very low, even after the test result turns out to be positive, we are thinking whether we should really be treating or not. In that case, it is better we avoid sending tests.
Yes.
This should be applicable especially for Gene Expert Ultra because the false positivity rate with Gene Expert Ultra is very, very high.
Yes.
So when there is we collect usually 2 samples. If there is any confusion, then we can go for the other sample. This is one. Number 2, when CBNAT is positive, we should send the sample for LPA.
Yes.
And LPA will again confirm.
And even if the LPA is negative and if the patient is CBNAT is positive, as sir has told, obviously that patient's sample will be subjected to a liquid culture as per that diagnostic algorithm. Yes. So then we come to again ground zero now. What is the clinical suspicion ultimately?
I have no control on that.
I agree. Although studies suggest that it is quite equivalent, the culture is equivalent to CVNAT, but in practical terms, we see that culture comes in less number.
Yes.
Always. This is true always. And the culture is a problem for time and transport. Thank you.
Thank you. Thank you.
Our next session is a critical care case discussion. And we are lucky to have Dr. Ajay Sarkar, consultant pulmonologist and intensivist, PLS Hospital as a chairperson. And Dr. Subhash Todi is a renowned critical care expert in the country. So with this, I hand the mic over to Dr. Sarkar.
Good morning, and thank you, Partho, for organizing this conference for years together. And these critical care sessions will be covered by Dr. Subhash Todi. I don't think Subhash needs any introduction for those who are attending this conference, because I couldn't find any new faces, all are old faces. So Subhash is, I think, is going to talk on
MDR, XDR, gram-negative infection.
So all antibiotics related problem we are facing day in and day out.
Okay, thank you, Ajay. So welcome you all. So from TB to bacteria, but the resistance remains the same, the problem. So I will. Forward, okay. So just give you a world resistance map and where do we stand. You know, resistant to cephalosporin to E. coli is 83%, almost what is ESBL E. coli. So this is data from both public, private hospitals, labs, 83% E. coli resistant to cephalosporin. E. coli resistant to carbapenem is 41%. So very high resistant to carbapenems gradually creeping up in E. coli. Klebsiella resistant to carbapenem is 65%. So very high carba resistant Klebsiella again in our country. This is all Indian data. On the contrary, the resistance to Pseudomonas is gradually coming down. This is, you might say, a light at the end of the tunnel. 30% carba resistant to Pseudomonas resistant to carba. So Klebsiella is known as a new Pseudomonas. At one time, Pseudo was very resistant to carba. And this is the big bug, Acinetobacter, almost resistance to everything. 80%, 71% resistant to carbapenem. So this is the scenario, E. coli, Klebsiella, Pseudomonas, and Acinetobacter resistance. So that's the phenotype. As the genotype is very important nowadays because we deal with CTXM, which is cephalosporin ESBL, cephalosporin resistance. We deal with NDM, which is all beta-lactams, including carbapenems. And we deal with OXA, which is carbapenem resistance. So these three enzymes we deal in our country, OXA, NDM, and CTXM. So coming from here, let's start with this case. We have a patient with acute pyelo, hemodynamically stable. The patient has E. coli with ceftriaxone resistance, piptase sensitive, mero sensitive. What should be our drug of choice? Any thoughts? Ajay, what would you give to this patient?
The resistant pattern, it seems that it's CDX.
It is ESBL.
Yeah,
ESBL.
So probably BLBLI would have been good for this. And I would, since piptase is sensitive, right, and MIC is not too high, 8. So I would go for BLBLI.
You know,
first,
that's what
keeping-
we have been practicing, giving piptase in patient who is hemodynamically stable. And, you know, recently there have been, this is what is called a living guideline. You know, guidelines are published every 5 years, so it gets very old. So nowadays there are very up-to-date guidelines. The present guidelines are recommending carbapenems. We don't have Cipro, Levo, Trimeth as a sensitivity. So carbapenem as the preferred treatment because of this study, a big RCT, piptase versus meropenem on exactly the same kind of infection that I presented, ceftriaxone resistance E. coli. And whether you give piptase or meropenem, both being sensitive, and it found that mero was much better than piptase because of various reasons, but that is what the clinical outcome was. Based on that, that's what they mentioned, that if you definitely want a good outcome, probably carbapenem is better. Then should everybody get carbapenem? That's also very difficult, isn't it? Say we don't have these cultures when we start. If I have started piptase in this patient and the patient has clinically responded, and then I got this culture results, and as per this randomized study, mero is better than piptase, should I change to mero or should I continue piptase?
I would continue with piptase. Reason because if you have a pyelonephritis, it's not the 7 days treatment.
Mhm.
There are many reasons. In pyelonephritis, you have to go by the grading CT criteria wise, and then you might have to continue for 6 weeks. So antibiotics. So in that situation, since patient is getting better, and if my parameter say CRP, I go for CRP, and if I find that CRP is coming down and WBC in urine is less in number, then I'll stick to that.
Yeah. You know, the question in everybody's mind is that can there be a relapse? For example, if I continue with piptase, patient might be getting better 5, 6, 7 days, then again spikes a temperature. Can there be a later clinical failure in these patients? So the recommendation now is, if you have started piptase as an empirical therapy, but for uncomplicated cystitis, you know, they are not recommending for pyelo whether to continue with piptase. They still say you should probably change it to carbapenem, except if you have a cystitis. For cystitis, you can get away just with continuing piptase. So that is the recommendation. I think our clinical experience also counts. Just as a side, we use a lot of nitrofurantoin and phosphomycin. They are trying to avoid this for pyelo and complicated UTI. What was very interesting in this recommendation is about prostatitis. We get quite a few patients with E. coli prostatitis, and you see the dose of phosphomycin is pretty high, 3 gram orally daily for a week, followed by 3 gram orally every 48 hours for 6 to 12 weeks. As you know, prostatitis has to be treated for a long time, and this is only for E. coli. Phosphor should not be given for other organisms for prostatitis. So this is just as a side on phospho and nitrofurantoin. We do use doxy, but I was surprised in this recommendation that doxycycline doesn't have much urinary penetration. So it is better to avoid doxycycline for urinary tract infections. So coming to our second patient, again, more or less a similar problem, sensitive to piptase and mero. This time patient has Klebsiella, but this time patient has pneumonia. You know, there is a difference between urinary tract and lung as a source of infection, and what should be our drug of choice. So what would you give this patient, piptase or mero? Sensitive to both, patient has pneumonia.
Here the MIC of piptase is a bit high, and the meropenem MIC is 0.5, which is quite good. And Klebsiella, we know we are dealing with lung. So there, if you can give antibiotic, right antibiotic, probably 8 days would be good enough. So I'll straight away go for meropenem.
Yeah, but you see, this is pneumonia is a bit different from urinary tract. Here they definitely recommend carbapenem, even if there is susceptibility to piptase is demonstrated. So very strong recommendation, because the clinical outcome of the patient do vary depending upon which antibiotic we choose. For urinary tract, still one can get away with piperacillin tazobactam, but outside urinary tract, giving piptase is little problem if you have ESBL, that is sensitive to piptase and mero. Now this patient with acute pyelo, patient has blood and urine Klebsiella, and we do get this kind of sensitivity nowadays. Piptase is resistant, ARTA is resistant, but mero is sensitive. Just day before yesterday, I had a patient with ertapenem resistant and mero sensitive. Colistin, there is no more sensitivity report nowadays. It's always intermediate. So what would you do? Do you treat it as carbapenem resistant organism? Or since it's mero sensitive? Or is it, one can treat this with meropenem?
No, there is no question of considering these bacteria as carbapenem resistant, because we know in the same class, different agent can have different sensitivity. So it's not always class specific. So in that situation, if I find that meropenem has got a good MIC, and I'll straight away go for meropenem.
There is again a trick here in the sense that ertapenem sensitivity is taken as a standard for carbapenem sensitivity, in the sense that the present definition is CRE is resistant to at least one carbapenem. Any one carbapenem, whether it is ARTA, mero, or IMI. And in fact, in the lab, it is ARTA resistance is taken as carba resistance. So this, I would call it as a CRE because it is ARTA resistant, or if you can show a carbapenemase enzyme. Nowadays, there are a lot of tests which can be done.
So just one clarification, because we know that there are few bacteria who are intrinsically resistant to ertapenem.
No, they are resistant to carbapenems as a whole. There are bacteria like, Proteus.
Say, for example, it would have been Pseudomonas, then ertapenem will always be resistant.
Yeah,
so,
true. But you see, this is Klebsiella. Klebsiella resistant to ARTA, sensitive to mero. By and large, if there is one carba resistant, you call it as a CRE. You can treat it with meropenem. That is the question. Can you treat it with meropenem or not? That becomes a question. It is mero sensitive, though it is ARTA resistant. Can you treat it with meropenem? Yes, we can treat it with meropenem, but the dose of meropenem, this is what is the recommendation says, that if you have a carba resistant organism, which is ARTA resistant, but susceptible to meropenem, you will come across this kind of report. You cannot treat it with 1 gram 8 hourly of meropenem. It has to be given 2 grams 8 hourly. That's also as an extended infusion, each infusion given over 3 hours. So that's the recommendation. If you get this kind of report, ARTA resistant, mero sensitive, you better, if you want to treat with meropenem, you give a higher dose of meropenem. Or if you do a carbapenemase enzyme test, which can be done on these bugs, then you cannot treat it with meropenem. Now coming to this patient, again a more resistant organism, Klebsiella, resistant to piptase, resistant to ARTA, resistant to meropenem, sensitive to TG and intermediate to colistin. How do you treat this patient?
There is no question of considering TJ cycline, because we all know TJ penetration through kidneys less.
But this patient has pneumonia.
It's a pneumonia. Okay. Pneumonia, then in that situation, I'll go for TJ cycline, because colistin lung penetration is only 1%. If you see the drug level for epithelium drug level in with colistin intravenous dose, it's only 1%. So if I choose colistin, then it has to be double.
Anything
One is
else?
intravenous and your nebulized colistin via mesh nebulizer, vibrating mesh, not the jet nebulization. But the problem with nebulization with colistin molecule, what we have been using is CMS. And CMS, we all know this is not the active molecule. It has to be converted to colistin. Now, question is, I'm giving prodrug through the nebulized, and I have no clue whether that drug will be converted to colistin within the lung. So we have been using for years together without any scientific basis. I haven't got a single paper saying that it can be converted to colistin, but I'm using also. So that is the problem. But tigecycline, yes, there had been some restriction about using in a pneumonia. Now that restriction doesn't hold good. So TJ can be given. So I'll go for TJ.
Anything else can you give? If you have this kind of report.
MIC of meropenem is 4. So in that situation, yes, another, I can use very high dose of meropenem. 2 gram, even meropenem can be used up to 12 gram.
Any new molecule that you can use?
Here.
Which is available? Resistant to mero?
Mero, I think it's not you have given, but another thing I've been using meropenem with EDTA combination. And because I know this is not a standard practice, but just few weeks back, we have Dr. Ansari has published once been study in 4 centers. And what they have done, it's an in vitro study. They have identified the meropenem resistant piptazine, all, not a single molecule, and added the artepenem with that. And the MIC has come down to significantly below level. So that is in vitro.
But you know, there's no international recommendation still on use of EDTA in humans. What else can we do? You know, ceftazidime, for example, in this patient, which is mero resistant, ceftazidime, avibactam in combination with aztreonam. This is what can be done if you think that this carba resistance is NDM. On the other hand, if this carba resistant is oxa, then one can use just ceftazidime.
Yeah, oxa. The problem is, if I don't know, and most of my bug in my hospital, oxa and NDM co-producer.
Right. So you can use ceftazidime with aztreonam. This combination is pretty good for NDM, and one can do these tests nowadays. The labs can do with card test, whether it is NDM, oxa, or combined. So that is an option that we can use in this patient. This is the standard, the international guidelines. So in our country, it's either oxa or NDM or both, if it is carba resistant. So we should ask the lab to tell us which one is it. If it is just oxa, we can use ceftazidime. But remember, use of ceftazidime has the highest frequency of resistance. So very soon we might be seeing resistant to ceftazidime. What about, as you mentioned, tigecycline, minocycline are not recommended as monotherapy because they are not potent enough for treatment of bloodstream infection. This patient had a bloodstream infection, blood positive for Klebsiella, and they are not secreted in the urine, so not recommended for urinary tract. Polymyxin, you know, that we have been using as a workhorse should be avoided. That is what is the recommendation now, should be avoided for treatment of carba-resistant Enterobacteriaceae, E. coli, Klebsiella. Colistin can only be, maybe an alternative for uncomplicated cystitis. Combination antibiotic is also not routinely recommended. Nowadays, we use a lot of combination, which is not actually justified to use a lot of combination antibiotics. Now, this patient have a vasculitis, immunosuppressed, now growing Acinetobacter. Again, a big problem. It is resistant to all except colistin, mero resistant. So what should we treat this Acinetobacter with? ET suction and blood culture growing Acinetobacter. Should we be treating with one antibiotic, double antibiotic, or triple antibiotic?
Yeah,
This patient
it's a
is
regular,
very sick.
routine problem we have been facing in our practice. So what is my way of practicing Acinetobacter? Always I have to go for one colistin or poly B, but in this situation, I have got an option for colistin nebulization. So I go for nebulized with IV colistin. In addition to that, you haven't got any TJ cycline. So if TJ is sensitive, then I would add TJ cycline. Or if TJ is negative and sulbactam we are not doing, so I'll go for sulbactam. And sometimes I had to give rifampicin as well as getting that synergism in this situation. So that is my way of practicing.
So, but over time, it has been found that sulbactam has become a very important agent for Acinetobacter. The reason is the Acinetobacter gets resistance, not with the classical beta-lactamase or AMP-C or OXA or NDM. They have a different penicillin binding protein in their cell wall. And sulbactam is the only antibiotic which is active against that PBP2. That is the penicillin binding protein which Acinetobacter has. So sulbactam has a very peculiar property of acting against Acinetobacter. So nowadays, the international recommendation is if there is a mild infection, you can get away only with sulbactam. If it is moderate to severe, like in this patient, sulbactam should be a backbone to all Acinetobacter infection. You have to have sulbactam, even if the panel says it is sulbactam resistant. High dose AMP-Sulb, you have to use a high dose sulbactam. In West, they don't have sulbactam, they have AMP-Sulb. And it may still be reasonable to consider high dose sulbactam as a component of combination therapy. And because you can have multiple toxicities, you have to use sulbactam with either Mino, TG, or polymyxin, as you said. This is the dose of sulbactam that we should be using. We are fortunate to get sulbactam. So 8 grams of sulbactam per day is a little nephrotoxic, but it can be used. So that is the recommendation of you must use sulbactam for Acinetobacter, and the dose is 8 grams. Now the question comes, you mentioned about TG or Mino. Which one to use for?
They have recommended monotherapy as sulbactam.
For mild. Say, Acinetobacter sometimes is a colonizer. Most of the patients die with Acinetobacter rather than because of Acinetobacter. They have so many other problems and there is some Acinetobacter growing. So if you think it's a mild Acinetobacter, then you can get away. There's no blood culture positive for Acineto. You can do a monotherapy. Now, regarding this TG or minocycline for Acinetobacter, minocycline, TG cycline is better for Klebsiella and minocycline for Acinetobacter. If I have to choose one of these cyclines, if I have an Acinetobacter, I would choose minocycline. And if I have Klebsiella, then probably I would choose TG cycline. And that Klebsiella has to be intra-abdominal infection. That's where TG cycline concentrates the most. And the dosing is double. You see, normally we give 100 milligram 12 hourly for Mino. For Acinetobacter infection, it's 200. And same is with TG cycline, it's double the dose. There are a lot of GI disturbance with this, and both have this nausea, vomiting and thing. And remember, minocycline MICs cannot predict TG cycline. So they are not that if it is sensitive to Mino, it will be sensitive to TG. It's not like that. It can be different. Now, what about polymyxin? Colistin can be considered as monotherapy in combination with at least one other agent for moderate to severe CRAB. But the problem with colistin is doesn't penetrate the lung, and even the serum levels are not very adequate. So people are getting away with colistin. We have not used colistin in our unit over the last 1 month, not even a single patient. got colistin. Only one patient got the month before. So we are completely getting away with polymyxin and colistin. One can use extended infusion meropenem for CRAB, just as we mentioned. High dose extended infusion you can do, just like 2 grams 8 hourly, along with polymyxin. But you have to have a third agent if you are using these two, of which I think will be sulbactam. Sulbactam and probably minocycline. So at the present moment, I would say sulbactam 8 grams, minocycline 200 twice daily. And if patient is very sick, then probably meropenem high dose should be, or polymyxin could be the option for very sick Acinetobacter infection. You mentioned about nebulized antibiotics, but if you go through the literature, especially the Acinetobacter literature, they are not suggesting nebulized antibiotics for CRAB. I do not know about the other gram negatives, but if you are, first of all, just nebulized antibiotic doesn't work. You have to give systemic antibiotics along with that. Question is whether by adding nebulized antibiotic, are you getting a better result than if you have just given adequate systemic? Where for tracheobronchitis and all, one can say, okay, but for a systemic infection, a lobar pneumonia, for example, if you are giving systemic antibiotic, can you get away with that?
If the infection is limited to lung parenchyma or tracheobronchial trees, then possibly nebulized antibiotic is going to work. But as you have mentioned that there had been a slide, I could remember, the lung concentration is maximum with nebulized and the side effect is 0.
That's
Because
what the physiology
on the other
says.
hand, if you use the high dose of, poly and lung concentration is least and the side effect is quite high. So if you have a bloodstream along with that, or if you suspect that there could be systemic manifestation because of the bloodstream extension of the infection, then possibly combination has to be given. And there are few anecdotal reports showing that it works better than only IV.
We all use it, but if you look at the critical review of the literature, the clinical outcome has not been very good with adding nebulized antibiotic. That's what the recommendation, the present 2022 recommendation is with this. So I think I will end it here and open it up. Ajoy, if you want to open it up to the floor for any.
I'm sure there are few queries or few questions or clarifications, so you can raise your questions and we'll try to answer them if we can, because still many things are not known to us regarding antibiotics. It's been changing. It's a very dynamic science, and I don't know in near future what will come, but as of now, what we have said about those resistant bacteria, that is the standard of practice, should be the standard of practice. Any questions from audience?
I think especially ESBL, whether we should give piptase versus carba. In carba resistant organisms, what should be the
just
drug?
Few regarding Astronam, because in my unit, all organisms, crab, are including NDA, are resistant to Astronam. So I have stopped. I have used it quite, frequently, but recently I haven't.
The Astronam is anti-NDM, but we have to remember that any organism which have an NDM also have ESBL, and Astronam is killed by ESBL.
Because if I find that Astronam resistant, and of course the other agents, ceftazidime, avibactam sensitive, and NDM is showing positive. So in that situation, what you will do? It's a co-producer, all are co-producer.
I will doubt that report of Astronam resistant, because the kind of reporting they do in the lab is actually not very gold standard. They do the Vitex and all that.
Yeah, right.
So if you do the gold standard lab test, Astronam is still pretty sensitive to NDM. So it might be that the lab reporting might be little erroneous, because otherwise you have to go for colistin only, because there is no other option. And
That is,
colistin
I'm doing
outcome.
Colistin plus avibactam, ceftazidime. It's not a known combination. So many physicians were asking me, are you sure that you should use both? So that's my.
Yeah.
Sorry. Any questions? No. If there is no question, then probably we are much below the scheduled time. So thank you. Yes.
No, you have to use Astronam with ceftazidime. Yeah, I think, it's better than colistin. There have been no randomized controlled trial of ceftazidime, Astronam versus colistin, but there has been retrospective studies, and this is much better than colistin, much better. If you can use a beta-lactam, penicillin, beta-lactams are penicillins, basically. If you have an option of using beta-lactam, that is always a much, much, much better option. In fact, we didn't had any other choice at one time but colistin. That's why we have kind of got colistin, and we think that it is a good antibiotic. Colistin is a very bad antibiotic, very bad antibiotic. And we didn't had any other choice. That's why we are using colistin. But now with newer beta-lactams coming, if there is even if a minor possibility that this can work, it is better to use that.
Okay. Oh, right. That is probably this is the last question. We have to stop.
So in our hospital, there's one more organism which bothers us a lot, is resistant Burkholderia, in especially CRBSIs. And generally it is sensitive only to Septran and to carbapenems. So between the two choices, to preserve carbapenem, would you suggest using IV Septran over carbapenem, or should we go for carbapenem?
This is an example. Burkholderia, Elizabeth Kinglia, Moragnella. Nowadays, these organisms are coming so much common in intensive care units in India. The reason is colistin use. Colistin, these organisms are intrinsically resistant to colistin. So the more you use colistin, the more you get Burkholderias and all that. We use a lot of minocycline for this because, nowadays we do blood culture for the biofire, and the biofire panel doesn't have Burkholderia. So if you have a blood culture positive and biofire negative, the chances are very high. Within a day, it is Burkholderia. We have been using minocycline for Burkholderia routinely. In fact, that has become very important empirical antibiotic in our ICU. Yeah, minocycline is a very good, Burkholderia, there are two kinds. We are talking about Burkholderia cepacia, which is, there is one Burkholderia melidio, the other Burkholderia, which is which is community acquired. Burkholderia cepacia is minocycline sensitive, and we do use it a lot. But if it is carba sensitive, I presume you can use it. But our experience is more with minocycline, with Burkholderia.
The Burkholderia mylori that needs prolonged treatment, at least 6 months. And probably they are the minocycline, doxycycline, both are working.
Yeah. Thank you.
Thank you. Thank you, Suresh. So.
We have almost covered up the delay that started with initiation a little late. Now we are heading towards the next session. It is ILD case-based discussion. There are two presenters, and may I request Dr. Lakshmi Kanti Yange as a chairperson with a co-chair, Dr. Supriyo Sarkar. Both Dr. Yange and Sarkar has been already introduced to you. Dr. Yange happened to be respiratory consultant in the Dinonath Mangeshkar Hospital in Pune, and Dr. Sarkar is professor of pulmonary medicine in Sagar Datta Medical Institute.
Good morning. We'll start the session straight away. Who is going to be the first presenter? You can start, please. Puneet.
Hello. Good morning, everybody. Thank you, moderators. I would first like to ask the chairpersons how much time do I have, because I was initially told that I'm the only speaker and there are two speakers. How much time do I have?
30 minutes.
Okay.
30 minutes for.
Yeah, so I might discuss only one case because I had come with two, or I might just go fast. So I'll be discussing two real life cases which I dealt recently in my institute. And as we go along, we'll try to see the approach and the usual issues that we have in the diagnosis and management of ILD. So the first case is a 50-year-old female with no previously known illnesses. She presented initially in 2015 in an outside hospital with history of dry cough and dyspnea of 3 months duration. And on questioning, she did give history of muscle weakness and aches involving both upper and lower limbs. Apart from that, there were no constitutional symptoms, no cutaneous symptoms, no other symptoms to suggest a connective tissue disease, no definite history of exposure to organic and inorganic dust, no family history of connective tissue disease or ILD. On clinical examination, the general examination was normal. The respiratory system examination showed a few inspiratory squeaks, but no crackles. Musculoskeletal system, neurological system were normal, and there were no other significant findings. The X-ray also was fairly normal, did not show anything significant. The spirometry showed a restrictive pattern with an FVC of 62% predicted. An HRCT of 2015 was from an outside hospital. I'll just show the images quickly. From these are axial cuts from the apex to the base. So I would request the chairpersons, what do you think is?
Can you go back to the CT images? Yeah. And this was the CT done in 2015.
15.
The initial presentation. Okay, so what we have is predominant interstitial involvement, which is not following any central to peripheral gradient or apicobasal gradient. There is involvement of upper as well as lower lobes. There appears some subpleural involvement, but there is also peribronchoscopal involvement. So at this moment, we can say there is diffuse parenchymal disease, which is actually not following any significant pattern. If at all I had to put it into a specific pattern, possibly I would put it something like NSIP-OP overlap.
So that is what we thought too. So when we try to classify ILD patterns, we try to fit in these 4 patterns as it is suggested: UIP, probable UIP, indeterminate for UIP, and alternative diagnosis. So the differences in the confidence levels. When we have a typical UIP pattern, we have a confidence of more than 90% to say that it is a UIP. Probable UIP pattern is 70 to 89%, and as we go along, the confidence levels, they become lesser. So it basically depends upon 2 things: the distribution and the characteristics. So a typical UIP pattern will have an apicobasal gradient, and it will have subpleural predominance. Whereas a probable UIP pattern, though it will have apicobasal gradient, will still be there, but the other characteristics of typical UIP may not be there. In indeterminate for UIP, we may have a diffuse distribution without subpleural predominance. And some specific findings like perilymphatic distribution or perivascular, peribronchovascular distribution would suggest an alternative diagnosis. Similarly, in characteristics, if we find typical honeycombing, traction bronchiectasis, and intralobular and septal thickening with peripheral predominance, it's more likely to be a typical UIP pattern. Whereas in probable UIP pattern, we might find everything, but not the honeycombing. And if we find features like mosaic attenuation, cysts, or predominant GGOs, then possibly we have an alternative diagnosis. So in this patient, we found that there was subpleural predominance. There were intralobular and interlobular septal thickening. There was not much of GGO. So we thought that it is fibrotic ILD. There were no definite features to suggest an alternative diagnosis. There was no definite apicobasal gradient. So we classified it as indeterminate for UIP. And as the chairperson mentioned, our possibilities were fibrotic NSIP or an SIPOP overlap was the possibility. So with this, we come to what are the essential components of history taking in ILD. So once we have diagnosed ILD, we generally always have to go back to the patient. So once we have taken the history, gone to the examination, diagnosed an ILD, it is always a good idea to go back to history and try to look for the etiology. The basic idea is to find out what is the etiology of ILD. Is it idiopathic or is it because of a specific cause? So there are certain things which are specific to ILD we must always ask for, and I remember it with the acronym C, D, E, and F. C is for CTD features. We always have to take a detailed history of connective tissue diseases. And D is for drug history, to rule out any drugs that may have been implicated in causing the ILD. E is exposure, which is occupational exposure, indoor exposure, smoking exposure, organic and inorganic antigens. And finally, F is for family history, which is again very important because it significantly changes the epidemiology, the demographics, and even the prognosis. The second thing is, what are the essential components of examination in ILD? So again, we have to carefully look for CTD and we have to find features of pulmonary hypertension. One important area to look for is the hands of the patient. Hands give a lot of idea, not only about cyanosis, clubbing, but also hands can have very important findings about the CTD, like in dermatomyositis, like in systemic sclerosis. So puffy fingers, hyperemic fingers, extensor aspect nodules, all these can give indications about possibility of a CTD. And then clinically, when we examine in fibrosing ILDs, we are more likely to find fine respiratory crackles or Wilco crackles, whereas in airway-centered diseases like hypersensitivity pneumonitis or sarcoidosis, we may not find crackles, we may find more of inspiratory squeaks like we found in our patient. And sometimes in ILD with obstructive airways, we might also find V's. The minimum laboratory workup which is expected in ILD, again, especially when the diagnosis is not clearly IPF. So if a 70-year-old male comes, a smoker male comes with typical UIP features, we know that it is IPF, we may not evaluate further. But in all other cases, it will be important to do a basic workup to find out the underlying etiology. And that also, the investigation, the workup is driven by the clinical profile. So a young patient, a patient who does not have definite risk factors would probably require more extensive evaluation than an elderly smoker where we clearly know that the diagnosis is IPF. So diagnosis, the evaluation would be sequential and it will be dependent upon the patient's clinical profile and the demography. So in our patient, when we investigated, we found ANA was 3+ speckled pattern, row 60, row 52, and SSB lower positive. All other serological markers were negative. CPK was elevated at 408, and we would want to remember that in history, she did give history of some muscle weakness. So we went ahead and evaluated for inflammatory myopathy. The thigh MRI was normal, but EMG showed early myopathic changes. So we had clinical and some evidence of inflammatory myopathy. We also had some serology positive, though specific myositis panel was negative, but row 60, row 52 were positive, which may be associated with inflammatory myopathies. So at this point of time, what diagnostic label is suitable? What would the chairpersons like to label this patient as, who has an fibrotic NSIP pattern or an indeterminate for UIP pattern ILD with some serology positive and some subtle features of CTD like muscle weakness?
It is CTD ILD, but the primary diagnosis of the rheumatic condition.
So this is a typical patient where we feel that this patient possibly has CTD, but we cannot put the patient into a definite CTD label. The clinical presentation, we would not be able to give it a definite CTD label. but we feel that this patient possibly has some CTD. So now there are two terms which are used in this kind of a scenario. One is UCTD, undifferentiated connective tissue disease, and another is IPAF, interstitial pneumonia with autoimmune features. And IPAF is a relatively newer thing which was defined in 2015, and UCTD has been going on. Between the two things, UCTD is relatively not very clearly defined. UCTD simply means that when you get features of CTD, but you cannot give it a label, it is UCTD. IPAF there relatively has been very formally defined. It's basically a classification criteria. IPAF is not a disease. IPAF is just a classification criteria for clinical research, for enrolling patients in trials, and possibly for trying to understand this entity better. It's not a separate disease. So IPAF has recently been defined, which is organized around 3 domains: clinical domain, serological domain, and morphological domain. So any patient who has got ILD, when we have excluded or we do not have any alternative etiologies, does not comply with the criteria for a defined CTD, and has at least one feature from at least 2 of these domains, then we can define it as IPAF. So clinical domain, like I said, the hand is very important. Distal fissuring, distal tip ulceration, inflammatory arthritis, telangiectasia, Raynaud's phenomena, distal edema, and Gottron sign. Similarly, serological domain, any of these antibodies, if they're positive. Now, again, it's important that homogeneous pattern, we need a high titer, because homogeneous pattern is quite common. It can be increased in a fair amount of population also. So for homogeneous spectral pattern, the titer should be at least 1:320, whereas for other patterns of ANA, any titer is acceptable, or any of these antibodies which are myositis specific or any specific serological antibodies, if they're positive, then this domain is fulfilled. And the third is morphological domain, where if HRCT or histopathology shows a definite ILD. Now, again, the point to note here is that UIP is not a defining criteria for morphological domain. It's only the non-UIP forms of ILD, which it's not that IPAF cannot have UIP. IPAF can have UIP, but presence of UIP will not give it a positive score. So if we have to have, if there's a UIP which we want to make IPAF, then the patient will have to have a criteria satisfying from both serological as well as clinical domain. So in this patient, we possibly can call IPAF because there is morphological domain positive, because we have labeled it as fibrotic NSIP, and there is serological positivity. So we call this patient IPAF, and the patient was started on, the patient was started on treatment for CTD ILD with immunosuppressants. So patient was initially started on low dose prednisolone along with azathioprine. So there are certain features of HRCT which suggest CTD ILD more than a non-CTD ILD, specifically when we have a UIP pattern. So there are 3 patterns that I would like to discuss today. One is this anterior upper lobe sign. When you have predominant involvement anteriorly in the upper lobes, it's also called a 4-corner sign. So typically we find that in UIP, it is a posterior peripheral predominance. But when we find that in the lower aspects, in the basal aspects, there is posterior predominance, but in the upper lobe, there is anterior predominance. This is called an anterior upper lobe sign or a 4-corner sign, which suggests CTD ILD rather than IPF. Similarly, exuberant honeycombing, typically seen in rheumatoid arthritis. If the honeycombing is exuberant, which is typically defined that more than 50% of the involved lung has got honeycombing, then it is possibly a CTD ILD rather than an IPF. And the third is a straight edge sign. When we see a coronal film and we find that there is a definite defining edge between the involved lung and the honeycombed lung, then it is called a straight edge sign. And in a recent paper, it was found that the presence of exuberant honeycombing, anterior upper lobe sign, and a straight edge sign, they have got a strong sensitivity and specificity for to define CTD ILD versus a non-CTD UIP pattern.
So for straight edge sign, I would just like to highlight that radiation pneumonitis is one entity where you can get that straight edge. So history of radiation is something which we have.
So when we see a straight edge sign, radiation is very important, but generally in radiation, we'll have a unilateral straight edge, whereas in CTD ILD, we generally have a bilateral straight edge. So that is one differentiation. Rightly said, in radiation therapy, after radiation therapy, we get a definite edge between the involved lung and the uninvolved lung. So this patient was labeled as IPAF and started on low dose steroids and azathioprine. Symptoms remained static for a couple of years. After that, there was some slow progression. Extrapulmonary symptoms improved and never recurred. So in the follow-up from 2015 to 2020, there was no recurrence or no appearance of any extrapulmonary symptom, but her pulmonary symptoms showed some slow progression. So how should the ILD patients be followed up? So again, there are no definite protocols. It all depends upon the presentation of a patient. More aggressive disease, we would like to follow up more frequently. Less aggressive disease, there are patients who do not have any progression for years together. We might like to follow them up less frequently. So typically, the pulmonary function test may be repeated once every 3 to 6 months. HRCT may be repeated once every 12 to 18 months. Depends upon the profile. And as we go along, the frequency may also change depending on the aggressiveness of the disease. So this patient, when we followed the patient up, when we look at the spirometry, now these spirometries are from different centers, so there may be some difference, but we find that gradually one thing is very remarkable, that the FEV1 upon FVC, gradually from 2016 to 2022, the patient had converted to an obstructive pattern. Initially, the patient had a restrictive pattern, but now there was an obstructive pattern on the spirometry. Whereas 6-minute walk distance had not changed much, exercise desaturation had not changed much. This is not what we generally expect in a fibrotic ILD case. We do not expect that person to become obstructive. And if the patient is progressing, we expect the 6-minute walk distance and the percent desaturation also to progress. But here what is happening is that there is some deterioration and the pattern has gradually changed to obstructive. So which are the ILDs with obstructive physiology? So you must remember that the airway-centric ILDs would generally have obstructive pattern or may have obstructive pattern. So this includes sarcoidosis, hypersensitivity pneumonitis, most of the smoking-related ILDs, RA-related constrictive bronchiolitis, combined pulmonary fibrosis and emphysema. So these are the diseases where we may expect an obstructive pattern. So since now our patient started showing obstructive pattern, we started looking into these, that can our patient be having one of these. So let's look at the CT scan, how it progressed. So these are the CT scans from the following years. The left one is from 2020 and the right one is from 2022. So I'll again go along slowly. The first CT is a little blurred. The second CT is more clear. So we find that there is some increase in the peripheral opacities. The septal thickening has improved, definitely increased. But what is remarkable is that now this patient developed a mosaic attenuation. So you can appreciate here, especially in the lower lobes, and even the cut before this, the patient had developed some mosaic attenuation. Now we can see multiple densities. There is homogeneous hyperlucency and the normal lung, really called a triple density sign. So we can find 3 densities in the same cut: hyperlucency, increased intensity, and a normal lung. So this mosaic attenuation is something which came up new, and it coincided with the obstructive pattern on the spirometry. So now, what are the differentials of mosaic attenuation? So I think we heard today only in the first talk here when we were discussing tuberculosis that mosaic attenuation simply means different lung densities in one CT, which may be because of a small airway disease. It can be because of a vascular disease like pulmonary hypertension, or it can be because of a parenchymal disease because of patchy GGOs. So patchy ground glass opacities, small airway disease, and vascular disease all can cause mosaic attenuation. And thereby we need to differentiate between mosaic attenuation versus mosaic perfusion. So mosaic perfusion means what was mentioned earlier in one lecture also, that in the black areas are abnormal. That is, in the black areas, the vessel density becomes lesser. The vessels are smaller in the black areas. Whereas when you have patchy GGOs, this will not happen. The vascular density will remain normal in the black areas and in the white areas. So this is how we should differentiate. When we see a mosaic attenuation, we should start looking at the black areas and see whether the blood vessels are attenuated in the black areas. If the blood vessels are attenuated in the black areas, that means it's either a small airway disease or if it's a vascular disease. Whereas if the vessels are same in black and the white areas, then possibly there are just patchy GGOs and our differential would change accordingly. How to differentiate between vascular disease and small airway disease? Then we have to go for air trapping, to see air trapping. So we need inspiratory cuts and expiratory cuts. If the black areas remain hyperlucent even after expiration, then possibly there is air trapping. So this is how we differentiate. There are 3 examples. This is a small airway disease, the left one on the top. On the right one, we have a vascular disease where we can see dilated vessels and mosaic attenuation. And the third one is patchy GGOs, and we find that the vessel size is not attenuated in the black areas. And this is an example of air trapping. In an expiratory film, if the black areas remain black without any increase in density, then possibly it's a small airway disease. So now that we find that our patient has got mosaic attenuation, obstructive pattern, and features of airway-centric disease, Now, what do we think? Because CTD related ILDs are not supposed to show these kind of patterns. This kind of mosaic attenuation and airway centricity is fairly uncommon in CTD ILDs. So is it possible that our patient does have a CTD, but the ILD is not because of CTD, ILD is because of something else? Is it necessary that an ILD in a CTD patient is attributable to CTD? So again, plurality should not be posited without necessity is what Occam's theory says, but Hickham's dictum says that patient can have as many diseases as they damn well please. So it is not necessary that we have to put all the eggs in one basket. Different problems have different etiologies. So whenever we are suspecting a CTD ILD, it is important to confirm whether CTD is causing the ILD or the ILD can have a different etiology as well. So in our patients, since we started seeing now mosaic attenuation and obstructive airway, we again held an MDD and we felt, okay, what should we do? So should we go for a biopsy? So chairpersons, what would you do in this case? Would you do a transbronchial lung biopsy or would you do a cryo biopsy?
Probably biopsy, because in transbronchial lung biopsy, the material is small and it is crushed, so it is often difficult to.
Truly said, sir, but now we remember that in this case, we are demonstrating, we're talking about an airway-centered disease. We are talking about possibility of a hypersensitivity pneumonitis or some other airway-centered disease. So though cryo lung biopsy is the gold standard for biopsies in ILDs, but that applies more for the peripheral ILDs. When we're talking about an airway-centered disease, the current guidelines say that TBLB should be done before cryo biopsy because we may get a very good diagnosis in TBLB itself in airway-centered diseases, which include sarcoidosis and hypersensitivity pneumonitis. And what about BAL? So BAL, though it does not have a definite diagnostic role, but sometimes it is good because we can rule out a lot of other etiologies using BAL. So this is what the current recommendation says, that generally in HP and in sarcoidosis, we may have lymphocyte predominance, whereas in IPF, we may have a neutrophil predominance. We may have eosinophilic predominance in eosinophilic predominant diseases. So BAL does have a lot of corroborative value, though it may not give a very definitive diagnosis. It may help to rule out other possibilities. And this is the recent paper by Raghu et al., the recent guidelines on hypersensitivity pneumonitis, where they mentioned that if we are suspecting a airway-centered disease, TBLB before cryo TBLB or a surgical lung biopsy, because TBLB may give us a diagnosis in an airway-centered disease like this. So we went ahead with a TBLB. These are the three tissues, the 4 pieces of tissues of TBLB. And we found that there was airway centricity. There were inflammatory cells. I do not have a pointer here. So there was, we can see that there's airway here on the left side top, and the inflammatory cells are generally around the airways and around the vessels. So there is airway-centered fibrosis and airway-centered inflammation. And we also found certain areas of ill-formed epithelioid cells, ill-formed granulomas. So here we can see some ill-formed granulomas, some histiocytes. Again, some ill-formed granulomas. I'm sorry, I don't have a pointer with me. So the final diagnosis given by the pathologist was chronic hypersensitivity pneumonitis or fibrotic hypersensitivity pneumonitis. So we again held an MDD together, and the clinical picture of inspiratory squeaks, the histopathological picture, the spirometry picture, and CT picture all were consistent with hypersensitivity pneumonitis, but patient did not have any exposure history. So even after repeated questioning, so we send an HP panel, which is typically the antibodies against the common antigens, organic antigens, which can cause HP. And we found significant positivity for pigeon and some mild positivity for certain fungi. We again asked the patient to go back and check whether there's something in the home environment which might be causing this and which might be responsible for the deterioration. And to our surprise, the patient came back and checked that the AC ducts around the house are infested with pigeons, which was something that they had not checked earlier because they thought that there are no pigeons in the balcony, there are no pigeons around the house. But the AC ducts of the house were infested with pigeons, and the pigeon antigen was actually quite there in the environment. So antigen exposure history is something which is very important in all ILD cases. and possibly it should be done using a questionnaire. But then there are so many organic antigens present, and we possibly cannot get history for all. So usual suspects, like it will depend upon where you are practicing. Like I am in Delhi, and Delhi is famous for pigeon infestation. Pigeon infestation is quite common there. And another common thing is Aspergillus fumigatus. So Aspergillus fumigatus and pigeon both have quite common in northern belt, especially Delhi and areas around Delhi. And but still, in a lot of cases, we may not get any history of exposure. Even in best of the HP series, the exposure history is elicited only in about 40% cases. So the management remains the same with immunosuppression, with an added advice on identification and elimination of the inciting agent, because continued exposure would cause further harm. And now there is also possibly role of antifibrotic agents in ILD. So in the inbuilt trial, which established nintedanib for progressive pulmonary fibrosis, it was found that in HP cases also, it works when there is progressive pulmonary fibrosis. So this is what we had in our patient. The patient deteriorated, and then again we changed from azathioprine to MMF and started the patient on nintedanib because there were features of progressive pulmonary fibrosis because there was declining FVC over the next 1 year, and the patient is still under follow-up. The final diagnosis was hypersensitivity pneumonitis and undifferentiated connective tissue disease. So the takeaway points are that HP pattern in CTD ILD is a rare finding. If a patient of CTD presents with features of an airway-centered disease or HP, we should reevaluate. Management of ILD patients in CTD is different. Even the prognosis is different from those without CTD. The current international guidelines recommend taking detailed history and physical examination, especially for CTD and antigen exposures. Immunosuppressive and antifibrotic agents for symptomatic or fibrosing CTD ILD can be selected in patients who require treatment. Not all patients of CTD ILD would require treatment, but those who progress would need an aggressive treatment. So this was my first case, Chairperson. Do I have time for second case or?
Yes, you have been allotted extra 10 minutes for the second case. But before going to that, before going to that, any questions from the present case? Yes. Yes, Saurabh, please. Yes, sir.
Yeah, it was a nice presentation. Two things. Firstly, I mean, yes, transbronchial biopsy can be useful for airway-centric diseases. However, there has been some publications in the literature that particularly with advanced HP or with the others, some of the other diseases, it might be difficult to ascertain the granulomas, and therefore always a surgical lung biopsy or is advisable.
My two points on that is that definitely cryobiopsy or surgical lung biopsy would be better. But what I said was that TBLB before this. So we do TBLB, and most of the times TBLB may not give us an answer. So we ultimately will have to do a cryobiopsy or an open lung biopsy. But if TBLB gives us a conclusive answer, which fits in our clinical picture, supported by other tests, then we may be able to avoid a more invasive test. That might happen in a very small percentage of cases. But like in this case, we had everything was going in sync. So we could avoid cryo TBLB in this particular patient. But yes, in most other cases, we would need a cryobiopsy.
And the secondly is, I mean, there has been also some publications, I mean, by the Raghu that if you can classify sometimes the HP into definite, probable, and possible, just like the UIP or IPF. Yes. And it all depends on the clinical scenario, the positivity, then the radiology and the histopathology. I think we can come to whether you really need a lung biopsy for HP.
Very true. So if we have a definite exposure history and everything is in sync, then it is a definite HP, but otherwise we may have a probable or a possible HP. And it is very important to classify this, not to give a diagnosis, but to keep our minds open that in follow-up, we may need to change the diagnosis. So if we are dealing a case of possible HP, we should keep our minds open, and during follow-up, our diagnosis might sometimes change. So our level of evaluation, the aggressiveness of evaluation, and our minds open during follow-up, this level of confidence is important. And that's why these categories of definite, probable, or possible.
Some markers of collagen profile is positive. How much importance do you give to them?
Pardon me, sir?
Like in rheumatoid factor being positive, it can be non-specific.
Absolutely.
Like RO and all could be non-specific. But the question is, if you take these are non-specific and from the very beginning it's a case of HP, then see the initial CT scans. They don't show airway centricity. So is it how to explain that?
So that is what. So in this particular patient, initially there were certain features of CTD. So first thing was that she had features of muscle weakness and she had a raised creatine phosphokinase along with EMG positivity of myopathy. So that gave us an indication about possibly inflammatory myopathy. Her ANA was 3+ positive with significant antibody positivity of serological factors that are consistent with inflammatory myopathies. So keeping all this together, there was a fair suspicion with the gender of the patient and the presentation that this could be CTD. Whereas it is very much possible that all this was non-specific and the patient might have had HP right from the beginning and the airway centricity appeared a little later as the disease progressed. It's very much possible.
Yes, the same question. Whether are we dealing with the same disease or two diseases? Initially, it was the IPAP. And later, after exposure, that HP occurred. So if we do the biopsy in the initial goal, then will it be better to get a diagnosis?
Okay, sir. So in CTD ILD, biopsy is not recommended. Why? Because biopsy will not be able to tell us whether the background illness is CTD or not. The biopsy will only tell us about the pattern of ILD, but will not tell us nothing about the etiology in a CTD. So therefore, in CTD, a very aggressive biopsy is not indicated because the treatment is with immunosuppression, whatever you may get on the biopsy. That is why in CTD ILD it is not recommended. However, in this particular patient, it will be difficult to say whether the patient had two diseases, that is a UCTD and an HP, or was it HP right from the beginning and everything that we got favoring CTD was just non-specific, because these things never recurred. Extrapulmonary symptoms never recurred. It was only the ILD that the patient suffered along the course of 5 years.
But she has been on treatment. So the
Yes.
symptoms might not have
Possible.
recurred because she is on
Absolutely. It is
treatment,
possible.
and the low dose immunosuppression she was getting possibly was all responsible for keeping the undifferentiated CTD under control or in remission.
That is very much possible. Though inflammatory myopathies are generally a little more aggressive than this, but it's possible.
I think it will be nice to clarify about this IPF and CTD ILD. In CTD ILD, there is a definite establishment of a connective tissue disease by the sort of criterias, not only by the markers. Here, the markers are positive, but the disease is not established by the criterias as shown in the literature. Therefore, it won't be right to call those patients with IPAF as the CTD ILD or caused by the CTD. It's actually something with associated markers, and similar thing can happen in IPF as well. We can get elevated ANA but the disease is actually behaving like an IPF, not.
So very true. We recently had we had a group in Delhi and we wrote a white paper on IPAF. And what was decided was that whenever we are labeling the patient as IPAF, we have to evaluate aggressively. We have to, possibly rule out every other single cause, and IPAF diagnosis, or not a diagnosis, but IPAF label. It's not a diagnosis. So IPAF label is given only when we have exhausted all means to identify an etiology.
Sir, my question is, exposure is important for diagnosing HP. So we have three options: either by history taking, by questionnaire, and by profile, the antibody profile. Sir, which one is better? And the next one, are you using any? You said you are using a questionnaire. So what kind of questionnaires you are using for during history taking for HP?
Okay, so so what you said, that exposure history can be taken by history, questionnaire, and antibodies. So antibodies is not a definite evidence of exposure. Antibodies just corroborates. The sensitivity and specificity of antibodies is actually quite poor. So if you go to a farmers community and you randomly test 100 farmers for HP panel, a lot of them will show positivity for fungi, and a lot of them will show non-specific positivity for a lot of organic antigens because they are exposed to it. So anybody who's exposed to an organic antigen may develop IgG antibodies against that agent. That does not mean that it will definitely be responsible for the ILD. So it is just corroboration. HP panel just gives a corroborative evidence. It is not the gold standard. It definitely neither it confirms exposure, nor it rules it out. So for history, we have to have a well-built questionnaire, and the questionnaire has to be territory specific. So we are using a questionnaire in our institute that is adapted to our territory, because we get generally patients from Haryana, from Western UP, from Rajasthan, and from in and around Delhi. So we know that this is predominantly agricultural community. We know that the pigeon infestation is common. So based upon the kind of agents that we get, we have devised our questionnaire accordingly, which has to be validated and repeated and revised again and again depending on what we get. So the questionnaire is best made according to the clientele that you're getting, the kind of place where you're working. The questionnaire has to be adapted to that particular place. What are the common occupations that the people have there? What are the common vegetations? What is the fungal load in the environment in that particular area? That is very common. Unlike the West, in India, the fungal load is quite high, and Aspergillus specific IgG positivity is quite high in HP panels across the country. So the questionnaire has to be adapted to our own territory. Pardon me?
What questionnaire we're using is in literature, in any published in anywhere?
Yeah, so what we are doing is, so we are a part of a ICMR network of pulmonary fibrosis, which is a national registry of several institutes on ILD. So based on that, we have had our own meetings, and we have devised a questionnaire which all our institutes are following. So it is not published or validated yet. It is a work in progress. And once we feel that our questionnaire has become perfect and it is suiting our needs, then possibly we'll publish it.
Because I am using questionnaire.
You can talk it. So
Small interjections. So I know very little about CTD, ILD, and IPF. The question is, CTD, ILD can be bronchiolitis. So that will be bronchocentric.
Pardon me, sir?
There can be bronchiolitis in a CTD, ILD.
Yes, sir.
So
yes,
it can be a bronchocentric pathology.
Yes, sir. So bronchiolitis would generally be seen in conditions like Sjogren's syndrome and rheumatoid arthritis. So in these two conditions, we may get airway involvement, and we may also have interstitial lung disease. So in rheumatoid arthritis, typically what happens, we get an ILD which can be of a UIP and an NSIP pattern, and we also get RA bronchiolitis and RA airway involvement. But we do not get airway-centered fibrosis. We get airway involvement, which is an intrinsic airway involvement of bronchiolitis, and we get a fibrosis which is peripheral. We do not get peribronchial fibrosis, which we are finding in HP and sarcoidosis. So airway centricity is there in RA and Sjogren's syndrome, but that is an intrinsic airway involvement. There is bronchiolitis, there is pathology in the wall of the airways. Whereas here we are getting pathology outside the airways. It is airway centric. We have fibrosis and inflammation outside the airways, around the vessels. We've seen HP and sarcoidosis, which is not the same thing as bronchiolitis. So that subtle difference would be there.
now this nice case remind me of a case I have seen earlier, and I have written it in my book, 101 Cases of Respiratory Diseases. The case came, elderly lady came with a HSCT, and that the radiologist gave a diagnosis of IPF. And I saw that there was no honeycombing or there was no traction bronchiectasis. So I diagnosed the case as fibrosing ILD, fibrosing NSIP, because at that time I have an idea that NSIP is a dustbin diagnosis. But after reading, I found that NSIP has some specificities and it must involve the lower lobes. So the diagnosis I was at that time confused whether I should give steroid or whether steroid will be effective in fibrotic cases. Later one day, her granddaughter gave me a history that she usually went to terrace to feed the pigeons. So at that time, I looked back in the HSCT and found there are the air trapping and lung volume is not reduced. So the diagnosis has been changed to HP, and HP is a commonest, the ILD in our country. We should remember it. And later I found that the progressive fibrosing ILD, we can use antifibrotic drugs. With this comment, I invite you to present the next case.
Because I'll quickly go to the second case and just discuss the issues that we have not done. So the case 2 is a 30-year-old male with no previously known illnesses. So I worked in the armed forces. So this guy was actually a serving soldier who was posted in Dras at a height of 18,000 feet. So a person who is working at that altitude, we expect him to be in the best of health. So this soldier, he presented with 2 months history of symptoms of breathlessness, insidious in onset, gradually progressive. MMRC1 on walking uphill or elevated platforms. And he also gave history of some mild wheezing for past 1 month, occurring mostly at night. No history of features of any CCF, no cough, sputum hemoptysis, no history suggestive of any CTD. Exposure history, again, nothing significant, no significant drug history, no significant exposure history. And he was working with vehicles, with the army vehicles. So there was some exposure to emissions from engines and vehicles, but nothing more than that. And his father also had history of some lung disease, which was labeled as asthma, but not very clear. And otherwise, no other exposure to any organic or inorganic pollutants. So on physical examination, he had clubbing. And he had significant exercise desaturation. So on 6-minute walk test, he desaturated from 98% to 84%. On examination, he had bilateral fine and respiratory crackles. His P2 was loud and other systems were normal. On investigations, his CBC was normal. All the serological markers were negative. His CK was normal, and 2D echo showed mild TR with RVSP of around 28. Spirometry showed moderate restrictive pattern, and the 6-minute walk distance was 560 meters with a significant desaturation. So again, he's a trained soldier, so his exercise capacity was good, but at the cost of significant desaturation. So this was the X-ray, which showed diffuse reticular opacities with no definite zonal predilection and slightly reduced lung volumes. His serological workup, as I mentioned, was all negative. We did an extended myositis panel, which showed Me2B positive and PMSL75 borderline positive. Both of them were in low titers, so we did not attach too much of importance to this, especially because he did not have any clinical symptoms or biochemical features of muscle involvement. His HP panel showed, again, mild positivity to Penicillium chrysogenum, but that also, we took it with a pinch of salt because, like I mentioned before, that exposure can give rise to antibody positivity. They may not always be pathogenic. So this was the CT. Now let's have a close look at the CT. We're taking axial cuts from the apex to the bottom. Chairperson, sir, what do you think?
Did he have any history of smoking?
No, sir, he did not have history of smoking.
No smoking. Okay. So basically what we have is predominant nodular pattern with some developing cysts. Or it is just normal intervening parenchyma which is appearing like cysts.
I mean, can't see any definite honeycombing. There are lower lobe predominant. There is lower lobe predominance.
I'll show you the coronal cuts.
Is it?
Yes.
Want to look at the fissures more closely, whether it is a bit nodular or not. Few areas of traction. So I think that's it. I mean, no, I can't see any obvious
if we take things together,
air trapping or anything.
So we are seeing some reticular opacities, both interlobular as well as intralobular pattern. There is no definite axial or peripheral predominance. The disease is quite diffuse, and from axial, from central areas to peripheral areas, all the areas are equally involved. We are finding some traction bronchiectasis, as we can see here. Significant amount of traction bronchiectasis there. There is no definite honeycombing. And like what everybody has noticed, that there are some septal nodules. There are some nodules over the fissure. There are some nodules along the pleura. So there are some perilymphatic nodules present. And this patient did not have any lymph nodes. So no mediastinal lymphadenopathy, prefissural nodules, subpleural as well as along the fissure, and diffuse reticular opacities, intralobular septal thickening, along with traction bronchiectasis. So again, we did not have a very clear-cut answer. He was a 30-year-old male. And no, so we did a serum ACE, which was negative. He did not have any other features of sarcoidosis. So HRCT pattern was not very clear. So we thought of several things. So if we keep it in the four buckets of typical, probable, indeterminate, and alternative, possibly we can keep it in indeterminate UIP. Indeterminate for UIP because it has got intralobular septal thickening, it has got Russian bronchiectasis, and it has got no apicobasal gradient. However, presence of nodules, it takes it against UIP. But nodules were not many. There were just a few nodules. So possibly we can still keep it as indeterminate for UIP. However, many alternative diagnoses was thought of. One possibility was sarcoidosis because of perilymphatic nodules. And then low probability of HP, fibrotic NSIP, or mostly unclassifiable ILD. So we did not have a very clear-cut answer at this point of time. So we had an MDD, and at the end of the MDD, our diagnosis was unclassifiable ILD. Now, unclassifiable ILD has a significant overlap with sarcoidosis, IPF, and fibrotic HP. So many of the patients who are initially labeled as unclassifiable ILD, ultimately they are discovered to have either a fibrotic HP or IPF or sarcoidosis. So we evaluated for all these possibilities. So what should be the next step according to the chairpersons?
Yes, you will go with cryo or surgical TBLB now.
Yeah, so we thought so as well that we should go for a cryo TBLB or an SLB. So this is the famous cold eye study, which was published in 2020, which showed that the cryo TBLB is almost as good as surgical lung biopsy for most answers. And in most cases, it has lesser morbidity, lesser mortality, lesser complications, and gives us almost all the answers that a surgical biopsy can be done in a center with experience. So we did a cryo TBLB. This is the cryo course that we got. And with the arrow, we can see a relatively preserved lung parenchyma. And here we find some definite fibroblastic foci. So there were fibroblastic foci in the tissue. There were significant areas of fibrosis, which no definite pattern. And so extensive fibrosis and fibroblastic foci. So the pathologist gave a diagnosis of probable UIP on the cryobiopsy sample. The BAL showed 30% lymphocytes. So probable UIP. Now, what are the causes of UIP? The most important cause of UIP is definitely IPF. But then there are other causes. So among the other causes, so we took down all the list and tried to see how can we help this 30-year-old young serving soldier. So CTD related diseases can cause UIP patterns, specifically rheumatoid arthritis and systemic sclerosis, and even other CTDs can cause UIP. Then asbestos related ILD, chronic fibrotic HP, radiation fibrosis, some certain drugs, and ANCA-associated vasculitis, typically P-ANCA or anti-MPO, and Hermansky-Pudlak syndrome, they all are associated with UIP. But in this particular patient, none of these were actually there. So we had no features of HP, there was no drug history, there was no exposure to asbestos, and there were no features of Hermansky-Pudlak syndrome. So we still did not have an answer. So this is what the latest paper on IPF says, that when we have histological pattern and HRCT pattern. So in HRCT, we had kept it as indeterminate. In histopathology, we have a probable UIP. So then it says IPF likely, but is it possible? 30-year-old male non-smoker without a family history, can he have an IPF? Can he have a familial IPF? Because familial IPF can come in young people. And remember that this patient had a father who had some lung disease labeled as asthma. So we called his father. His father was somewhere down in south. We called him, we sent an air ticket, called him and evaluated him that does he have an IPF which has been mislabeled as asthma? But no, he actually had asthma. He had an obstructive disease on spirometry, CT scan was normal, and he actually had asthma. There was no ILD. So now, so when we look at this algorithm, the first thing is IPF suspected. When you have IPF suspected, then you go for all these things. So the first thing is IPF suspected, then you look for all this. In our patient, definitely IPF was not suspected. A 30-year-old male with 2 months history, no smoking history, why should he have IPF? So histopathological pattern had no answers, HRCT pattern had no answers, and the patient, even after a cryobiopsy, remained as unclassifiable. So chairperson, what would you do in such a case?
Actually, there is a presence of wheeze and the paraseptal.
So actually, the patient gave history of wheeze, but on examination, we did not find any wheeze. There was no obstruction on spirometry. I wonder whether the history that he gave, did he really understand what wheeze means? Because we never found any wheeze in the patient. We never found any obstruction in the patient. There was no response to bronchodilators.
Regarding the...
I mean, one of the BAL finding was a very sort of contradictory.
Yeah.
If it's a fibrotic ILD, particularly if you're thinking of IPF, then 30% lymphocytes, we expect neutrophils more. So I think we will be more inclined to look for that the lymphocytic bile fluid causes mainly
lymphocyte predominant BAL findings causing UIP. The first thing that comes to our mind is fibrotic sarcoidosis and fibrotic HP. But then we did not have features of both. We have done a cryobiopsy. We have got a good quality tissue. So, we were so confused because lot was at stake. We sent his biopsy reports and his CT to multiple centers of excellence, which included AIMS New Delhi and PGI Chandigarh. And they had their own MDDs and we had video conferencing and their answers were also unclassifiable at both the centers. So what should we do next?
Present, I would consider it to be a part of HP, which is progressing. Keep closely monitor if there is progression. And I'll also look for inflammatory markers. How are they? What is his ESR, CRP? If he has any other features of activity. Of course, avoid exposure and put him on
avoid exposure to what?
Whatever exposure we can say. You had one antigen positive for
so there was positivity for some penicillium.
Yes. So moist areas he has to, moist exposures all he has to avoid. And I think I'll put him on immunosuppression. At least mycophenolate, I'll put him and monitor closely.
The CT shows mainly fibrosis. There is no inflammation.
And can you just show the X-ray? Only X-ray.
Okay, yeah.
The CT shows mainly fibrosis, interlobular septal thickening, and there is no mosaic attenuation and no feature of inflammation. The BAL only the lymphocytic, and the histopathological it is the mainly fibrosis, no inflammation.
With fibroblastic foci, which is a very important finding. There was unequivocal fibroblastic foci.
With fibroblastic foci that can come in both HP and that can come in the
non-specific finding.
That can come in
unless we can show sort of different patterns at the same time in different areas, it cannot be diagnostic of UIP or IPF. So cryobiopsy at the best can show some fibroblastic foci, whatever available can suggest.
So if we see what we found in cryobiopsy was extensive fibrosis. We found fibroblastic foci in almost all the tissues that were sent, and there was absence of any alternative pathologies.
Yes.
So we did not find a granuloma. We did not find. So that is important that there was no alternative possibility on the biopsy.
Yes. The fibroblastic foci is also in common HP and the UIP, both IPF. So my take is we can give some immunosuppression trial. If patient improve,
70% is strongest point for
BAL lymphocytosis is the strongest point for giving immunosuppression. If patient cannot improve, then antifibrotic is the treatment.
That is true, sir. So that's what we did. So we could not give a definite label, but we felt that since BAL has 30% lymphocytes, he's a young person, to give him benefit of doubt, we started him on immunosuppression. So we started him on low dose immunosuppression, initially steroids, gradually tapered steroids and added MMF in full doses. However, even after 3-4 months, he continued to deteriorate. Spirometry worsened, his 6-minute walk distance worsened, and his symptoms came back. His sinuses worsened. On minimal exertion, he started developing sinuses. So there was definite worsening while on immunosuppression. So then comes the issue of progressive pulmonary fibrosis. Now, this is a term which was in evolution for many years, but now we have definite guidelines on progressive pulmonary fibrosis. Again, it is something in evolution, and we do not have definite answers. But what is currently said, it is among all the physiological markers, FVC is what we have to look for. And if the patient has worsening respiratory symptoms, if there is physiological evidence of disease progression in the form of absolute decline in FVC more than 5% or absolute decline in DLCO more than 10% predicted within 1 year of follow-up, or any evidence of radiological evidence of disease progression in terms of fibrosis, progressive fibrosis in radiology. So if any two are present, we can call it progressive pulmonary fibrosis. So though the most robust findings are for FVC, the most robust role is of FVC, but if any two are present, we can call it progressive pulmonary fibrosis, and they become candidates for antifibrotic therapy. So antifibrotic therapy, nintedanib and pirfenidone, have been established in IPF with the ASCEND and the capacity trials and the impulses trials. But for progressive pulmonary fibrosis, they have started with the Census trial, which was for systemic sclerosis, followed by INBUILD trial. And now they are approved, especially nintedanib is approved for progressive pulmonary fibrosis. Pirfenidone is still under research because the pirfenidone research is not unequivocally positive, but possibly both antifibrotics should work. So we will have three scenarios. One is a clear IPF where we would definitely give an antifibrotic therapy. We would have a progressive fibrosing non-IPF ILD, which will initially treat with immunomodulatory therapy and then may go on to antifibrotic therapy, or we may choose a combination of antifibrotic therapy and immunosuppressive therapy, like in this particular case. So this patient progressed on immunosuppressive therapy, but he was young, he deserved an aggressive treatment. So we started him on, so this is his progressive spirometry. We find that the spirometry is deteriorating, the 6-minute walk distance is deteriorating. So we started this patient on nintedanib also. And currently the patient is on immunosuppressive therapy as well as nintedanib. And the time will tell whether this works for him or not, or do we have to go for lung transplantation. So here is a young, fit, medically fit soldier who was fit for all duties till 6 months back. And now we're talking about lung transplantation, who has not responded to any treatment. We have done an extensive workup, including a cryobiopsy. We even thought it should we go for a surgical biopsy, but the pathologist said that we have sufficient tissue. Surgical biopsy is not going to change the answer because we have sufficient lung tissue. There's no point subjecting a sick patient to a surgical biopsy when we already have a sufficient lung tissue. So we continue to treat him as an unclassifiable ILD, and let's see how he progresses in future. So take your points. TBLC is now a well-indicated modality in clinical practice, almost as good as a surgical lung biopsy. Again, even after TBLC, a fair amount of patients may remain unclassifiable, and the current guidelines suggest that in progressive pulmonary fibrosis, we should start antifibrotics for better outcomes.
Thank you. Okay. Thank you. The lung has a limited way to response. It is usually by fibrosis. So in late stage, lung biopsy will not be helpful. That is the message. But primarily, the disease, I think it is sarcoidosis. Thank you, Dr. Puneet. Now I invite Dr. Suranjan Mukherjee. Okay. MD, MRCP, FRCP, and he's a renowned pulmonologist in our city. And with this introduction, I invite Dr. Suranjan Mukherjee. Please start.
For this case. I won't take a lot of time. It will be very short and crisp, but it's a very interesting case, not a very common case as well. So let's proceed with the case. Now, this happened about 3 years back. This is a 51-year-old lady on a background of hypertension, and she mentioned about some history of nephritis in childhood. She presented 3 years back with episodes of hemoptysis on and off, and that was happening about 2 weeks before admission. There were no other systemic symptoms, particularly joint symptoms, any rash, any cola-colored urine, weight loss, or any other systemic symptoms at all. No history of recent travel, paired substance abuse, or exposure. But she had a TB lymphadenopathy in 2003, for which she had ATD, but she couldn't remember how many months she took them. Physical examination was generally unremarkable, nothing except for some inspiratory crepitations on auscultation of the chest on the right side. Rest of the including the autoimmune features, all were negative. So the workup started, and we found, and that was the total count was slightly elevated. However, the CRP was only 3.3. Sodium, potassium, creatinine were all normal. ESR of 30, normal platelets. And this was the X-ray on presentation. Now, any comments about the X-ray, Chairperson? Any obvious? I mean, I know the X-rays are not very sort of well projected sometimes.
Yes, there appears some volume loss on the right
yes,
side with
yes.
predominant involvement of the right mid-zone and lower zone, which inhomogeneous opacities in this area. There's some inhomogeneous opacities in the left side as well. So some sort of pneumonia, not bacterial pneumonia, I would say. So some sort of parenchymal involvement, which is there right more than left with some volume loss. With that, I think I'll go. So I'm
Clearly, there is some volume loss and some alveolar opacities. Actually, it was mainly on the right side. So she had a CT scan done at HRCT. And any comments about that, the HRCT?
CT confirms almost the same finding. Again, we are not any much wiser except for the fact that we are definitely dealing with non-necrotizing kind of pneumonia, predominant interstitial involvement.
Yes, and the pattern is not sort of like a dense consolidation or anything. It's mainly sort of a reticulation with some ground glass and consolidation. How sorry? Yes, I will come to that. Yeah. So that's in. So next, so that was the sort of, and there was a lingular consolidation. Sorry, I forgot to mention on one side. And there is definitely a volume loss on the right side, as you can see in these CT films. And you can see that all the changes are almost 90%. I mean, there are probably a few changes on the left side. However, most of the changes are on the right side. So what's next? How should we proceed from here? I don't have the windows here. I mean, there were no lymph glands or anything in the mediastinum. Right. So we did a BAL. Now, there was a suspicion of an alveolar hemorrhage here, given that the CRP was normal, total count was mildly raised, and she had history of hemoptysis in this age group. Yes, and the macrophages, the hemosiderin-laden macrophages were very high, although I couldn't sort of elicit that 3 Alicard sign for bleeding. You know, I mean, when you take the BAL fluid one after the other, the third one becomes the more hemorrhagic in alveolar hemorrhage. We did an ANCA, MPO, and PR3, which were all negative. Anti-GBM was negative. And I did a transbronchial biopsy, which didn't show any evidence of vasculitis. It only showed non-specific inflammation. Urine examination was unremarkable. It was not reactive, no casts, no blood. Any thoughts?
Idiopathic pulmonary hemosiderosis.
Sorry?
Idiopathic pulmonary hemosiderosis.
Yes, that could be a possibility, but unilateral is not that very common. I mean, I have never sort of, it's mostly bilateral. I mean, what we are dealing with is a unilateral picture. Anyway, I will just move on. So at that point, we're thinking of ANCA negative small vessel vasculitis, which is called a primary sort of lung involvement, where you can get small vessel capillaritis without any systemic involvement. Malignancy, tuberculosis are sort of broad-faced differential, but really couldn't think of anything specific at that moment. However, so we gave some routine treatment, broad-spectrum antibiotics, and given that the patient probably had alveolar hemorrhage, I gave sort of high-dose methylpred and other supportive medications, and did an echo Doppler, which didn't show any evidence of pulmonary hypertension, and the ejection fraction was fine. She improved, her bleeding, hemoptysis subsided, and she was discharged with oral steroids. And on follow-up, she had no further hemoptysis, her cough settled, and you can see the blood counts were unremarkable. The total count might be an effect of the steroids. The CRP was normal. So she was on the follow-up. I expected that the opacities would improve, the hemoptysis, the blood would resolve if she didn't have any further hemoptysis. But the opacities are persisting. And this is the comparison between the two X-rays about 6 weeks back. I mean, I expected that they will be resolved. So she had an admission after that in January 19 with a clear signs and symptoms of a community-acquired pneumonia, high white cell count, very high CRP. And that was the X-ray when she got admitted. She was treated with intravenous meropenem, improved and got discharged. And then came for follow-up. At follow-up, she was having a sort of MMRC class 2 dyspnea. And if you look at the spirometry, she had a mild to moderate restrictive defect, non-specific ventilatory defect, but her gas transfer indices were very low. So there is some problem there. Next, and that was a repeat test which showed probably some improvement, but still they were quite low. And this is again the comparison between the X-rays that's from January 19, February 19, and September 19. The changes are persistent. At this point, even after about 9 months back, no diagnosis was made why she was having these problems. She was not that symptomatic, as I said, but yes, I mean, there was a definite problem. And this was a CT thorax done. Any comments?
So the alveolar component has gone down a little bit. Interstitial component still remains, and there is some architectural distortion.
There's one more
and
thing.
The left lingular collapse has improved now.
Yes.
The linear collapse consolidation, which
Yes.
was there, has improved completely now.
Sorry? They are probably the sort of, there's one more thing, I don't know whether it's projecting well or not. There's some ground glass and mosaic appearance on the left lungs.
Yes.
I think it shows better here. So that was a feature. Now we can see, as we say, there was some traction bronchiolactasis, few cystic changes, but no definite honeycombing. And I don't know whether it shows better. And these were all the films, all the sections, and you can see all the cuts. I can see again, it's predominantly right side, almost on the right side only. So she was discussed in the MDT. So the opinion was right-sided ILD, non-UIP pattern, probably unclassifiable, but she refused a surgical lung biopsy. And we don't have a cryo biopsy facility at our center, so we have to accept that diagnosis. So the discussion, the thoughts come, say, what are the causes of unilateral, predominantly unilateral ILD?
It's mainly infective. It is mainly infective, particularly viral.
I mean, infective, yes, but that will be temporarily, not sort of. I mean, you can get sometimes unilateral ILDs in systemic sclerosis, particularly when it's related to recurrent aspiration, which happens mostly on the right side. Ventilator-induced lung injury, chronic vascular occlusion, chronic local inflammatory diseases, say bronchiectasis or GERD. But the last one, that's very interesting. I can give you the diagnosis, UAPA. It's not very common. It's a very rare diagnosis. Because of the chronic vascular occlusion as being one of the differentials, we did a CT pulmonary angiogram. Any features? Any comments?
Do you have the sequential cuts?
Huh?
Do we have the sequential cuts? The cuts above and below, the complete data.
You can see there is the right pulmonary artery is stenosed. And there was a hypertrophy, which I won't be able to show here, right bronchial artery, right phrenic artery, and right intercostal artery is a part of the collaterals. So we did a 3D construction, and you can see the right pulmonary artery, don't have a pointer here, which showed the yellow one, is severely stenosed. So this is a predominantly right-sided ILD secondary to right main pulmonary artery stenosis. And it is a very rare disorder, about 350 cases reported in literature worldwide. Most of the sort of the stenosis is mostly on the right side. And you can see that it can cause ILD on the right side. Now, automatically the question comes in mind, how come the ILD develop? Now, there has been some postulations about why the ILD develops. However, the symptoms are very similar with our case. She didn't have any pulmonary hypertension, but she had exercise-induced dyspnea, recurrent pulmonary infections, hemoptysis. And if you look at the HRCT findings in the literature, they were all same. And even they mention the Mosaic Attenuation on the left side, on the contralateral side. So you can get pleural thickening, subpleural bands, mosaic, dilatation of the bronchial arteries, cystic bronchiectasis, honeycombing, septal thickening, and etc. And if you do a xenon wash-in images, you can see that there is a definite volume loss on that particular side. And this comes to, I will skip the pathogenesis. However, the postulated mechanisms are reduced blood supply, epithelial damage, disruption of the basement membrane, inflammatory cell infiltration, and therefore progressing to fibrosis. Treatment, of course, symptomatic. If there is significant hemoptysis, it needs embolization and surgical correction of any associated defects. Isolated pulmonary artery stenosis is rarer than pulmonary artery stenosis associated with other congenital cardiac defects. Thank you. Any questions?
Thank you. No question, please. Time is already. So thank you, Dr. Mukherjee, for delivering a very nice case. I have never heard of it before. Thank you very much. With this, we can close this session.
Thank you.
Sally, you can discuss it.
Thank you. It was a very interesting session. Now we'll pass on to the second next session. And this is my pleasant duty to chair this. As a customary to our Pulmocon, we always invite the awardee of the Acharya Prafulla Chandra Roy Memorial Award for this particular talk. This is Igniting Innovations in Young Mind. And as you know, Professor Shivaji Chakraborty happened to be the recipient this year. Dr. Chakraborty was introduced yesterday. He is an innovator, a teacher, an organizer, and is a leader also. So may I request Dr. Chakraborty to kindly deliver his talk. Workshop is likely to start in the right time in Hall B. So those who are interested may attend that. But it is not now.
So good afternoon and greetings from my side. I am the odd man out here, and I was listening to the previous two presentations, and then I was seriously thinking that why I am here and what I am going to talk. Anyway, I start my presentation with deep respect to Acharya Prafulla Chandra Roy, who is a doyen of industry, the indigenous industry in India. And secondly, I quote a Japanese proverb at the very beginning that says that if you understand everything, then you are misinformed. So therefore I thought that I don't understand what I was listening, but probably I can say a little bit what I am doing in a way that might be something which you may understand a little bit. I am not going to show anything detailed, technical, any equation, anything, but I have been invited to say a few words about igniting innovation in young minds. So that's what I will try to do. So first, I would like to see what is the impact of ignition. Trying to ignite innovation. So that's what I'm trying to do now. And what's the impact? So the impact is this. And that's very pertinent here, I think. Yeah. But anyway, that's what I'm supposed to do. Now, what I'm trying to say, I have divided into two parts, a little bit on the conceptual aspects and then straight away the practical aspects. Now, I will not talk about innovation as such as a whole. That's a very big topic. I will talk about what is called frugal innovation, because I come from an institute or university which is resource constrained. So when we work in such an atmosphere, how do we do some innovation? Now, what we do is that we respond to our limitations. This resource could be financial resource, this could be material, institutional resource. But what we try to do is that using a range of methods, we turn these constraints into our advantage. That's what we try to do. And that's what I try to say to our scholars too. And this is not only valid for engineering, this is valid for any subject where there are these constraints. And any successful frugal innovation, people at first think that they are only low cost. It's not only that, actually, it can even outperform the alternative. And very importantly, it can be made available at large scale. That's the important one. But then to do that, what we have to do? What I have found is that all innovative people, whoever I have met in my life, in whatever profession, I have seen that they have very good observation power. In fact, in real life, we all know that everything need not be explicitly told to us. It never happens in practical life. So many things that goes around us, we have to observe, learn, and act. That's what I always try to tell my students. And I firmly believe that innovation not only requires theoretical and experimental knowledge, which is required, but it also requires a knowledge gathered by logical observation of the natural as well as man-made processes which goes around us. And to sum it up, I would like to say that innovation does not fall from tree. Another aspect I have seen in my life is that most of the time, what we do is we hear with the help of our ears. Hardly we listen with the help of our brains. I can give you an example. Honestly, if we try to think, whenever there is a discussion, we start answering a question when the other person has not finished the question yet. I have seen in 75% cases. Or when we are, say, having some sort of argument, we start our own counter argument when the other person has not completed his or her statement. That's a typical sort of our behavior. Now, what does that mean? It means that we are not listening to the others. And I have seen personally that somebody who listens to others' opinion, then they are given value by the other and they share their ideas. And therefore, listening patiently to others always gives new ideas. That's what my experience is. Of course, you can differ from my view. I would like to say one important thing, that domain insight. Now, this domain insight may be in your medical, maybe in engineering, or maybe in chemistry. Domain insight is extremely important. I tell you a story, I find always this very inspirational. It happened in the Second World War. When it was at the initial stages of the Second World War, when the Allied forces, that means the British and others, they were sending their aircrafts to bomb the German areas. If they are sending 20 aircrafts, only 10 are coming back and 10 will be lost because of the German firing. So they started an analysis and they found that the aircrafts that are coming back, in certain areas, they were hit maximum by the bullets. So there was a meeting of generals and they thought that let us reinforce those areas where the bullets have hit. Very interestingly, second para, you can see a name, a mathematician, Abraham Wald, who was present in that discussion. And he said to the military generals, we can look at the problem in a different way. He said, look, 20 aircrafts went there, 10 came back, and these 10 were hit in these areas. Why the other 10 did not come back? Because they were hit in the other areas. And that's why they fell down. And these were hit in these areas, but they could still come back. So you should reinforce not in these areas, in the other areas. Those were the weaker parts. That solved the problem. This is called domain insight. And it can happen in any subject, not only in engineering or science. It is in any subject it can have. So I always believe that domain insight leads to innovation. Now that was the conceptual side. I don't want to go into any more details because I've already taken 10 minutes of my time. So I will go to something that we did in our lab. And this is completely different. It's a very high voltage lab. It's a big lab we have in our Jadavpur University. So I will try to tell one example because you were all discussing case studies here. So this one you can take as a case study in the engineering field. But as I discussed with Dr. Partha Bhattacharya, I said that I will try to tell you in a way that it could be more like how the doctors work. I mean, how we work is similar to how the doctors work. So let us see what is that. You were all talking about pulmonary diseases and others. Now I am going to talk about one equipment which is called transformer. I am pretty sure that you have heard the name. Maybe you are not aware what is it. But let me tell you that transformers are ubiquitous, which means that they are everywhere. The first, on the left side, you can see the very small transformers which are in the electronic gadgets. These are always there. Even in your mobile charger, there is a transformer. So they are everywhere. And then as you walk around your streets, locality, you can see the second one, that pole mounted, this sort of transformers you can see. What I am going to talk about are not this type of transformers, but the bottom one you can see, these are the real large power transformers. And you can see here the person standing there just to show the dimension of the equipment. You can see the dimension of the equipment compared to a human being. So you can understand that how big this equipment is. A little bit of understanding comes if I tell you about the cost factor, because see, engineers work primarily based on cost. I can design an equipment, but if it is not cost effective, nobody will buy it. As simple as that. Now, this is again something, we call it an electrical substation. I think if you drive along the highway or if you travel through railway lines, I think you have seen this sort of things. Now, these are typically the equipments there. You can see two transformers here, and there are a lot of other equipments. There is a thumb rule of our power engineers. We are the power engineers. We say that if you take the cost of all the equipments, add them, so the total cost is X. The thumb rule is that the cost of these two transformers will be more than X by 2. That means more than 50% of all the cost is only these two equipment. So you can understand how expensive they are. But then that is not enough. I will tell you specific cost. What is the cost? This is the unit cost in 2020 I collected. This is not a very big transformer. It is a 33 kilovolt transformer. It is rupees 13 lakh per unit in 2020. This is a relatively bigger one, 132 kV transformer. Just one unit cost 3.6 crores. This is an even bigger transformer, 220 kV. One unit cost 5.3 crores. In India, we have even higher voltage levels, 400 kilovolts. So you can estimate what will be the cost of per unit. So it will be, per unit cost will be around 8 crores. So you can, just to give you an idea that the equipment that we are dealing with, how expensive they are. And this is a very interesting photograph. I have got it from Siemens, Germany. See how it is being transported, a big transformer. Can you see? This is the one in the middle. This is the transformer, and just see how it is being transported, how big it is, that how it is transported. Now, these are the equipments we are talking about. And most importantly, we actually don't feel these are there because we take electricity as granted. We feel that electricity should be there, but how it is coming? How it is coming? That is because of all these equipments. Now the fundamental questions that comes to a technologist, and you can understand as a doctor also. See, if such a big transformer becomes faulty, what happens? A very big area is dark. You will not get any electricity. That is the first effect. Second, if this becomes faulty, can you go to the market and buy another one? It's not a laptop that you go to a mall and buy another one. These are all tailor-made. I place the order today, it will be delivered 10 months later. Second, and the third point is, since it is not available in the market, can I have one as a spare in my store? Can I keep 7 crores, 8 crores as a spare? No way. No company has that much of financial resources. So therefore, what's the solution? The solution is exactly what you do, that you have to keep it working. Now, that's the question, that how we'll do it. So in that case, I was listening to the previous talks and you were talking about the age of the patients that you were treating. Similarly, we also talk about the age of the equipment. Now, just to give some idea, I am giving two very demonstrative figures. These are taken from the top international journals. The left one is a figure which is from UK. The right one is from Dutch, that means the Holland. That means how many transformers were installed. You know, the growth of electrical power in every country has a history. It doesn't happen in 1 year. It happens over the years. So you can see that most of them were installed during the early part or later part of 60s, early part of 70s. It's true in India also. Most of these are installed in 1970s and 80s. Typically, one transformer has a life of 25 years. That is the declared life. So theoretically, all these transformers have crossed their age, their design life. So now the big question, since they have crossed their design life, should we replace them? But the question is, can you estimate the cost if I have to replace 100 transformers? If each one costs 8 crores or 5 crores, you require 500 crores. No power company will have that money. It's just not possible today. So then what's the solution? Now the solution is that we have to do testing. That's exactly what you are doing also. That means we try to understand that what is happening inside that equipment. Now for that, we have to know what is there inside, like you were showing through that lung details and others. What is there inside this equipment? Primarily 3 types of things. One you can see here, that this is the magnetic material, which is primarily steel, the gray color. These are typically the conductors, which is copper, covered with an insulation. This insulation is, as you can see, paper, polymer, oil. Now the question is, as it is aged, copper or steel, they hardly age. They are robust material. They are metals. So which one ages? That is this, the last one, the paper. And if that ages, then there will be a short circuit inside and it will be simply gone. So therefore, what causes damage to the paper insulation? Just exactly like the question which was raised in the previous talk. I am raising this question, and the answer just given straight away is moisture. This is a typical transformer winding just to show you what is inside that equipment. And since it is pretty big, it is almost 1.5 times man height, grown man height, the moisture is not same everywhere. So there is a distribution, it is shown here, that it is less on the top, more on the bottom. So damage will be more on the bottom side. So these are the things we have to know if we have to save these very expensive equipments. So therefore, what we do today, we do exactly what you do. We do non-invasive health diagnostic. And what do we mean by this non-invasive? Really, we don't think about like an extra sort of thing. What we think is like your, for example, ultrasonography, or for example, ECG. That means you put some electrodes on the surface and you get all the information what is happening inside. So what we do is exactly same. We put some electrodes on the outside, take the readings, and try to understand what is happening inside. That is the primary target. Well, these are the three techniques that we use. So I am not going to talk about the techniques because these are engineering techniques. Now, what were the challenges involved? Because remember, I was trying to talk about the frugal innovation in our lab. So what were the challenges involved? I have already shown these transformers are used outdoor in on-site. And the currents that we are measuring, they were of the order of nanoampere. Again, I repeat, it was of the order of nanoampere. Now, this is very difficult to understand how small it is. I can tell you it is extremely small. Now, when we are using in this outdoor place, there are so many other equipments operating. So there are a lot of noises. So how do I record such low value in such noisy environment? That was a big challenge. But then people told me, okay, there are a lot of techniques. You put a filter there. I said, yes, fine, I can put a filter there. Noises will be eliminated. But how do I know that my original current is also not eliminated? Because I don't know the current beforehand. Yes, fine. And there was a second problem. That question is there, that when I record this current, there is a waveform. Like ECG, you have a waveform. Now, if the ECG waveform is deformed, you get a bad diagnosis, which is hampering the diagnostics and the subsequent treatment. So when I put all those filters and others, how do I know that what I am recording is having the actual waveform? So these were the challenges, very serious challenges we were having, and we had to solve it. Well, we solved it. Of course, it took more than 2 years. It all, as I said here, it all started in 2007. And when we started this work, nobody helped us because that time some of the companies were selling this product. Each unit was costing about 40 to 50 lakhs. So we thought we'll develop ourselves. And we developed it. We developed the hardware, we developed the software, we developed all the data acquisition systems. And we can say that it was a very cost-effective solution to the very expensive equipments. Just to show the photographs of what our development was, on the left top, this was the version 1 of our equipment which we developed. As you can see, we were at one particular site, we were testing one particular transformer. Then we did a lot of work. This is the right side, is the present version, which we have developed a lot. These are all the software interfaces we have developed based on, of course, a lot of researchers. And based on this, a big power company came to us and we transferred this technology to this power company. And this is a real life transformer on site. This is, I am not telling the site, it is near to Delhi. Once again, just these people were standing in front to give you an idea that how big an equipment we are testing. Just you can see the idea, the size of the equipment and therefore the cost of the equipment. So all the tests that we are doing, that non-invasive in diagnostics, and if we give a bad diagnostic to this company, then this equipment will be seriously imperiled. So then what did we do? See, exactly we take the clue from the doctors. See, when we go for a blood test or something, the laboratories, when they give us the result, they never say the test result is good or bad. What they do, they give a result and then they say this is the range. So we took the same approach. We identified some parameters, important parameters on the left. We have also identified the ranges wherein the value should be in this range. And then finally blue color, the actual result, and then some remarks. But then we don't say good or bad because this very expensive equipment belongs to some company. So ultimately decision will be theirs that if they want, they can replace it. If they want, they can run it. So we hand over this report to the company. So that was our approach. So this is what we have done. So I was trying to tell yesterday also that whatever innovation we do, I have to remember that at the end of the day, it should work. It is not that I will give a hypothesis and it will be proved 20 years later. That doesn't work. That doesn't do. So what is important is preparation. Preparation, I always feel, is the key. So I have to prepare for my work at hand, whatever we are going to do. And if we do that properly, innovation is a logical conclusion. That's what I personally believe. So only one equation I'm going to show you. I am repeatedly trying to tell you that consistency pays in the long run. So it's the first equation. If you see, very simple equation, 1 to the power 365 is 1. That means if we don't do anything, at the end of the year, we remain where we are. But 1.01, that means I do 1% more every day, a very small amount. So that to the power 365, that becomes 37. So 1 becomes 37. So that's what I personally believe, that if I am consistent and do a very small amount every day, in the long run, it's a big thing. This is a book that was published on our work, whatever we have done. This is published by Springer Verlag. We have done very good publications, and let me tell you again, we have worked with a laboratory which is resource constrained, but still our publications are all in absolutely top journals of USA and UK. We have 2 patents granted, 1 software copyright granted, 1 technology transferred to industry. But as I always say in the end, that these are the people who have done the work. All 8 people completed PhD in these areas from 2007 onwards, 1 continuing. Well, I take the credit because I come here and give the talk to you. So you feel that I am doing the work, but I am only the person who is collaborating with these people. So I thank these people. Thank you very much.
It's been wonderful to listen to him. With all humility, he presented his work, and it's I've taken simile from doctor's work. So if there is any question from the hall, I would request the attendees to ask him. But it seems everyone is very much impressed. I've got nothing in their mind, but we have learned a lot from you. The most important thing is consistency, and that small bit of change of 0.01% daily is a huge change in course of time. That is the most important lesson that I have taken from his talk. Thank you.
So namaskar, thank you.
The next session is on COPD case presentation. I request Dr. Pawan Agarwal to chair this session, and the speaker is myself. I will not take much time. We are running 15 minutes late. I will just present one single small part of COPD. Pawan, may I start with your kind permission?
Yes, please.
Yes.
Go ahead.
So as you understand, COPD is a very, it's a big chapter. It's a heterogeneous disease, and there are several facets of COPD. I will just take up only one small facet of it, and I will discuss that how important this facet is, which is absolutely neglected in our day-to-day practice. May I have the projections? Dr. Agarwal, the chairperson, is like my younger brother, so I hugged him from behind. And I'm so grateful to him that he has come. I've snatched his job of introducing me. He has not taken anything. He hasn't. Let me go to the COPD case presentation. This is the first case, a 63-year-old male, retired government employee, symptomatic for 10 years. He has cough, shortness of breath, which is progressive, but a little variable. History of occasional exacerbation, less than 2 occasions a year for last 2-3 years, and history suggestive of allergic rhinitis. No significant seasonal variations. This is, so there is okay, I'll come to the summary later on. This is a 2-chair test. This test was innovated by us. This is a post-exercise recovery response testing. And we look at the recovery response in terms of saturation and the pulse rate. Here you can see that the patient has got a desaturation of 2%. We named it desat max, and the report is seemingly abnormal. It's not a normal. This was the X-ray, which is nothing much significant, very unlike a classical COPD chest X-ray with tubular heart and horizontal reaps. Reaps are of course horizontal, the heart is not tubular. This is a lung function test. I hope you can read it and you can look at the flow volume loop. The FEV1 is reduced, and the FEV1 is 1.26, which is 45% to 1.21. There's hardly any reversibility. So it's a classical COPD without reversibility. And you can see there is scooping of the expiratory limb with concavity upward, suggesting small airway obstruction. Now with this, the COPD diagnosis was fairly sure. But luckily we had a system of follow-up. So I looked at his old PFT. Here you can see the FEV1 by FVC ratio is again less than 0.07. And the FEV1, which is a marker of obstruction, is 1.36. But after bronchodilator, it has been up to 1.50. So there is a 140 ml reversibility way back in 2017. So this also doesn't rule out the diagnosis of COPD. So this patient is a case of COPD. Fine. But why am I presenting it? I had to go back to a little more previous history, and I could recollect a PFT where the FEV1 reversibility is 1.09 to 1.68. So you can see there's a huge reversibility of 590 ml, and this is 54% reversibility. If this reversibility is there, this patient cannot be a case of COPD. So something happened in 2017 for which the patient has lost its reversibility, and now he's presenting and posing as a COPD. Well, I looked at the total IgE being tested at that point of time. It was 1391 Ku per liter. The normal level was less than 114 Ku per liter. And at that point of time, we had a sensitivity test been done. There are multiple antigens to which the patient was sensitive to, like most importantly, like Aspergillus fumigatus. So in 2017, February, the diagnosis was asthma with Aspergillus hypersensitivity. And in 2017, late 2017, it was COPD. In 2022, is classical COPD. Then I looked for a FeNO at this point of time. 31 ppb, normal is slightly higher. Up to 25 is a normal, so this patient has got a higher FeNO. What does it mean? It means that the patient has got a positive Th2 high phenotype. It is an obstructive airway disease. It was as asthma. Now it is presenting as COPD, and this patient is predominantly Th2 high phenotype. There is allergic sensitization. He is non-smoker. The impression is non-smoker COPD, asthma converted COPD. I'm presenting this case because of reasons. Let me come to another patient. You can see the 68-year-old male. Sorry. I'm sorry, the I cannot see the video to be played here. Anyway, this gentleman's video is very telltale of this whole story. He is suffering badly for last few years. Now he's not been able to move out. He requires significant assistance for dressing and undressing, even for eating. And he's so sad that he started weeping in between the interview. And he, as I looked at, has got an emphysematous chest. There was intercostal suction. You can see the accessory muscles were prominent. It was a very sick, very advanced COPD patient. The video would have been wonderful anyway. It's not playing out here. The summary is that he's an ex-smoker for 12 years, but he smoked for more than 30 years. He has got seasonal cough and expectorations, seasonal cough with cough and history of nasal congestions for over 10 years. He had progressive and presently having severe shortness of breath, occasional seasonal changes. On examination, it is emphysematous. CT scan shows pan-acinar emphysema plus bronchiectasis. I'll show it. And FeNO was 29 ppb. See, with this stage of diagnosis of emphysema, that was quite apparent. The FeNO of 29 ppb is a little high. And if you look at the TLC, it is 7,200 with eosinophil being 6%, means there's more than 400 eosinophils. Well, let me have a look at his X-ray and COPD. Don't look at the other things. The chest X-ray is classical of emphysema. See the big lung from top to bottom, the diaphragm being flattened out, the lips are horizontal, the heart shadow is tubular. There is hyperlucency predominantly in the mid and lower zone. And this is classical of an emphysema. I look at the CT scan, it's all black. In between, you can see certain ring shadows, which are nothing but bronchiectatic changes. Bronchial wall thickening is obvious. Some little bit of fibrosis is there on the right side. So there is a bronchiectasis in emphysematous patients. And if you look at the PFT above, see the FEV1, the ratio is so low, 0.21. And the FEV1 is 0.35 to 0.38, is hardly 19%. So in summary, the patient is a case of severe airflow limitation without reversibility. Clinico-radiologically, it's emphysema subtype. And pathophysiologically, it is a Th2 high subtype with superadded smoking-induced damage, possibly enhanced by infection and bronchiectasis. So this is another COPD, which has absolutely emphysematous subtype, and there is superadded bronchiectasis. But this patient, I didn't think that he would come out as a Th2 high subtype. So it was a shock to me. Basically, the history was important. I didn't give much importance to the history of cough, that nasal congestion, that seasonal variation, which are classical of asthma. This patient has got an asthmatic genotype, if I can express it that way, and he has got a COPD phenotype. The phenotype is now obvious for emphysematous type, and this patient is basically Th2 high group. And what is the beauty of these two patients? If they are Th2 high, they are supposedly be responsive to steroid. If you see a patient of emphysema, you are not tend to prescribe inhaled corticosteroid. And with no reversibility, you certainly withhold yourself unless the patient is too sick, or the patient is having recurrent exacerbation, or the patient is going to hospital. So this patient does not qualify otherwise for steroid. However, if you find Th2 high phenotype, this patient will qualify steroid. So we are possibly missing a lot of patients who are asthma converted to COPD, and we are not giving steroid to these patients. This is my take from these two patients. Well, let me go to the third case. Before that, let me just have a small discussion about the definition of COPD, and it will elaborate how little we know. This is from the GOLD guideline. Please mind it, it is meant for the primary care physicians. This is not meant for the experts. I'm not an expert. I belong to primary care physician, although I see a lot of referral patients. Chronic obstructive pulmonary disease is a common preventable and treatable disease. It doesn't mean anything to me right now. That is characterized by persistent respiratory symptoms. These two patients had persistent respiratory symptoms and airflow limitations. They had obvious airflow limitations. That is due to airway and alveolar abnormalities, usually caused by significant exposure to noxious particles and gases. The second patient had history of smoking. The first didn't have that, and influenced by host factors, including abnormal lung development. Significant comorbidities may have an impact on morbidity and mortality. We have got a poster on this Th2 high phenotype today. You can have a look at this poster in the leisure hour. So So see, it's a significant exposure to noxious particles and gases. That's the most important thing. Here, the first patient didn't have any significant exposure to noxious particles and gases, at least known exposure. And the second patient was, of course, a smoker. With this, let me pass on to the third case. This patient presented to me in February 2022. I looked at his file, and this is my previous prescription. This is my prescription in February 2022. He presented only recently. He had history of shortness of breath for 8 years, and he was given empirical antitubercular treatment in 2013, 2014. And now the reason of visit was increased shortness of breath. See the examination, 50 kilograms, blood pressure is normal. The 2-chair test showing a 1% desaturation, and the pulse rate hike from 93 to 124. The prescription is shown. This is X-ray. This is very obvious bilateral upper lobe scarring is there. The hilar pulled up. The lower lobe showing some areas of hyperlucency. So a diaphragmatic surface showing some concavity with hyperlucent areas, as if there are some emphysematous bullae, some scar perihilar areas, and the lung doesn't look that clean as it was in the previous patients. So there is a fibrosis in the upper part, bilateral. There is hyperinflations, maybe airspace dilatation in the lower part. And so it's a case possibly of mixed upper lobe fibrosis with some emphysematous changes in the lower lobes. This was the lung function test. The ratio was 0.35 and 0.37 before and after bronchodilatations. And the FEV1 by FVC ratio, FEV1 was barely 0.84, which is, it was 0.84, 73% to 0.97. So with 34% change from 8.4 to 0.97, this is not a significant reversibility. So he also qualifies a diagnosis of COPD. Now we do another test called glycopyrronium reactivity. This is not, today I'm not projecting that because that will invite a lot of questions. But as we do salbutamol reversibility, we try with another bronchodilator of a different class. And sometimes we find patients are well responsive to the anti-muscarinic agents, and we can preemptively choose a treatment for these patients. So here you can see from 0.6 or 0.81 to 0.97, it went up to 1 liter. So there was a 30 ml reversibility, 300. This was a CT scan, the upper cuts. So what are the, see what is the feel? If this CT scan is given to anybody, to me, if I do not know the history, my impression will be that on the left side, I can see some clumped alveolar shadows, especially on the right upper mid zone. And there are areas of ground glassing, some areas are slightly hyperlucent. In the areas of ground glassing, there is a bit of reticulations. I can see, and this could be a case of DPLD as well. My first impression was that when I looked at this COPD, it looks more like DPLD, not like COPD. It is not a fibrocavitary disease that can follow a case of treated tuberculosis. So that is not classical of a treated tuberculosis. It's more like a DPLD. Going a little down, just below the hilar, if what you can see the same kind of findings. The pulmonary vessels are dilated. You don't see accompanying bronchi being dilated. So there are other areas showing bronchial dilatation. There is a bronchiectasis, but there are a lot of ground glass opacities, some bit of mosaic appearance, and some reticulation. This also can go with a diagnosis of DPLD. The same in much lower cuts, but there are multiple panacina emphysema. So this patient has got a mixed DPLD and emphysema. So what is the diagnosis? Radiologically, it is a mix of DPLD and emphysema, and clinically and spirometrically, it's a case of COPD. So I'm not going into discussion, maybe 1 or 2 questions may be asked to me. What is the etiology? So if it is a COPD following a tuberculosis, this patient didn't have a history of smoking and no history of exposure to noxious gases or maybe pollutions and others, no obvious history. So is it TOPD? This is tuberculosis associated obstructive pulmonary disease. TB has been known to be a cause of COPD, and people have decided to lovingly call it TOPD sometimes. Is it a mixed disease, TOPD and TILD? Nobody has heard of this called TILD. tubercular ILD. So this is also a question. So let me come to the causes of COPD with that. You can see this is from Gold 2022. Tobacco smoke, fine. Only one case of mine fits to it. Indoor air pollutions, occupational exposure, outdoor air pollutions, genetic factors, age and sex, lung growth and development. We had a paper yesterday where we have taken 4,000 plus patients' history of childhood events, and we found that there is an association of COPD with childhood tuberculosis and childhood pneumonia, socioeconomic status, asthma, and airway hyperreactivity. See, this has been placed so low. In fact, if you go to our today's presentation, you'll find roughly 30% of our patients of COPD is having Th2 high subtype. So it is not that infrequent to be placed so low in the list of gold given list of etiologies of COPD. Chronic bronchitis and lastly, infections. A history of severe childhood respiratory infections can be associated with reduced lung function and increased respiratory symptoms in adulthood. So this takes me to the etiology of COPD. In our soil, it's absolutely different from the perception being given by gold because they do it on evidence-based. We don't produce evidence. Evidence been produced by us, by Dr. Salvi for non-smoking COPD. I'm sure we had a meeting with Alvar Augusti. He said that we'll seriously think of including non-smoker COPD in the next gold meeting for detailed discussion. And if I take this to tobacco smoke to be followed by non-smoking COPD, maybe from biomass fuel-induced COPD, and to my mind, it should be followed by asthma converted to COPD. Then rest of the causes will come to our subject. Let me come to the diagnosis. The presence of post-bronchodilator FEV1 by FVC less than 0.7 confirms the presence of persistent airflow limitation, and thus a COPD in patients with appropriate symptoms and significant exposure to noxious stimuli. That's all. I mean, this is a substance from the diagnosis. But where is the role of asthma? So what we read in our guidelines is not enough. We have to keep our eyes open and we have to find what we are looking for and what we are actually seeing. We have to try to explain them. And this is what I thought I would present to all of you. I went back to the history of this patient. This is the last prescription on December 2013, where the patient had fever for 6 months and cough with shortness of breath. There was no history of exposure, but he was suspected silicosis in a medical college, and he was given some drug, maybe ATD or maybe steroid, I do not know. I couldn't find out that record, but there's a summary been written by me, history of transbronchial biopsy. His suggestive of transbronchial spread of the pulmonary tuberculosis was noted. His hemoglobin was 13 gram%. Sugar was normal, sputum AFB was negative, bulb fluid AFB culture was no growth, Mantoux test was very strongly positive, 28 into 30 millimeter. Bulb fluid, there was predominantly neutrophilic, HIV serology was negative, and he had ill-defined nodular densities. This was the CT scan at that point of time. I'm showing you zoomed pictures, and here you can see how it looks. And to me, it looks like a tree appearance. Not a tree in bud. We are very accustomed to the word tree in bud, but this is tree appearance. And I have seen such appearance been seen in transbronchial spread of tuberculosis. So it may be a case of transbronchial spread of tuberculosis. So with this appearance, with the background Mantoux positivity, with a shadow not explained, patient refusing further investigations, I had nothing with me but to take a consent from the patient, and it's written in Bengali যে সমস্ত জানিবার পর অনুমান ভিত্তিক চিকিৎসা করার জন্য ডাক্তার বাবুকে অনুরোধ জানাচ্ছি. After learning everything based on suspicion, I am allowing the doctor to start my treatment with anti-tubercular drug. So I started rifampicin, ethambutol, and pyrazinamide and INH, and the patient responded. Let me come back to the recent past. This is his, I'm not going to discuss this. So this was also a diffuse parenchymal lung disease to start with, and this is also diffuse parenchymal disease to start with. The type of the disease has changed. Presently, it may be appearing as a ILD. So is it TILD? I looked at the literature. Interstitial lung disease misdiagnosed as tuberculosis. Well, it can happen, agreed. Risk factor for interstitial lung diseases, a 9-year nationwide population-based study. And the conclusion says smoking, hepatitis, history of tuberculosis, history of pneumonia, chronic obstructive pulmonary disease, male sex, etc., etc. They are risk factors for interstitial lung disease. And if you see the univariate, multivariate analysis, you see the hazard ratio is 3 and hazard ratio is 1.5. So there is a higher hazard ratio for the patients having history of tuberculosis to develop interstitial lung disease. I do not know whether I'm really dealing with a case of TILD. It just opened my eye. We must look for ILD also. So TB can do anything but pregnancy, including COPD. Thank you very much.
Thank you very much. Do we have any time for questions?
1 or 2 questions.
So if any questions from the audience, please. There were 3 interesting cases. And we always have this dilemma about, in obstructive airways disease, whether we are dealing with asthma, we are dealing with COPD, whether there are elements of both. And in real life, I feel, in a large number of cases, you have elements of both, So you could have asthma to start with, and then you smoke, or you get exposed to any kind of noxious stimuli and you can develop COPD. But what was interesting is what one of those cases which initially had a lot of reversibility. And the question was then, was that patient treated appropriately for asthma or not? And if the patient is not treated appropriately, we see in a large number of patients, they come later and they develop a fixed airflow obstruction. So all asthmatics may not have reversibility. You have the asthma phenotype, but the lung function becomes like a so-called COPD patient.
The patient was seen in 2017. He came back on 2022. In between, he didn't come for follow-up. So I do not know what happened in between, but definitely he's converted from asthma to COPD.
Yeah. So that may be one of the reasons that his asthma was not really treated, and he's now got a fixed airflow obstruction.
What is my take from these stories is that even in COPD also, we have to look for the treatable traits.
Absolutely.
And the treatable trait is Th2 high phenotype subtype. So we must look for Th2 high subtype in all OADs. Despite it may be asthma, it may be COPD. And if they have got a Th2 high subtype, these patients should be given inhaled corticosteroids. These patients may be given oral corticosteroids with due indications.
Absolutely. Yeah, and even the GOLD guidelines, they allude to that to some extent. So they say if a patient is not responding, you see the eosinophil count. And if the eosinophil count is more than 100 also, you could consider inhaled corticosteroids. Any question or comment, please? Thank you for a very, very interesting talk, Parthuda. Thank you very much.
For the next session on lung cancer, we would like to call upon stage Dr. Madhuchanda Kaur to chair the session. Ma'am, please to come and honor us. Dr. Madhuchanda Kaur is a clinical director of Department of Oncology, Peerless Hospital, Kolkata. She is a principal investigator of ICMR hospital-based cancer registry. She was a former chairperson of BOG Aizer Mohali. She is an existing member of Executive Council, Central University, Gaya. She was a past member of UGC Expert Committee, past national president, Indian Association of Clinical Medicine, and past president of IMA, Academy of Medical Specialties. She is also a member of editorial board in many of the peer-reviewed medical journals. We are waiting for her to arrive.
All one, please. She's coming. Meanwhile, I'm just doing hard duties. My pleasant duty is to introduce the speaker today. He is Dr. Pawan Kumar Singh. And Dr. Pawan Kumar Singh is a DM Pulmonology. He passed out DM Pulmonology from PGIME at Chandigarh. Presently, he is in Rohtak as a consultant in the Department of Critical Care and Pulmonary Medicine. Where is Pawan? Yes, thank you, Pawan. Dr. Kaur is coming.
Thank you so much, sir, for the kind introduction. I would like to thank the organizer for giving me an opportunity to talk at Pulmocon 22. Very good afternoon, ma'am. So before diving deep into my talk, I do understand this is a mainly pulmonology conference, and most of us have been practicing only the diagnosis part of lung cancer, and our other practices involve mainly benign pulmonology. And as we all know, lung cancer has been known to be associated with a significant form of stigma and nihilism. Most of the patients that come to us are either at very late stages, they have an advanced disease, metastatic disease, they are beyond resectable. Most of the patients are even beyond operability, even if they are at an early stage of disease. And our common perception is that take him home, Seva, and all those things. And lung cancer has long been one of the most deadliest diseases possible. But recently there have been significant advantages, and as doctors and as researchers, we need to stay updated with our practice, especially with lung cancer. And lung cancer has seen some dramatic changes in past couple of decades. So I'll start with my case. My case is she's Mrs. VK, a 72-year-old lady hailing from Bengaluru, Karnataka. She's a homemaker. She has been never a smoker. She might have worked at Chulas and she would have some biomass exposure, but overall she's a never smoker. She's a known patient of type 2 diabetes mellitus, and she has presented with 2 months history of progressive dyspnea and chest pain on right side. Her dyspnea is insidious in onset and has been gradually progressive from MMRC 1 to MMRC 4 over past 1.5 months. It increases on lying left lateral, and it is not associated with any orthopnea, PND, cough, or wheeze, and there's no seasonal or diurnal variations. The chest pain is mainly dull aching, which increases on cough and on deep inspiration, and it is also insidious on onset and mainly on the static kind of severity. So she came to us. Our clinic, and most of the patients, like other patients, she has underwent some basic investigations and she has underwent some evaluation by a local physician who took a chest X-ray and found some fluid on the right side. She underwent pleural fluid tapping twice, 500 ml each time. She did get some relief after getting pleural fluid removed from her chest cavities, but it was occasionally found to be rapidly accumulating, and she required frequent taps. She was started on anti-tubercle therapy based on clinical and radiological grounds, and after initiation of ATT, she had increase in dyspnea with frequent vomitings. Some additional data, her past and family history are not particularly contributory, and she is having significant loss of appetite and loss of weight, and her sleep has been disturbed for past 15 days. On clinical examination, she was having tachycardia, tachypnea, and she was febrile. She was cachexic, pale, and with icterus that was present, and apart from that, there was no clubbing. On respiratory examination, there was decreased movements on the right side and decreased air entry on the right side. Rest other systems are normal. So with these findings, the provisional diagnosis of our patient is more or less clear. The aspect of morphology and the anatomy is particularly clear because she's having effusion, and that too on the right side. So right side pleural effusion, it is beyond any doubt. What are the etiologies that can be responsible for such kind of effusions? The most important etiology will be malignant because it is a session of lung cancer, obviously. But apart from that, the common etiologies will be TB, malignancy, and obviously heart failure, because we still don't know whether there was some effusion on the left side or not. What else? She has one more complication that was given to her after starting of ATT, and that complication was giving of ATT therapy, and she has developed drug-induced hepatitis. So what is the next plan of action? There are several things that we can take up from all this data and move forward. And we have several choices of doing, like we can get a repeat chest X-ray, pleural fluid tap, we can stop ATT, we can modify ATT, and even get a CT chest. So it is not very, it depends on the clinical practice and what kind of hospital you are sitting in, what kind of facilities that you are offering to the patient. So everybody might have different opinions behind it. So one can try to modify ATT, one can go for a repeat pleural tap, and even a person who is more aggressive like me can get a computed tomography of thorax as well. So what we did was, she was having some baseline investigation with us. which was showing anemia, presence of increased lymphocytes. She was having significant amount of hepatitis with OTPT almost reaching up to the levels of 1000. Her bilirubin was 3.5 and her albumin was low. Because of the frequent vomiting, she was slightly dehydrated within form of increased urea. She was incidentally found to be HBs antigen positive as well. And X-ray was showing a significant diffusion on the right side. Right side is almost completely white out. And we got a chest CT done at this particular juncture. Now in this particular CT scan, you can see that there is likely a hilar mass. There is a hilar mass present, which might be encasing the pulmonary artery. We don't have all the cuts. There is significant diffusion, and rest of the lung window, the mediastinal window are normal. There is a precarinal lymph node. There is a subcarinal lymph node. So a doubtful mass, an effusion, and some lymph nodes from this step. So what is the next step? What would you like to do? So how many of us would like to do a repeat pleural tap, or how many of us would like to do an EBUS first? Can you raise your hand? Anybody for a pleural tap for this patient? Yes. So one of the most least invasive investigations in this particular patient was pleural tap. That's what we did. And the minimum investigations that we should do for pleural fluid for any particular patients are basically doing a TCDC, total counts, protein and sugar, ADA, malignant cytology. What about AFB and CBNet? So pleural fluid AFB is an overkill. It is expecting too much from pleural fluid to give us back. Even sputum AFB is now likely to be getting removed from the armamentarium of tuberculosis diagnosis. So pleural fluid AFB is commonly done, very rarely found to be positive and largely unhelpful in making a diagnosis. CBNet is not recommended otherwise, but it is a practice of individual practice what will determine whether a CBNet should be done or not. We did not get a CBNet done in this particular patient. So only 4 basic investigations.
Doctor, can I just interfere?
Sure.
Here? So with that type of hilar mass, still you would like to do all this AFB, CBNet, ATA?
No,
do you get this type of hilar mass in the diagnosis which was made before?
So TB can present with the hilar mass and lymph nodes, ma'am. So even though we did not do it, but these are the investigations just we kept for discussion. So we went ahead with 4 main investigations, that is ADA, cytology, protein sugars, and differentials. Our reports show that she was having an exudative kind of effusion, low ADA, and malignant cytology came out to be positive. And so our final diagnosis was malignant right side pleural effusion. Primary diagnosis, we still don't know where this effusion is coming from. And in addition to this, she was having ATT-induced hepatitis. So we stopped ATT because we did not have any particular evidence supporting the diagnosis. So ATT was definitely stopped. What should be the next step? Now, this is where most of the physicians or chest physicians or us will be differing. What should be the next step? So should we refer this patient to medical oncologist right now? Should we repeat a pleural tap or do a medical thoracoscopy? This is a very delicate situation. There will be some people who will be encouraged to refer this patient to a specialist who will be treating him better. And some people who will understand that still our diagnosis is not clear. We have just established that there is cancer. There can be n number of ways. Patient can have a mass in lung, can have lymph nodes in lung, can have effusion in lungs, and the primary can be sitting anywhere in the body. So our job is still not complete, and we still need to do a couple of more tests so as to establish our diagnosis, or more importantly, to refine our diagnosis where the patient is harboring any malignancy from. So as far as my personal opinion is considered, there's a long way to go for this particular patient to be referred to a medical oncologist, because we need a lot of tissue before sending this patient to a specialist so that we can establish where the malignancy is coming from. So right now in modern...
I will interfere here. So can you go back to make the discussion lively? You want to do a medical thoracoscopy in a patient whose pleural fluid is positive for malignancy. So what is the stage of, if it is a primary lung, what is the stage of the disease?
This is stage 4.
So in a stage 4 disease, our treatment will be not guided by medical thoracoscopy.
I will.
If we get something more from the fluid
Yes,
only, that will
yes,
help.
yes, we
So
will
I
get from-
differ from that yes, which you have written.
Yes.
Yes,
So
please proceed.
the purpose of each investigation will be different. Some of the investigations will be helping us to a therapeutic point of view as well. Medical thoracoscopy is one of those things in which we can actually do a pleurodosis to a patient who is having recurrent pleural effusions, especially in our case. That's what it. So in modern oncology, tissue holds all the power. The diagnosis is not just adenocarcinoma or not just lung adenocarcinoma. Diagnosis is precision diagnosis, which includes the molecular morphology of that particular patient. So our localization, that is in this particular case, which is who is a female with presenting with malignant pleural effusion, the main four origins can be breast, cervix, ovaries, or lung cancer. In males, you can add prostate to this list as well. But these are the main roughly cancers which can present with malignant pleural effusions. In this setting, I would like to get an IHC to differentiate which of these cancers is presenting with these findings in our particular patient, because IHC is much cheaper. The turnaround time is very quick for this particular investigation. So IHC needs to be preceded before doing a PET scan, or if even choosing to do a PET scan in a stage 4 case. So what we did was we did a medical thoracoscopy, and we did a pleurodosis, talc pleurodosis in the same sitting, so that this patient can be relieved of her symptoms of recurrent pleural effusion. And we found that it was a TTF1 positive adenocarcinoma. So our radiological diagnosis, which was suggesting that it can be a lung malignancy, is confirmed on IHC. After this, which genetic alteration should be tested on this particular sample? So testing for genetic alterations in today's scenario is so important that it can change the management of that patient extensively. And it can be as drastic as that patient will be eating only tablets instead of going through chemotherapy if our diagnosis is right. So the bare minimum investigations that should be done in this particular patient are EGFR, ALK, and ROS. Now, ALK and ROS are rearrangements and not mutations, whereas EGFR is a mutation. So hence we call genetic alterations and not genetic mutations. So these are the basic investigations. In fact, it is commonly said that it is a crime not to get EGFR and ALK done in a patient of lung cancer and adenocarcinoma histology, irrespective of the smoking status, irrespective of the age or gender.
Okay, can we just stay here? So you have done the IHC from the thoracoscopy, then you took a tissue pleural biopsy and you did it.
Yes.
But if you have a very efficient and a high volume center where you have the facility of doing IHC from the cell block without doing any invasive procedure, you can do it from the cell block. And all these markers which you are telling, EGFR, ALK, ROS, we can do from the cell block as well. So what is our practice as oncologists, that we do not prefer doing a medical thoracoscopy, rather we'll do it from the fluid which acts as a tissue if you have a cell block. Number two, we use pleurocath or something to do the pleurodosis. So usually we are non-invasive, less aggressive than the pulmonologist.
So what ma'am means is that when you take pleural fluid, you take a large volume amount of pleural fluid, you centrifuge it, and the cells get deposited in the end. That the pellet of cells can be utilized as a histopathological sample instead of a cytological sample. That can serve with the purpose of doing an IHC or doing genetic mutations or genetic alterations or RT-PCR. Anything can be done on that particular cell block. So it is now becoming a replacement of a biopsy sample. And in addition to this, fluid sample can be removed using a catheter, and the pleurodosis can also be done through catheter. The both approaches are just fine, and it depends on the individual practice whether you are with the practice with which you are comfortable with. Significant. There is a significant.
Always, if you can get a tissue,
yes,
then the yield is much more. But medical thoracoscopy in a suspected stage 4, you have a hilar mass and you have pleural fluid which is positive for adenocarcinoma. So suspected stage 4, we are not at all aggressive. We would wait for a good cell block if your pathologist is competent enough. And we can do all the markers that he has mentioned here, which should be done in the workup. Yes.
Yes. So
Yes, you can, of course, but you have got adenocarcinoma in a simple cytology. The chance of a failure in cell block is very less in this patient. Of course, there are patients where there can be failure. Yes, please.
If the cell block has the adequate cell, then it can replace the biopsy.
Yes.
Biopsy is not this. The other problem in the cell block is the cell are very old. That is the sedated cell and so sometimes.
So you have to do with fresh specimens. Don't keep it.
Sometimes they do not represent the mutation or other.
So in dead cells, mutation can be falsely negative.
So that's what I said, that you get the cell block early morning, send it to your pathologist, tell him that we have sent a cell block, and they will do it as early as possible so that the cells are not degenerated, as you said. Correct. Correct. But see, you have a stage 4 lung cancer, you are subjecting them to thoracoscopy. This is not the practice by the oncologists. We will be more aggressive in getting a good pathologist who will do the cell block properly, and the cells should not be degenerated. But yes, sometimes there can be failure where we have to do something to get a tissue. Tissue is the issue, we know.
You will be surprised to know the benefits of doing thoracoscopy at an early stage and relieving patient completely of our dyspnea by doing a pleurodesis in one single setting.
Okay, I will not go to the controversy of Pleurocath versus thoracoscopy. Let us proceed.
So we did a medical thoracoscopy and pleural biopsy just to save time instead of wasting time for a cell block to come out to be negative after a week and then after scheduling a biopsy again. So we did a biopsy, we found it to be TTF1 positive adenocarcinoma and did all these investigations.
So your turnaround time for a biopsy tissue is
around 5 to 7 days.
So you will have in cell block also the same time.
Yes. So if cell block is negative.
So this is not the issue. I think it's the competence which is the issue. Turnaround time is quite same.
What I'm saying is cell block, if comes out to be negative, then we'll have to do a medical thoracoscopy instead of waiting for 2 weeks.
That is okay. That is okay. But you have got cytology positive, which is sometimes so difficult. You have got a cytology of adenocarcinoma.
If once cytology is positive, there's no guarantee that repeat cytology will be positive.
This is, I don't think, common.
Okay.
This is quite common that you will get a cell block.
Okay. So let's move ahead. So basic investigations, basic genetic alterations that must be done in any patients of lung cancer adenocarcinoma are EGFR, ALK, and ROS. So sometimes you have to push even harder. There's a big spectrum of testing of mutations or genetic alterations, which include HER2/neu and BRAF other mutations, in sometimes you have to push harder to get these tests included in the diagnostic armamentarium as well. So when are those times when you have to try so hard? First of all, in patients, especially who are females, who are never smokers, who are young patients, have an adenocarcinoma histology, are Asians or South Indians, especially South Indians or Asians. With Asians, I mean patients who are living in either China or Hong Kong in that particular areas, where the probability of getting genetic alterations is much higher. And similarly, in Indian patients, the probability of getting a mutation positive is much higher in the southern part of India as compared to northern part of India. So our patient was hailing from Karnataka. She was a female. She was a never smoker and was having adenocarcinoma. So 4 out of the 5 main criteria was fitting on this particular patient. So we did try to get an NGS on the histopathological sample that we had. So why do we need to be so aggressive? Now, NGS is a big investigation. The turnaround time is more for this investigation. The cost is higher for this particular patient. So how do I convince my patients and how do I tell them that you need it and you might benefit it from doing it at an early stage? So this is a case report, a couple of cases that we published a couple of years back in which we tried to unearth EGFR mutations, and the reward was the survival of more than 10 years in patients who were having metastatic non-small cell lung cancer. And this was achieved only after finding out EGFR mutations were repeated samplings and finally doing an NGS at the time of disease progression. So in this particular patient, she was started on afatinib at an initial stage, later on added crizotinib because of the MET alteration. Even after disease progression, she was started on chemotherapy, and finally she underwent NGS on blood sample or the liquid biopsy and was found to be positive for EGFR or T790 mutation and was started on osimertinib. So it is definitely worth it to investigate or over investigation, especially lung cancer adenocarcinoma cases.
Can we have a discussion here? Very important point. Number one, you showed EGFR ALK. So we all know samples are very limited. These are biopsy, even if you do, these are small biopsies. So what he tried to highlight is if we do stage by stage, say IHC for one, then PCR for one, these will take time and you might lose important samples. I mean, they can become deficient in sample. So the trend has become the next gene sequencing at the very beginning. If you do all the mutations and all the gene rearrangement, you can pick up. That is what your message.
Yes.
So if we can do NGS, but yes, cost is an issue. Turnaround is becoming low, fewer days as more and more samples are coming. So I don't think that is a problem now. But yes, cost is a problem. And in-house NGS, most of the institutions are outsourcing the NGS. So that is the problem. But yes, the message is very clear. And you will also pick up PDL1 if you want, because immunotherapy is becoming a very important part of treatment. Yes.
So what we actually mean is one aspect is the sequential testing. You test for EGFR, it comes out to be negative. You test for ALK, it comes out to be negative. You test for ROS1 in the order of frequency with which the probability is it is probability of one of them is to be positive. So instead of going stepwise, you can straight away apply for NGS with all those investigations, and they can tell you straight away what the answer is. So in this particular study, these two approaches were compared to each other, and they found that actionable alterations which were tested sequentially was almost as costly as an upfront NGS. In addition to this, the final NGS took a time of 1 month, whereas NGS, if done at an early stage, took only around 10 to 15 days. So upfront NGS, if affordable, should be done instead of going for a stepwise method. In addition, it is not all about cost. One of the most important issue is the tissue. After each testing, the amount of tissue left is getting decreased in amount, and the exhausted tissue will eventually fail you into testing any further. So to save time, and to save cost, we straight away went for NGS in this particular patient. So upfront NGS was done, and we found that she was harboring a mutation of BRAF V600. Now BRAF is one of the actionable mutations. Actionable mutations means that there is a therapy available for this particular mutation, and the patient might benefit after getting this particular drug. The drug which I'm talking, BRAF is not generally recommended to be straight away tested. In fact, the guidelines by ISLC pathology team, they have said that BRAF mutations should be tested only in clinical trial settings, including MET. So BRAF, even though we did, but it is still not recommended to be done in clinical setting. It is only supposed to be done in a research setting. So what we did was we tried to find out dabrafenib and trametinib. This combination is the treatment that is targeting BRAF, and that was not available in India at that particular time. So we applied for compassionate access program to Novartis, and meanwhile patient was started on carboplatin, pemetrexed, and bevacizumab. There was partial response with this particular patient. The size of effusion had decreased, and size of mass had also decreased. Meanwhile, we were able to successfully achieve and get dabrafenib and trametinib from Germany on a compassionate basis access program. And after starting dabrafenib and trametinib for 9 months, there was a remarkable reduction in number of lymph nodes and sizes of this patient. But as the future holds for us, the disease is treated with PubMed, but not the patient. What happened was Novartis received an FDA approval of starting these two medications, and once the FDA approval was there, these two medications were launched in India with a combined cost of each of these medications around 1 lakh rupees a bottle, and the total monthly cost was 3,60,000 rupees. This was cost of 1 month, and this patient was supposed to take this medication for the rest of her life. So the cost of therapy was more than the cost of life, and the compassionate access program was stopped because the drug has been launched in India, and she was restarted on chemotherapy after this. So after total 6 cycles and multiple adverse events of neutropenias and everything, she did achieve a partial remission, and she is currently on maintenance pemetrexed and bevacizumab and with sustained PR. My take-home points from this particular presentation, for especially for our group of physicians, is never assume a diagnosis. Always try to prove a diagnosis either with histology or with at least molecular mutations, or at least approved tests like ADA in case of TB associated pleural effusion. So it is very important to prove a diagnosis instead of starting treatment only on assumption basis. Your intentions might be right, but patient might still get harmed because of the treatment you're offering. Lung cancer is even more common in non-smokers and females. Diagnosis is multiple stages. One is provisional diagnosis, image-based diagnosis, histopathological diagnosis, and finally a molecular diagnosis. Treat the person, not the illness. You have to manage the issues around the diagnosis and the treatment aspects and optimize referrals. This is my team where I work. Thank you so much for your time and attention, please.
Okay, Dr. Jasper, 2-3 issues in this. One is a take-home message, which you said, and I also tried to tell that cell block is the way out as days go by. Number one. Number two, on progression, there is a chance that you acquire a new genetic abnormality. So we re-biopsy on progression. That is also a standard of care. And then you can use NGS in the progression as you used it. And number three, liquid biopsy is becoming very important because we think lung cancer is heterogeneous. So you have biopsied from one side, but the genetics of the other part can be different. Whereas if you take a sample from the blood, the liquid biopsy, the heterogeneity can be covered, and you can pick up some odd mutations in that sample, particularly the EGFR, which he was talking about. EGFR is not plain. EGFR has got several nuances with it. You have exon 19, exon 21, drugs for them are different. So things have become very heterogeneous for lung cancer. It's not one line answer. Not adenocarcinoma is alone sufficient to allow you to treat the patient. So yes, workup has been very stringent and also delayed. So I find a lot of physicians saying, why don't you start the treatment? Why is it getting delayed? You have got all the answers. You can do a PET scan, etc., etc. But that is not true anymore. As his case discussion pointed out, you want to know the very basic of the genetics in that patient, because if, like he showed, you have a driver mutation like EGFR, like you had BRAF, BRAF. So these are driver mutations. If you use a perfect target for that driver mutation, the patient can survive very long. So the attitude towards lung cancer has changed. It's not one size fits all. And we all have to customize our treatment for that particular patient with that particular genetic makeup. Once the disease progresses, even a EGFR mutation can develop odd resistant clones. And then we do that liquid biopsy or re-biopsy from the tissue. This is the message I wanted to give all my pulmonologist friends, because sometimes I get calls that you are unnecessarily delaying the treatment of this patient. Yes, for that meantime, in such a patient, we can do fluorodesis for symptomatic relief, but full workup is very much needed. Like he so well showed his patient who had several types of genetic testing done and several markers positive. First EGFR. EGFR was positive.
No,
we used afatinib.
We tested for EGFR, it came out to be negative.
Then
Only
afatinib was used just like that.
That was different case.
Oh, that was
I was showing the maximum survival for a stage 4 case is 16 years.
Yes.
It has been
So the BRAF was compassionate ground in this patient.
BRAF was done on NGS and was
dabrafenib was compassionate ground.
on compassionate grounds.
So yes, and maintenance therapy, number one. Number two is maintenance. Even pemetrexed maintenance we can continue. We have seen the progression of the disease is delayed. And so even after completion of 4 to 6 cycles of chemotherapy, we have patients where we maintain every 3 to 4 weeks on some form of chemotherapy if they do not have this type of mutation. So friends, lung cancer is a changed disease.
Thank you so much.
Thank you for the wonderful presentation. Thanks a lot.
Sir.
two doubts regarding sample collection. One is that you talked about cell block. So if we are sending an expensive test like NGS and we have the option of cell block, a non-invasive test, or a biopsy, an invasive test, before sending for NGS sample, would we send cell block, fail, and then do a biopsy, or would we want to send biopsy upfront because there is a possibility that a cell block may not have enough material, we may get a negative NGS report. Second doubt is you mentioned that tissue liquid biopsy is the way forward because lung is heterogeneous and we may have findings on liquid biopsy which are biopsy tissue may not give. So in case if we get discordant results on our solid biopsy and liquid biopsy, how do we proceed further?
Okay, regarding liquid biopsy, not very standardized for the other mutations, but EGFR, yes, it is standardized. So suppose in the liquid biopsy, you do not get a satisfactory result of new mutation, where we do liquid biopsy, where you are using the EGFR, but your results are not satisfactory. So you are suspecting resistance. So there, when we do, you are correct, there can be discordant result. We may not get the mutation we are looking for. Then you have to take a tissue. You can't do anything about it. Yes, this can happen. And the challenge of cell block is always there. But see a stage 4 lung cancer where we want to be least invasive.
We're talking of a stage 4 lung cancer where the chances of a targetable mutation are not low. She's a female, non-smoker,
yes.
Asian. Yeah. So in this case,
that is why my cell block will also have a good yield, I'm sure. So it's useless, I think, arguing on this. I am telling you what we do in cancer hospitals.
Yes.
We don't go for thoracoscopic biopsy. We go for cell block in patients where your cytology is
so
positive.
a practical question.
You may not get patients whose cytology
Yes,
is
ma'am.
positive.
A practical question: if we cell block, most of us are outsourcing
And everybody
NGS.
comes with a PET scan. Sorry, he said that PET scan, we have to wait. Everybody comes with a PET scan. I mean, suggested by the general practitioners. I don't have to suggest it.
A practical question: if we are sending for NGS, most of us outsource this facility.
Yes.
If on the cell block the material extracted is not enough, do we pay twice or do we pay once if we are sending
No,
a
no,
biopsy
they will
again?
call you.
They'll
We have
call
time
and
to
not
call
charge
us.
for the first.
Yes.
We pay
But we
once.
can't come to a conclusion.
Yeah. So
Yes, they
we
call
would.
us.
We get behind them and we pay once.
See,
only.
I tell you, there are pharmaceutical houses who are doing not the entire panel of NGS, but 12 gene they are doing, which are workable. See, all the mutations don't have a targetable driver mutation. So the ones I really want to know, the 12 gene panel is also quite good. And it is only costing 7,000 because of the companies supporting. So practical thing is this. Okay, thank you.
Thank you so much. Thank you so much.
Thank you, sir. Thank you, madam, for the extensive section. Now we break for lunch, and post lunch, we will have the final round for our National Pulmo Quiz. Thank you.
Zain Fateh, Shrumanjit Chakraborty.
Medical College.
Medical College.
Okay, so I think we'll just start the initial bit. Good afternoon, everyone. And first of all, congratulations to all of you for reaching the final round of the quiz. It wasn't easy. Elimination round, all of you who participated did a good job. It wasn't an easy round at all to get here. And it's a very good job that you've got here. And best of luck to all 6 of you. So team 1 is from AIMS Patna. We are waiting for Amit to come. Team 2 is from Medical College. Please introduce yourselves.
Dr. Zain Fateh.
Dr. Shrumanjit Chakraborty. Team 3 is from Medical College, Kolkata.
IPGMR. Ma'am, we are from IPGMR.
Team 2. Oh, no, team
Team
3.
three.
Sorry. Team 3 is from IPGMR.
Krishanu Mukhoti.
Sritama Bandyopadhyay.
Great. Team 4 is from RG Corps.
Dr. Anirban Bhattacharya. Dr. Shubhajit Khamaru.
Very good. Team 5 is from Calcutta National Medical College.
Dr. Akhtar Jamal বিশ্বাস. Dr. Rahul Pal.
Team 6 is from AIMS Bhubaneswar.
Myself, Dr. Rohit.
Doctor?
Rohit.
Rohit. Okay.
Dr. Devapam Chatterjee.
Okay. Great. So well done, all of you so far. So just the basics that we'll start with, that there are 6 rounds. All of you are 6 of each. So each round will have 6 questions. So we start with, say, the first starts with round 1, starts with team 1. So round 2 will start with team 2. Round 3 will start with team 3. For each direct question to the team that the question is asked is +4 and a -1. There will only be one pass, which is going to be buzzer. Okay, so whoever buzzes first gets to answer, but the catch is that you get +2 and -2 for a wrong answer. +2 for a correct answer and -2 for a wrong answer. Okay, so there are 6 rounds in total. None of these are buzzer rounds. The reason we haven't kept a buzzer round is there is always this question, I did first. So it is 6 rounds. So each of you will get 1 question first, depending on which team you are in. All right. Any questions so far? No. So at the end of the day, if there is any question and if there is any problems, then whatever the quiz master decides or the quiz masters decide is going to be final. In case there is a tie, we are not going to give a tiebreaker. We are going to give at the end, if there is a tie, both will be joint winners. Okay, so we will not do a tiebreaker because that is unfair. So we will not do tiebreaker. Both of you will be joint winners. So best of luck to all of you. So is team 1 here yet? No? 2 minutes. Let my other quiz masters come. Huh? I think shall we start with team 2? They can be last. Huh? Ashleigh, we'll just leave 1 question. So we can start with team 2. Why keep them waiting?
Shiva madam.
I'll do the till she comes.
Shiva madam,
Start for it.
Everybody check your budget. Ma'am, बोलो दीजिए मेरे को. Rules बोलो दीजिए.
So rules clear so far. Okay.
So
Let's start.
welcome everybody. We'll start this final round of Pulmocon quiz. We have 6 rounds. We are beginning with the round 1. So the first question, direct question, goes to team 2. University of California, San Diego level. applied for classification of a surgical specimen. Which surgery does it refer to? Your time has started. Meaty one has not come. So time up. Now the question goes for a team 6.
Thymoma.
It's a wrong answer, and there is only one chance for pass. So we'll go to the answer. This is pulmonary end arteriectomy, or you can call it pulmonary thromboembolectomy. There are 4 levels, and according to the segments, as you go distal, the levels increases. So this is the first question. Now we go for the second question, which is a direct question to team 3. So if it is written like YPT1A N0M0 for a surgical specimen after some pulmonary surgery, what the Y and the P stands for? "30 seconds are given to you to think, to recollect if you can. Then it will go for pass. Your time is up. Anybody want to try? So if, please.
So P stands for pathological staging and Y for autopsy.
It's a good trial, good try. But Y is for adjuvant. So it is like if you give adjuvant therapy before going for surgery, then the surgical specimen is YP. Otherwise, P is pathological, post-surgical specimen. So it will be considered a wrong answer. Now we'll go for the direct question to team 4. So your question is B0 to BX. This is a classification system of pathological specimen after post-transplant lung. In a post-transplant lung, after some bronchoscopy examination. So what it actually represents? What is the disease it represents?
Bronchiolitis obliterans syndrome.
So I cannot give you marks because it's not bronchial. So it will go for pass. We'll wait. Your answer is wrong.
It shows the involvement of the bronchus. Airway involvement will be is labeled by B0 to B.
This is a specific grading system for a specific pathological process occurring in a post-transplant lung. So it will be considered
in primary graft dysfunction for the when we assess.
It's not. The graft dysfunction can be 3 types. It's one of the graft dysfunction. So you have to mention which type you want to tell. So no more try. This question is also negative marking for both the teams. And now we go for answer. Answer is lymphocytic bronchiolitis. And it has a classification from B0 to BX. And that is the elaboration of the classification. We no need to discuss it here. Now we go for a direct question. This question 4 to team 5. How should an atypical carcinoid of lung be described as per WHO 2018 classification for NET? It is no more called a atypical carcinoid. It is classified in a class of and grade system. So you have to tell which class, which grade you have to put it. You want to put it. If it is a atypical carcinoid of lung. Your time is up. Anyone want to try? Yeah, please.
Sir, it depends upon the presence of mitosis if more than 10 or less than 10.
You are defining the atypical carcinoid, what it is. I am asking you the grade, the nomenclature, how you should call it. So it is not why it is atypical. We know it is atypical carcinoid, then how you should call it if you follow this latest classification for NET, neuroendocrine tumors. So it's a wrong answer. No more try for pass. So the answer should be like this. It should be neuroendocrine neoplasm. I have the pulmonary neuroendocrine tumor and grade is G2. Then it will be atypical carcinoid. You have to tell the grade, type, family, and category. That is how it has been described right now. So now we'll go for the direct question to team 6. What anatomical structure is split and expanded during dome procedure? DOME. Direct question for team 6. Time is up. So anybody want to try?
Audience.
Somebody is trying from audience, please. The correct answer.
Very good.
Very good. So this is a distraction, osteogenesis, and maxillary expansion procedure. Palatal roof is expanded.
1 second. Are there any teams from yesterday that participated? Is there anyone from yesterday? Any team at the back who are not here?
Any team who has
did not
participated yesterday in the elimination round, anybody available here, then they can participate in the final round. Anybody?
Do the RIMS team want to participate? They are already
You can
scared.
participate. Yeah. Don't get afraid with the question. Question is difficult for all.
This is just for you to learn. There's
We will
nothing-
invite you for the participation. Please come and sit. Please.
No, they've bowed out. They've bowed out already. Okay, so leave it. So we just go for 5 questions.
So we are having 5 teams. The first round ended here. We have a 6 question that will just store for if there is needed for a tiebreaker. So next round by ma'am.
Okay. So round 2.
So round wise, see the thing
Round
is,
wise bolo, duto rounded
you
bolo.
have to be careful about the questions that you are choosing when you are doing the, what do you say? The pass ones. So you have to remember it's -2. Team 2, 0. Team 3, -2. RG Corp, -3. CNMC 0. AIMS Bhubaneswar -4.
Okay, don't worry. This was just the first round. There's easier rounds ahead. Okay, this one will most of you will know. So we start this with team 3, right? The first question. What are the membrane associated mucins found in human airway? I'll just take the names. This is in your anatomy, you should know. Team 3. No? Anybody on the buzzer? No? Anybody from the audience? Huh? It's actually MUC1, 4, and 5. MUC5 and 6 are secretory proteins. MUC1, 4, and 5, 3 and 4 are membrane associated proteins. The secretory ones are 5 and 6. So next one for team 4, your question. Which alveolar epithelial cells are more numerous in human alveoli?
Type 2.
Sorry?
Type 2.
Type 2, correct. I'll take the answer. So it is 82 cells, which are although only 3 to 5% of the alveolar surface area, but because the surface area is so much that they comprise 60%, not compromise, of all alveolar cells and 15% of all lung cells. Well done. Well done. Give a round of applause first. Team to score. They deserve it. Yeah. Okay. So next one is for team 5. What is the last major stage of lung development in humans? Think of all the stages as you come down in the tree, in the airway tree. I've given you a big hint. I want you all to score. Buzzers are ready already.
No for buzzer.
Okay. Do you have an answer, team 5? No.
Is it alveolar phase?
Very good. So alveolar phase is the stage, is the last one, as you can see, all the way from fibroblast progenitor all the way to the alveolar stage is the last one. Good. Well done. So they get +2. Okay. So your question, team 6. Which cells store the ACE2 enzyme in the human beings, in the human lungs?
Pulmonary vascular endothelial cells.
What's that?
Pulmonary vascular endothelial cells.
Good. Capillary endothelial cells, but I'll take pulmonary vascular endothelial cells. Well done. +4 to team 6. And now we've started. Well done. Yes. So team 2, you're going to get the last question of this round. In which lung zone is the pulmonary capillary wedge pressure ideally measured? So you know when the right heart catheterization is being done, they have to reach that zone to definitely get the PCWP, otherwise it can be wrong. So you have to know the lung zone. Any answer for you? No? Okay.
Zone 3.
Zone 3. Well done. So zone 3 is where PCWP is always it is critical to get the right PCWP. Remember that. So it has to be zone 3. Well done. So the next question we are not giving to anyone. There's an extra one. So we are going to round 3. Okay. So round 3, the first question goes to team 4. Okay. Team 4. What does blizzard appearance in radial EBUS signify? This is a simple one, easy one. There are lots of audiences getting excited about it. You know the answer? No. Team 6.
Ground glass opacities and all.
Excellent. So this is the blizzard appearance, and it is ground glass opacities. And in a lot of these, it actually turns out to be adenocarcinoma. Okay. So GGOs. GGOs is what the answer is. Okay. So team 5, your question is next. Which of the following features of a lymph node does not predict malignancy during convex probe endobronchial ultrasound? Round shape, distinct lumen, central nodal vessel, and coagulation necrosis sign.
Central nodal vessel.
Well done. That is the correct answer. So central nodal vessels do not signify malignancy. Oh, sorry, the other way around. So team 5 get +4. So team 6, your direct question is next. Which pattern predicts TPE while during thoracoscopy? Do you want me to tell you what TPE is? Tubercular pleural exudate.
Sago grain nodules.
Well done. So you got an easy one. Sago grain appearance. Yeah. So that signifies. Okay. So team 2, your first team 2. Your first question is now. Rule of 4 is implied for which airway procedure? You can only be wrong. If you're in the negative, don't worry. Just answer if you have an answer.
LMA.
LMA. Wrong answer. Go on.
Is it electrocauterization?
No, I can't give you that answer. That's
It is a
minus.
rule of, it's one of the bronchoscopic interventions itself.
It's usually airway laser.
Airway
therapy.
laser.
Airway laser, not electrical cautery. They're not the same, so we can't give you the points. So -2. Yeah. So airway laser is where you use the rule of 4. So duration of lung collapse should be less than 4 weeks. Life expectancy should be more than 4 weeks. Procedure time should be less than 4 hours. And FiO2 during laser therapy should be less than 40%. Those are the rule of 4s. And only then, if they qualify, then you think about laser because it's an expensive therapy to use. Okay. So next question is for whom? Team 3. Which radiological sign predicts better yield during transbronchial sampling? When you're doing a transbronchial sampling on radiology, what is the sign that tells you that you will actually get something?
Peribronchovascular involvement more.
I'll give you one more chance if you want to.
Describe in words.
Yeah, you can describe even if you can't tell me this particular sign name, what you're trying to describe.
Bronchus directly ending in a mass.
Correct.
Any radialicus.
I'll give you
can't
points for that.
remember.
So that is CT bronchus sign.
CT bronchus
because
sign,
you've
yes, ma'am.
described what you meant. That is absolutely correct. And this is what it is. You can see CT bronchus sign tells you that in transbronchial lung biopsy, you might get a sampling. So CT bronchus sign, you described it, you get the points. Good. Has everyone completed this round? So round 2 and round 3 completed. Yeah. So you come to round 4.
Now the score, ma'am.
So you tell the score while we. So just I've been asked to say that iOS workshop is starting in Hall B. Any of you who are interested or who have registered for it, you can go and join that because it's starting.
Sure, ma'am. Score, please.
So we have team 6 leading with 8 points, followed by team 5 with 4 points. Team 3 comes third with 2 points. Team 4, 1, and team 2, -1.
Okay, buck up. We've still got 3 rounds to go. 3 rounds down, 3 rounds to go.
So we'll start with team 5. Direct question to team 5. Yes, ma'am.
Yeah. Direct question to team 5.
Direct question to team 5. So your question is, what are the 3 mediastinal compartments as per the INTIG classification, the latest one? Your time has started.
Is it upper mediastinum, aortic, and lower mediastinum?
No. Answer is wrong. So it's for the buzzer. Please.
Anterior, middle, and posterior.
Okay, we'll give you points for that. It has been described by this, the prevascular, visceral, and paravertebral, but they are equivalent to anterior, middle, and posterior.
We'll take it.
We'll take it.
+2 for them. Give them a round of applause.
Now, direct question for team 6. What imaging modality has the highest sensitivity to diagnose cardiac sarcoidosis?
Cardiac MRI.
Now, you have to tell which
Gadolinium,
modality.
gadolinium contrast enhanced cardiac MRI.
Till now, we will not accept the answer. There is a specific modality which is used. You have to tell that, because otherwise gadolinium enhanced MRI is not that sensitive until and unless that phase is also done. So which is the phase? Which is the phase of the gadolinium enhancement you want to see when you're doing a cardiac MR to diagnose cardiac sarcoidosis? The phase. So it will go for a buzzer. Anybody want to try? So, ma'am, decision will be final. I am showing the answer is late gadolinium enhancement phase of CMR.
Give it to them.
Okay. Please, ma'am.
Give them.
So now the direct question to team 2. There is a protocol known as DETECT protocol, which is proposed to diagnose a clinical entity in pulmonary medicine. Which is that entity? DETECT protocol is an algorithm to diagnose a clinical entity in lung disease. Anybody? Yeah, please.
Pulmonary hypertension in systemic sclerosis.
Good.
Very well done.
Very good.
Excellent. This is a very hard question.
So it is a
You deserve
DETECT
a
study
Big round.
which has done it. There is a ratio of FVC by DLCO, and as per the ratio, you can predict whether you should go for a pulmonary hypertension screening. Very good. Now we'll go for a direct question for team 2. Right, ma'am?
Yes. Direct question for team 2.
Which of the following antibody has the highest association with development of ILD in CTD? Presence of which serology test, positive serology test, will give you the highest chance of the patient is also getting ILD. If not present now, will develop later. Team 2. 5 से शुरू किया.
5 and 6 होएगा sir.
6.
Yeah, so now team 2. There's no team 1. So team 2.
This is for them.
Detect was for them.
Okay.
Accolade
So team 3. Yeah.
This is team 3.
Okay, you will get the time, please.
Sir, anti-row 52.
Anti?
Row 52.
So this is a wrong answer. It will go for a buzzer. It's a correct answer. So this is the percentage. So ACL77 is 60%, row 52 is 40%, anti-Q is 30%. So ACL70 is the correct answer. So direct question to team 4. Which toxin produces this Silo-Filler's disease?
This you should know.
Direct question to team 4, last question of this round.
Is it nitric oxide? Nitrous oxide.
Wrong.
Nitric.
It's not nitrous oxide.
Nitric oxide.
Not nitric oxide. -2.
It is nitrogen dioxide.
Nitrogen dioxide.
So this round is completed. Now we move to round 5.
Yes. So direct question to team 5.
1, 2, 3, 4.
Team 5.
1, 2, 3, 4 होएगा ना?
Team 5 will get the direct question. Round 5.
No, team 6 में. 1 to नहीं.
Oh, हाँ, नहीं. ठीक है.
So the next question, the next round, direct question to team 6.
Yes. Team 6.
So round 5, first question. Which sign is here? being shown. Radiological sign on X-ray.
Orange about boot-shaped heart.
Is it hilum ovalis sign?
No, wrong.
Wrong.
Pass to buzzer. Anybody want to try? Anybody want to try?
Anyone in the audience wants to try?
So it is a cervicothoracic sign. It tells you whether the lesion is the anterior or posterior mediastinum as the opacity crosses the clavicle. So now we go for a direct question to team 2. Correct, ma'am?
Yes, team 2.
So which is this sign called? For buzz.
If I could give a, okay, you have answer. Go ahead.
It's abdominal thoracic sign.
Very good. Thoracoabdominal sign.
Now we go for the next question, which is a direct question for team 4. Right, ma'am?
Team 4.
Team 4.
No, direct question for team 3.
Team 3. No, দুটো question হয়ে গেল তো।
No.
6টা. Direct question to team 3. Yes, ma'am. Sorry for the confusion. So, what is this sign called?
Head on cheese sign.
What side?
3 density sign.
আবার বল।
3 density also.
No, this is not 3
This is
density.
not 3 density. This is not 3 density. If you
Yeah.
can tell what the sign is and if you can tell which
Team
disease, you'll
6.
get an extra.
Team 6. But you have pushed the butter before the time.
It's called a straight edge sign.
Huh? This is
Straight edge sign.
What is the
Straight edge sign? Which is correct.
What is the? I think I accept. What is the?
In cases of UIP, if this sign is present, it indicates that it is associated with CTD finding. CTD associated UIP.
Very good.
Well
Excellent.
give them 2 plus 1.
We cannot
2
give
plus-
them, but
because
it's a
they
very
told
good
about
answer.
the disease as well.
Yeah. This straight edge sign. Good.
Well done.
So the next direct question is for team 4.
Team 4.
So which is this sign? X-ray sign. On the PA view, it is seen, and we want to make it easy by the lateral view. Don't get confused with the lateral view. PA view, it is seen.
Just look at the PA view only.
Try. Yeah, you want to try?
Dipsalcus.
Huh?
Dipsalcus.
No Dipsalcus. Which team is first, ma'am?
Okay, they.
So left upper lobe collapse, lupsial sign.
Good.
Well done. Left upper lobe collapse, or whatever you say.
Luptical sign.
Yes, luptical sign.
So the one question is direct question is left for team 5. So this is a congenital form of disease. Congenital form of disease. What is the etiology, genetic
Please.
or non-genetic?
Please make sure that the congenital form is answered.
Yeah.
Not the adult
We are
form.
giving clues and clues. Bolo. A.
GMCSF2.
Is wrong.
Wrong.
Anybody want to try? Okay.
No, let them answer.
Yeah.
What is the disease? So
PAP.
congenital PAP. Well done. Yes.
So answer is correct. Reason is that there is 3 types of PAP: primary, secondary, congenital. So you have answered for hereditary PAP, but that is in the primary PAP, and we have mentioned it's congenital. Okay, it's a difficult question. Now the last question, ma'am will ask.
So we'll just give you one question. This is just an extra question, buzzer for all of you.
Buzzer for all of you.
Whoever goes first on the buzzer answers it.
So
okay.
it's a radiological sign. You have to name the diagnosis. Okay.
So points will be +2, -2.
Yeah.
Just as a buzzer would be. What is your diagnosis?
Sarcoidosis.
Well done. So that is sarc. Huh? So team 6, they are very fast on the buzzer. You guys need to buck up.
So this is basically miliary sarcoidosis.
Yeah, good.
So ma'am, we'll move to the last round.
Yes. Last round, who's going to be first?
Team 2.
Team 2, your question.
Ma'am, score bolben. Bolen atte round.
So tell them the score so that.
Don't tell them.
Okay, actually don't tell them.
Don't
we'll tell in the end only.
We'll tell in the end. Let's see. So now the last round. Now the question direct to team 2. So which group of patients did not get any benefit from systemic steroid in COVID-19 in recovery trial? The famous trial after which DEXA is being used, which group of patient does not get any benefit?
Mild to moderate COVID.
We cannot accept this answer. Mild to moderate is a
non-severe.
What do you mean by non-severe?
We want a specific group. You know, in recovery group.
Anybody want to try?
Anyone in the audience? Very good. Well done. Big round of applause to Suresh.
So no oxygen, that is the group, and that is the, you can see this chart.
Yeah.
Now we go for a direct question for team 3. Which of the following is not a feature of platform trial? Platform trial is doing round now because of COVID. It is a multi-arm RCT. Ineffective arm can be dropped. Randomization can be changed in between trial based on response assessment, and it can address effect of an intervention in multiple diseases. Which of them is wrong? Direct question for team 3. Time up. Anybody will try with buzzer? Anybody will try with buzzer? No. Then the answer is option D. It cannot address effect of single intervention multiple disease. It can address effect of multiple intervention in case of a single disease. Now is a direct question for team 4. Which bias can be reduced by trim and fill method in a meta-analysis? Trim and fill method. Direct question to team 4.
Selection bias.
No. Meta-analysis, there is no selection bias.
Meta-analysis is already done. So in meta-analysis, you won't have selection. We'll give you one more chance because you are before time.
Bergsonian bias.
Huh?
Bergsonian bias.
No.
Anybody want to try? Anybody want to try? No. So it is publication bias. Publication bias is decreased by these trim and fill methods. When you do a funnel plot and you try to make it symmetrical. Now we go for a direct question for team 5. Genix trial. Genix trial has been planned to find the dose and duration of an anti-tubercular drug. Which is the drug? Direct question for team 5.
No? You want to give up? Okay. Anybody on the
Buzzer?
This is going to be for your exams.
Nobody is going. Yeah, please.
Go on.
BPL regimen means
BPL regimen?
betaquilin, pretomanid, and linezolid.
Which drug, particularly BPL regimen, is the baseline regimen in this trial. But which drug they want to find a dose and duration among this B, P, and L?
Linezolid.
Correct.
Well done.
With a lot of clues, but you have done very good. Now we go for a direct question for team 6. What is the importance of a exploratory outcome in RCT?
Last question.
So it's time up. Anybody want to try? Nobody want to try. So it is to bring forth the hypothesis for future trials.
Okay.
That is why this expected outcome are simple. So we end our quiz here. Let us hear the final score.
While she's tabulating, one buzzer question for all of you. No marks for that, but one buzzer question. Let's see if you can get it. It's an interesting one. Go on.
Who can be identified as a ghost author in a trial?
Who is a ghost author? A lot of students usually are. Still? When do you call somebody a ghost author in a trial or in any paper writing?
Anybody from the audience want to try?
So, ghost author is one who has not contributed. Okay, go on.
Bah.
But
Very
they
good.
don't have their name mentioned in the paper. Yes. So big round of applause to all ghost authors. Okay, well
So
done.
final score.
Tough questions, but I think they will help you with your exams definitely. So let's see who did really well. I think we sort of know, but let's see who the surprise winners are. So, after complicated tabulation by Dr. Shivarashmi Unnithan, we find out that Team 2 Medical College scores 2 points. Team 3 IPGMR scores 3 points. Team 4 RG scores 3 points. Team 5 CNMC scores 4 points. And Team 6 AIMS Bhubaneswar is first with 16 points. So first is AIMS Bhubaneswar, second is National Medical College, and third is TIE, RG and IPGMER. Okay, so we'll see.
Thank you, everybody. Sir.
We have a tie in Team 3, and we've said that in a tie we will give to both of them.
Okay.
So,
First prize.
No, one first prize, one second prize, and two third.
Wonderful.
Great. Thank you very much to the audience, especially.
Or the quiz masters too. Tabulator also.
Tabulator is the big-
Most important.
That's the most important.
Most important.
So we'll move on to the next session. The next session will be on pulmonary eosinophilia, a case-based discussion. The chairperson of the session will be Dr. Arindam Mukherjee. We are requesting sir to be on the dais. Thank you.
Dr. Arindam Mukherjee is a young pulmonologist in Kolkata. He's working with Tata Medical Center and some other hospital. He's been already introduced in the quiz session.
Thank you, sir. Thank you, sir. So for this session in pulmonary eosinophilia, I want to invite on the stage Dr. Ajmal Khan, sir. He is my esteemed teacher, and he presently is associated with Sanjay Gandhi Institute of Medical Sciences. His prominent area of work is obviously intervention pulmonology. He's a very renowned person in that field, and he is today going to deliver the talk. Welcome, sir.
Good afternoon, everybody. So after this said to be a difficult quiz, now these cases are going to be easy, and I have opened the answer on the first slide itself, that it is revisiting a tropical pulmonary eosinophilia, and it is a common disease. Although it is not a common disease in every place, it is thought to be a pockets of disease as called as an endemic area. But in a so much of fast world, we cannot say any area is endemic, because in the morning 4 hours back I was in Lucknow, and again in next 3 hours I will be in again Lucknow. So with this movement of fast movement, we cannot say it is a disease limited to an endemic area. So it's a common disease, and it is routinely can be seen in day-to-day practice. At least what I have found is that in Calcutta, these patients are there. So it is a 43 years old male who is a carpenter by occupation, and who had a history of cough with this expectoration, dyspnea, and with a diurnal variation. With this history, he was on examination. There was no rhonchi, but there was a crepitations were there bilaterally. So on a outside private practice, he was started on a treatment for. Anybody can guess the diagnosis at this stage? Obviously, it is asthma. So somebody has prescribed the inhaled drugs. Patient had a initial response with inhaled bronchodilators and inhaled corticosteroid. However, after some time, he stopped responding to those medications. So he came to the next level of the doctor, and where the initial investigation showed that he has a count of 30,000, out of which the eosinophil constituted the 21,560. Afterwards, he was again investigated and found to have a total IgE in a range of 20,000, and Aspergillus specific IgE is 2.27. So he was diagnosed as a patient of ABPA, and he was started on the standard dose of 0.5 milligram per kg body weight of steroid. After 6 months of treatment, the IG was repeated. After not 6 months, it was 3.5 months. The IG was repeated, and it showed that it is still 8.8, more than 8,000, and specific was 2.12. However, the thing is, the eosinophil count has mildly reduced. So this investigation, repeat IG, was done by us, and the reason to do the repeat IG, this ABPA panel, as we call it, panel, because it does the aspergillus specific IgE as well as IgG. So if we see the IgG, aspergillus specific IgG label was normal. So obviously it was not ABPA, and this patient has not responded at all with steroid. So it has a two message. One is the wrong diagnosis. Another is that in patient with tropical pulmonary eosinophilia, a lot of people think steroid is as a part of a treatment, but steroid does not have a role in tropical pulmonary eosinophilia. So this was the CT scan done at our center, which shows that, can anybody tell what is this?
Miliary nodule, sir?
Actually, we cannot call it miliary nodule. It is called central lobular nodules. The catch is these nodules are very fine, very soft, we can say it, because if we see the nodules of tuberculosis or sarcoidosis, it is very well defined, but it is something like a something more than a ground level, but lesser than the central lobular nodules. So these type of nodules are characteristically seen in patient with tropical pulmonary eosinophilia. So we evaluated this patient because this patient had a very high level of eosinophil. So we need to, because this tropical pulmonary eosinophilia is something that is a diagnosis of exclusion. So we must have to exclude the clonal variety of eosinophilia, and with that, the investigation with for them are the PDGFR alpha and beta to rule out the hypereosinophilic syndrome, bone marrow biopsy to rule out acute or chronic phase of eosinophilic pneumonia, or BCAR ABL mutation. So in this patient, we have also done, because as Arindam said, somebody from our department also thought it is a miliary nodule. So we did the transbronchial lung biopsy on this patient. And this is what we found out. Anybody can tell what is this? On this high power, can anybody tell what is this? It is a microfilaria inside the lung with a lot of eosinophilic infiltrates. So this was for us, this 18,000 label. Initially, when he presented, he has almost 27,000 eosinophil counts. When he presented to us, the baseline was 18,200. So we repeated this after 3 weeks of treatment with diethylcarbamazine, that is hetrazan. Normally, if we see people use 100 milligram TDS. Actually, 100 milligram TDS is not the dose. The dose is 6 milligram per kg body weight, which may vary because sometimes it is 100 milligram 4 tablets a day. Sometimes in some patient it is 100 milligram 5 tablets a day. So the dose is 6 milligram per kg body weight. Routinely people write 100 milligram TDS. So in these, patient may not respond at all. So after 3 weeks of treatment, the count has come down to almost 3,000 from 18,000. In next, we have repeated the dose after 3 weeks to another 3 weeks, and it was almost 300. And this was the IG report. It is come around 1,000, and aspergillus specific IG has also come out as 0.56 from 2.27. It is just an association. It is not has any causal link with the tropical pulmonary eosinophilia. These total IG and total IG may be raised because of the eosinophilic condition, but aspergillus specific IG has no correlation with this. And this was the CT after treatment of 6 weeks. So anybody has a question on this? I was told that it was a case-based discussion, but nobody has a question or nobody has any queries. So either I'm not clear or I'm not able to explain it. I think this is the only case that we have got, out of which I will tell you later. This is the only microfilaria, because once you diagnose, it is a microfilaria inside the lung. It is very easy. But we have done almost 48 lung biopsies in 248 patients. So only one we have found the microfilaria.
So if we don't find a microfilaria, there is another specific biopsy finding?
No, it is only the eosinophilic infiltrate. Means it is a diagnosis of exclusion.
So in this city, are there any septal thickening?
Septal thickening may be there because this long-standing disease, 6 months, 8 months of eosinophilic infiltrate, that much of. So we have done immediately after 6 weeks of therapy. So maybe if you would have done after maybe 1 year, 2 years, it might have been all cleared.
And so any role of follow-up with spirometry?
We are doing the spirometry, and there is a significant increase in lung function after the treatment with DEC, 3 weeks course or maybe 6 week course of DEC. So in 1954, this tropical pulmonary eosinophilia diagnostic criteria has been given by Donoghue in 1954 and 1963. That was published in New England Journal of Disease. And it is diagnosed with the pulmonary symptoms, that is nocturnal cough and dyspnea. Eosinophilia counts more than 2000, or the filarial complement fixation test positive. At that time, this test was used to be done, but now it is obsolete and nobody does this test. So, and there is a response to DEC. In minor criteria, there is a resident in endemic area for several months, illness in young adults, male, rhonchi with crepitation, chest X-ray showing diffuse miliary nodules, raised ESR, non-specific symptoms of fatigue, weight loss. And diagnosis requires all of the 3 major criteria or any 3 of the minor criteria. So this is how we approach, in our department, we approach patient with this peripheral eosinophilia. This is our approach. It is not being published yet. So it is going to be published in a few weeks. That when we encounter absolute eosinophil count less than 2000, what we do is we do a drug, take a history of drug exposure allergy. We do a stool examination, peripheral blood smear, filarial antigen antibody, microscopy with the microfilaria, and IG aspergillus specific IG. We just do this baseline investigation, but we do not treat any patient with tropical pulmonary eosinophilia who has a count of less than 2000. We prefer to wait with a serial absolute eosinophil count. And we do not do any further evaluation, and we just follow up with some kind of a symptomatic treatment. Suppose patient has some allergic symptoms, we give that Montelukast and cetirizine, levocetirizine combination, something like that. And if the patient has absolute eosinophil count of more than 2000, what we are doing is we are doing an evaluation for its etiology and evaluation for any end organ damage. So for this, we do is echinococcus serology, vasculitis workup, PDGFR alpha and beta estimation depending upon the clinical picture. We are not doing all the evaluation in all the patient. Chest X-ray and ECG, pulmonary function test, diffusion capacity, bone marrow examination, CT thorax, bronchoalveolar lavage, TBLB, plus minus endobronchial biopsy, which is required. And if there is no etiology is being found on these, then we label it as a tropical pulmonary eosinophilia and we start with the treatment. So in our experience, as opposed to the Donoghue criteria where it says young male, we have a spectrum of ages that has been involved in 248 patients. That age 10 to means 10 to 70 years of age, we have almost more or less equal, with equal frequency we have seen this patient. So if you see, the most common is that cough with a diurnal variation, and fatigue, wheezing is seen only in 28% of the patient, while rhonchi is only seen in 24% and crepitation in almost 40%. So absolute eosinophil count, if you see, it is a median of 6,051. Why we have not done mean is there is a wide variability, because some patient has a count of maybe 2,500, some patient has a count of more than 90,000. So it is better given in a median or interquantile range. So if you see, this is the answer of your question, that patient has a both pre and post bronchodilator improvement in lung function. And this is how the eosinophil counts goes down during the follow-up. And this is the decrease in absolute eosinophil count. This is decrease in Ig, and this is specific Ig with treatment. So out of 248 patients, we have a cure with a 3 weeks of course of hetrazan.
So cure means?
Cure means patient has eosinophil count has come down less than 2,000 and patient has no symptoms. So it is basically clinical and hematological response. So we have defined that as a cure in 129 patients. There is a persistent disease in almost 190 patients, 19 patients, which required prolonged treatment. And there is a relapse. The relapse varies between 6 months to 4 years. And the final cure is achieved in all the patients. And DEC course was maximum was required 5 times. 5 course of DEC is required in some patient of some kind of a patient. So we have a follow-up from 4 to 71 months of follow-up is there with us. So TP is not a rare endemic area. Diagnosis is of exclusion. Diagnostic criteria needs a revision. Definitive test is required to confirm the diagnosis if we want to label it as a disease rather than a diagnosis of a exclusion.
Sir, I have some questions.
Yes.
Sir, the first question is, so do you suggest that we should suspect TP in endemic areas in all patients with
not
non-controlled asthma?
Not in endemic area. My question is, I very categorically say, tell me a disease where you can find a eosinophil count of maybe 5,000 even. I will not say 90,000. I will say, tell me a disease where you will find a eosinophil count of 5,000. Nothing, nowhere. Even if you see the hypereosinophilic syndrome, they define it as that eosinophil counts more than 500. So I say that there is no disease except tropical pulmonary eosinophilia where you can find a eosinophil count of more than 5,000, except in eosinophilic varieties of leukemia, which is very, very rare in occurrence.
So should we do a eosinophil count in all asthma patients?
Asthma patient will have some amount of eosinophilic. There is a paper from Dr. Ritesh from PGI Chandigarh, where he has evaluated the role of eosinophil in ABPA. And the maximum level was 1,600 in that study, in all the patients of ABPA. So even in the ABPA, the eosinophil count does not go more than, maybe we should say that 2,000. I have taken the 2,000 criteria because I wanted to meet I want to go through that I don't know who criteria. Maybe that is because Ig is raised, because it is eosinophilic pathway is activated. So Ig is activated. Maybe there is a colonizer. So once you treat, the eosinophil count comes down, Ig level come down. So maybe that colonizer has a cleaning effect, nothing, but there is no specific cause for it. It is just an association as of now.
So CT, how will differentiate between ABP and TP? If the eosinophil count
No,
is high.
there is a
and
very clear
spec-
cut, very clear
and
cut
specific
difference.
IG is also positive.
No, that is what on CT, there is a very clear cut. If there is a bronchiectasis, it is not TP.
Okay.
Because in TP, normally there is a no bronchiectasis. And after a treatment, there is a complete reversal of PFT as well as the CT scan. And there is a, I was just discussing one patient because our resident has reported there is a restrictive defect. And on top of that, there is a significant BDR. So I was taking the class and I was asking why there are two contrasting. If there is a restriction, how can it be reversible? So now, then I told to them, there is only one disease in tropical pulmonary eosinophilia, and majority of the patient you get a restrictive defect, but you get a BDR.
Okay. Any question from the audience? Thank you, sir.
Okay.
Thank you very much for the excellent presentation. Sir, please sit. Apni beri jaye, sir. Sir, nikal jayenge aap. So I now invite Dr. Angita Dasgupta to deliver her lecture. She is professionally trained method associated with epidemiologic study, clinical and operative research. She is an eminent speaker and participated in different national level conferences. Her area of expertise are airway disease, non-invasive measurement of airway inflammation, asthma and COPD. Currently, she is associated with pulmonary medicine specialist in B.R. Singh Hospital, Center of Medical Education and Research, Eastern Railway, Kolkata. Welcome, ma'am.
I think I'll stand this side. Otherwise, I'm getting lost behind the presentation computer. Okay, without wasting much time, let's go into the case. So this is the story of a 57-year-old gentleman who is symptomatic since the age of 20, suffers from shortness of breath, wheezing, cough with whitish expectoration, and he was a never smoker. So this patient has a recent increase in symptoms despite being on very high doses of bronchodilators and inhaled corticosteroids. There is an increased need for the rescue inhaler. He has frequent nocturnal awakenings, symptomatic even on minimal exertion despite being on all this high dose of inhalers, and also complaint of having frequent exacerbations, at least one of them needed in hospitalization in a year. His family doctor believed that his exacerbations were mostly related to infections because it was associated with a high total cell count. So we proceeded through the clinical exam, which was just limited to a patient having bilateral rhonchi. The other systems were all within normal limits. So what, as doctors seeing such a patient in the OPD, what would you do next? Like Dr. Khan said, we need a little bit of interaction. So what do we do next when such a patient walks into your clinic? So nobody sees such patients in clinics. Okay. I would proceed by taking more detailed history. The modifiable risk factors, whether they were being corrected or not, for example, very few of them can be corrected. Can you name some of the modifiable risk factors that would give rise to such symptoms, such disease? Maybe one will, yes? Smoking, I will take that, yeah. Pollen, of course. So whatever was causing a deterioration of the patient's disease would be a trigger. Animal dander, yeah, of course. So the second thing I would do is to take care of the comorbidities. Inhaler use issues is a very big thing to do, and adherence to the treatment. So these are some of the things that which I would have done if this patient walked into my clinic. Next, what would you do after this? You would like to see some other test reports? Okay. So would you do that right away, or would you want to do something else? Because remember, this patient is a patient who's already on treatment, right? ABPA, okay. But we'll come to that a little bit later. I would have done a chest X-ray. And that's what we all do in clinics, right? More so in this era of COVID-19. So we would not like our machines or patients or doctors getting infected with COVID-19. So what does this X-ray shows?
Bronchitis.
Bronchitis, absolutely, yeah. So we also did a CT scan in this patient, and it showed cystic bronchiectasis, which was possibly a result of the long-acting severe asthma that this patient had. Proceeded to spirometry. There you go. Can you read the numbers? Okay, so what is the interpretation of this spirometry report? Maybe one of you can volunteer, if you can see.
Will you show them?
So FEV1 is
It's a moderate obstruction reversible.
moderate obstruction reversibility, but it's not completely reversible, right? FEV1 change is 11%.
FVC is reversible.
FVC, right. We just had a comment on that from Dr. Khan. So now this patient has apparently reached the uppermost level of GINA guidelines. So now we have to do something else with this patient in order to have control of his symptoms. And what is that? So let me summarize the picture in front of you. So this patient walks into the clinic on maximum treatment with inhalers, whatever was available, and as per the GINA guidelines. Modifiable risk factors were taken care of, comorbidities taken care of, inhalers taken care of, allergens taken care of, whichever was possible.
We'll investigate for any secondary cause.
We'll investigate for any?
Secondary cause like ABPA.
So we've done a little bit. Let us do a little bit more.
CT scan has been done. It is showing bronchiectasis. Aspergillus specific IG we will want to see.
Okay, so I'll show you that a little bit
And,
later. But before that, I think most of us would like to do a phenotyping, because we've reached right at the top of the ladder. Even if ABPA was positive, I think this approach would be better. So what is phenotyping? How do we understand the concept of phenotyping? Okay, so if you consider that all asthma patients, all pulmonary eosinophilia patients were similar, the approach would have been similar for each and every patient. The patients were homogeneous in their characteristics of asthma, whatever disease they had. That's traditional medicine, like the one we called out right now about GINA guidelines. They treat as if each and every patient has a similar disease. But when we stratify that, and we put a clump of patients in one cluster, another in another cluster, another in another cluster, we get a stratification clusters. And even when the clusters do not work out, we get a personalized medicine, that is individualized treatment in every patient. So a little bit about the endotypes of asthma, because I think it's required in this discussion. Th2, non-Th2, allergic, eosinophilic, neutrophilic, postgranulocytic, right? So you've all heard about this. So what about this patient? Don't see the red part, see the blue part. So what type of blood reports is this? Total cell counts raised, eosinophil counts 12% on the first occasion, 11,700, 4% eosinophils in the second occasion, and 7,800, 3% neutrophil eosinophils in the third occasion, IgE 427. This is a Th2 type. So if this is a Th2 type, because this is an eosinophilic disease, we would like to know what the definitions of eosinophilia are in such patients, right? So eosinophils are usually less than 5% of the circulating WBCs, and it is defined as being enraged if there is an increase of circulatory eosinophils of more than 500 millimeters per cube. Based on the counts, the eosinophils can be divided into mild, moderate, severe, and hypereosinophilic syndrome is defined as an absolute eosinophil count greater than 1,500 on 2 occasions, at least 1 month apart, or marked tissue eosinophilia. So where does our patient fall into? Asthma patient may be something else as well.
He has eosinophilia. He had eosinophilia.
He had eosinophilia.
But you cannot define most like a hypereosinophilic syndrome because consistently 2 counts was not more than 1,500.
So that's gone.
That gone. We see eosinophilia only. And we'll consider as a mild eosinophilia.
Okay. One important question here to address would be, is eosinophilia definition different in case of asthmatic? Do we consider something else?
In the various biologic trials, they have considered more than 300 or more than 150 more than 2 times what is written as a eosinophilia in asthma patients.
Absolutely, yeah. So whenever you see patients of eosinophilia, peripheral blood eosinophilia, try and find out what the exacerbation rates were, what the past records are showing. So in any patient, the past records are very important, okay? So now, can we name diseases who have blood eosinophilia and features of asthma? So this is the center point around which our entire case is revolving.
So we can consider 3 diseases, ma'am. One is Tuberculosis, one is tropical pulmonary eosinophilia, one is APPA.
So all the answers have been given by the chairperson. The audience is mute. Do you agree with what he said? Where are your hands? 1 person, 2 people, 3, 4, 5, 6, 7. Okay, so I think most agree with what Arindam has said. Now, this is the most important slide of this entire presentation. You could have eosinophilia in patients with benign diseases, allergy, atopy, asthma, parasites, fungus, aspergillus, HIV, vasculitis, IBD, and drugs. Now, remember those names because that's what you're going to exclude once you get patients of eosinophilia. You could have malignant disease like solid organ malignancies, lymphomas, not true eosinophilic syndromes, and of course, the hypereosinophilic syndromes. So if you go through this list of causes of blood eosinophilia with other features, which diagnosis most fits with our patient? So on the right-hand side, we have the hypereosinophilic syndromes. Certainly that doesn't fit with our patient. Malignancy doesn't fit. What about the benign diseases? Which one have we not seen or you would like to see? Like you said a while ago, it's the aspergillus you want to see, right? So now this is the allergy panel. Name it, it's positive. Yeah. So what is the diagnosis?
I consider it asthma. Type T2 high endotype asthma.
Okay. I agree with you too, but with a little bit of twist there. Severe asthma with fungal sensitization. So this is something like an ABPA, but not completely. So once more, we have the diagnosis. Now you are going to treat your patient. Now for treatment purposes, we have to put our focus on the phenotypes of severe asthma, right? So supposing we had this blood picture in the last patient, right? Blood eosinophils, 234 cells per cubic millimeter. Serum IgE 427, pheno 27. So what would we do here? What is the endotype? No? Okay, so is the blood eosinophil count raised? Not really. Serum IgE raised? What does this mean? But it's raised, right? Pheno?
Raised. More than 25 is raised.
More than 25.
25 should be considered raised.
So, it's something like when we say that my hemoglobin is 10 in one occasion, and when I measure it again, it's 10.1. So 10 and 10.1 could be the same person, the same measurement, right? So 25 and 27, I would consider to be not raised. So do we really need some other test in order to treat our patients and identify what we are treating? Remember, it's a case of eosinophilia, all right. But are the eosinophils restricted to the blood? It's no. The answer is no, right? But so what happens to the eosinophils? The eosinophils migrate into the organs of damage. So in asthma, where does the eosinophils migrate to? The airways. And so if it's the airways that we want to see, then we need to do some type of tests that would reflect the airway situation directly, right? So not via, meaning that if the blood eosinophil is 234, so I assume that the sputum eosinophils are going to be something like raised more than 3%, okay? That's not the case. You have to measure it. So this is one reason why you have to measure it, because there are two pathways of eosinophils going into the airways. One of them is directly from the innate lymphoid cells, and the second one is from the blood into the bone marrow and then into the airways. So there are situations that happen like this. The sputum eosinophils may not match with the blood eosinophils. So you need to do the tests separately. So why sputum? Because it's a highly specific sensitivity and sensitive test. And remember, it is the secretion of the organ of interest here. So if this patient would have had a eosinophilic gastritis, we would have investigated in lines of doing a biopsy in some form. So here is the process. You take the sample, which is either an induced or spontaneous cell sample. Induction samples are also, may also be used. We induce with hypertonic saline and it's safe. Pre-medication with salbutamol, and the trick is to process the sample within 2 hours. So this is the process. I'm not going through this at all, because we are now concentrating on the type of airway inflammation that we measure from the sputum assay. So there are essentially 4 types. eosinophilic, neutrophilic combined postgranulosity. And the strategy would be to increase the ICS if you had an eosinophil count more than 3%. We do not give antibiotics there. In neutrophilic bronchitis, we do not increase the inhaled corticosteroids, but give antibiotics and retest after 2 to 3 weeks. And if there is no inflammation, we do a hyperresponsiveness test, a bronchoprovocation test, and give the patient a bronchodilator depending on what the results are. Now, what are the disadvantages of sputum assay? This is something we need to understand and remember as well. So all does not converge into a single test. It needs training, wet lab facilities, availability, and the most important thing that may happen is you may not have enough sputum despite induction. So I think people who have tried to induce sputum know this. So what are we going to do if we do not know what is going on with our patient? We have to do something, right? So here is where the sputum fluid phase measurements are important. Okay, so we have an experience of doing fluid phase measurements and measuring the proteins. And we found that 21 proteins were important. They clustered into 5 important functional types. And when we tried to compare patients with frequent exacerbations and patients who did not have frequent exacerbations, we found that the inflammatory proteins were different in both the cases. If you see the graph, you will realize the differences. And mucins, of course, were different in each of the 2 groups, different from frequent exacerbators and those who did not have a frequent exacerbations. Okay. So I'll summarize by saying that patients with pulmonary eosinophilia need accurate inflammatory to identify the specific phenotype. Blood eosinophils may not be good enough. We need sputum. Sputum quantitative assay has the ability to phenoendotype even in clinical practice. And sputum fluid phase measurements is the future of inflammatory. I leave you with this slide because I assume that most of the students are there. So it's for you. Just remember the causes, because excluding a single disease at a time, you are definitely going to reach to your diagnosis. Thank you very much.
Thank you, ma'am. I now ask for some questions from the audience, if they have any. If they do not have any, I have some questions. So, ma'am, my first question is, so when should we do that phenotyping for asthma? For all the patients, when we get a patient in our clinic, whether it is controlled or not well controlled, should we go for phenotyping, or only for the asthma which are difficult to control?
Your second answer is correct. So we do not do phenotyping. Phenotyping by sputum assay is only done when we have not been able to understand the phenotype of the patient and the patient is already in stage 5 with the maximal doses of inhaled corticosteroids and sometimes oral corticosteroids too.
So ma'am, here I have a small doubt. It is usually said that if you go more than 400 microgram of budesonide per day, it has some effect on the adrenal.
It has some effect
when you
on
go to the fifth, then we are giving 800 microgram per day. So should we not do this after when they are in the GINA 4 stage, or wait for the GINA 5? This
no, because if you go through the GINA 5, you'll find they have other options there as well.
Yeah, ma'am.
For example, tiotropium.
Yeah, tiotropium, ma'am. So if the patient is in tiotropium is also in the stage 4, stage 5 when they are going to the highest dose of ICS. So my question is that we wait for that highest dose, or when the patients are already not well controlled or moderate dose, and we should do the phenotyping, then we increase the steroid further.
It's like trying to answer a question where, when would I do a tuberculosis AFB test?
Ma'am?
It's like trying to answer a question which says that when do we do the sputum tuberculosis test, that is AFP, whether it's after the entire regimen is completed or before that, right?
Before that.
Yeah, so, but here, this is a chronic disease.
Yeah.
So there is no question of being contagious or spreading or something. So we have the option of giving oral corticosteroids too in patients of stage 5. So we have to be very, very careful to see that we have done enough. The patient is not responding, then we do a phenotype. That is what my take is. It may be different for other people as well. So that's completely acceptable.
And another point is that, ma'am, in the Arindam has a question. Please, Arindam.
As you are suggesting that for system, but into its own availability, we have been that system eosinophilia and eosinophilia are usually concordant. So, what is your take on the concordance of the discordance?
Okay, so there was a slide there. There was a graph. If I could go back to that. This one. Okay, so the y-axis is sputum eosinophil counts and the x-axis is the blood. So what do you see here? If you have a low sputum count, you could have a high blood eosinophil counts. If you had a high blood eosinophil counts, you could have a high sputum eosinophil counts. So that doesn't seem to be quite a sub-complementary test. Okay? The concordance is not that great here. Am I getting marks or something?
Any more questions? So, ma'am, I have another question. The question is that these biologics which has been recommended for severe asthma, none of the recommendation at present having the sputum eosinophil count mandated. So, do you think before going for these very costly medicines, we should do a sputum eosinophil test, or we can only rely on the blood?
So I would always say that you need a sputum inflammatory test.
Before starting any
Before
biologics.
starting, because you have to be very accurate in your phenotyping.
Yes,
if you're not very accurate, you're not going to give your patients the best of treatment.
yes. Thank you, ma'am. Any more questions from the audience? Thank you, ma'am.
Thank you very
Finish this session here.
Yes, yes, yes.
Thank you, sir. Thank you, ma'am. So then we'll proceed on to the next session. That is management of massive hemoptysis and BiPAP in critical care and understanding. To chair the session, I would like to invite Dr. Shrudeep Ghosh on the dais. And the eminent speakers for this session is Dr. Kranti Garg and Dr. Leelavati Thakur. Dr. Ghosh. Dr. Ghosh is an assistant professor in the Department of Pulmonology, Medicine in AIIMS, Kalyani. Sir, over to you.
Good afternoon to all. So without wasting much time, I'm going to the topic of discussion. The topics are management of massive hemoptysis. So I would like to invite Dr. Kranti Garg for his speech.
Very good evening to all. Thank you so much, Chairperson, sir. First of all, I'd like to thank Dr. Bhattacharya for giving me this opportunity to be here on this platform. So today, I'll be speaking about management of massive hemoptysis. First of all, coming to the definition itself. So when we search the literature, we find that there is no consensus on the definition of massive hemoptysis. Practically speaking, any life-threatening hemoptysis is vice versa called as massive hemoptysis. That is a hemoptysis, the amount of blood which causes significant hemodynamic decompensation or respiratory distress. And if it is left untreated, it has a mortality risk of more than 50%. So when we go through literature, any large amount ranging from 100 to 1000 ml per day, some have quoted more than 300 ml per 24 hours. So we have different definitions for massive hemoptysis. And what we should remember is that in cases of massive hemoptysis, we need urgent life-saving interventions. So then there is another magnitude of effect definition, again, not depending upon the amount of blood, but basically it relies on the clinical consequences of hemoptysis. Airway obstruction and hemodynamic instability, I have already quoted in my previous slide. And then again, any hemoptysis which may require transfusion, hospitalization of the patient, there is a risk of aspiration, hypoxemia, and death. They are all labeled as massive hemoptysis. Now coming to the various sources of bleeding in massive hemoptysis, usually the bleeding is from the bronchial circulation. However, there could be some cases where we have bleeding from the pulmonary arteries or the non-bronchial systemic arteries. Now, how do we diagnose a patient with hemoptysis? First, as always, X-ray, which may help us in the diagnosis in 70 to 80% of the patients. But we should remember that it may be normal in 20% of the individuals. Then coming on to chest CT, it has a high sensitivity. And remember, if we have availability, yes, it has a prompt reporting in comparison with the MRIs. Then we talk about MDCTs, that is the multi-detector CT angiographies. And then we have diagnostic and therapeutic bronchoscopies. Another important thing to remember here is that CT and bronchoscopy, they are complementary approaches to each other. And we should never fail in history taking an examination. Why? Because we have to see what is the cause of hemoptysis. When a patient of massive hemoptysis is coming to us, we may be having different temporizing methods to control that bleed. But basically, we have to address the underlying etiology. So we have to go through the history of the patient, we have to examine the patient well, and then we have to reach at a diagnosis with various modalities which are available with us. Now, what is a general approach to massive hemoptysis? We should remember that we have to protect the airway, we have to hemodynamically resuscitate our patient, and then we have to control our bleeding side. I will again stress that the stepwise approach is prioritizing rapid airway protection and hemodynamic stabilization. We should remember that the patients are not going to die with the bleed, with the amount of bleed, but basically they are dying mostly because of asphyxia. So first we will hemodynamically resuscitate the patients, then we will protect the airways. For hemodynamic resuscitation, we have fluids, we have blood products and transfusions. We have to correct the coagulopathies if there are any. We have to transfer the patient to ICU depending upon his predictability. Then we have various airway protection techniques and controlling the bleeding side, which I'll be taking up one by one. First, coming to the airway protection. So, as I have already told you, it is a stepwise approach. First of all, we will place the bleeding lung in dependent position if we know which side is bleeding. So here, this is a photograph where a patient is placed in left lateral position because the bleeding was from the left side. Remember, multidisciplinary approach is very, very important in patients of massive hemoptysis. As soon as any patient with a life-threatening hemorrhage comes to us, we have to consult a thoracic surgeon, pulmonologist, anesthesiologist, and interventional radiologist. They have to see the case in totality and decide what will be the best possible intervention for that particular patient. And as I have told you that we have to find out the etiology. So etiology means we will be going for a definitive treatment of that patient. However, in the meantime, we have to utilize the various temporizing methods for controlling the bleeding. We have to promptly correct the coagulopathies, if any, and we have to identify the etiology. And we should also remember that even after thorough workups, in 11 to 19% of the patients, no etiologies could be found. That is, they are cryptogenic hemopsis. And such patients have to be kept on close follow-up and monitoring once they stabilize. So I will not go into this extensive list of causes of massive hemopsis, which we all know, and they include bronchiectasis, post-tubercular, and then we have ABPAs, and then we have various airway causes, parenchymal vascular malformations, and iatrogenic reasons. Now coming to the first part after resuscitation. First is the resuscitation. This is the second part, that is the air protection. So one of the methods is endotracheal intubation. We have to intubate the patient to protect the airway, and we have to isolate the bleeding lung as well as the non-bleeding lung. How does it help? It helps in effective ventilation, and definitely it helps us in the facilitation of passage of bronchoscope and tamponade devices. So the various lung isolation techniques include a selective bronchial intubation. So when the bleeding is from the right side, like in this patient, when the bleeding is from the left side, we place a single lumen endotracheal tube into the left main bronchus. But here we should remember that if there is a left-sided hemopsis, then we cannot go for selective bronchial intubation because of the risk of right upper lobe collapse due to proximity to the carina. In such patients, selective right main stem intubation is done. Another method is the endobronchial balloon tamponade bronchial blockers. So here, through the endotracheal tube, the bronchial blocker is passed to the bleeding side, So this is the widely used method. This is left in place for 24 to 48 hours. Bleeding site can be evaluated with a pediatric or a small bore fiber optic bronchoscope after deflation. And Fogarty's embolectomy catheter is one of the devices which can be used as a bronchial blocker in our patients. Then another technique is the double lumen endotracheal tube. Here we have two tubes which are passed through the airways. One is the tracheal tube, which will provide the ventilation to the lung. And second is the bronchial tube, which will provide tamponade to the bleeding site. So here, what it does is it basically ventilates the lung and provides for intermittent suctioning of the either lung. However, the various disadvantages with this process is, first, it needs a lot of experience and expertise in placing such tubes. Smaller lumens mandate use of thin bronchoscopes, and removal of blood clots is very difficult because the lumen is quite lesser in diameter. Now, talking about the bronchoscopic approaches, we have the fiber optic bronchoscopy as well as the rigid bronchoscopy. We know the advantages and disadvantages of both of them. I will not go through the details. Rigid bronchoscopy, it definitely has a wide bore suction and therapeutic port. However, it can be reaching only up to the larger airways. Fiber optic bronchoscope has a smaller suction with limited interventional options. However, it can go farther away than a rigid bronchoscope. Now coming to the various temporizing techniques, we can directly tamponade the bleeding site with our bronchoscope. We can instill various vasoconstrictors like cold saline, diluted epinephrine, terlipressin, and ornipressin. Balloon tamponade is another method to control the bleeding through the bronchoscope. Then we have endobronchial airway blockades through silicone spigots, bronchoscopy guided topical hemostatic tamponades like oxidized regenerated cellulose mesh, and we can use biocompatible glues. And then we have endobronchial stent tamponades as well. So this is one of the patients where there was a bleeding from the right upper lobe. So a Fogarty's catheter was introduced, it was inflated. You can see here that the Fogarty's catheter is in place and the bleeding has stopped. This is another patient where a silicone spigot was placed in the posterior segment of the right upper lobe to control the bleeding. So these were the temporizing methods which are done with the help of a bronchoscope. Now coming to the definitive treatment options through the bronchoscope. So when we talk about definitive methods, first we have to relieve our airway obstruction and then we have to control the hemopsis. This can be done only when the source of bleeding is bronchoscopically visible. And the two methods which are most commonly used are the laser photocoagulations by the NdVag lasers and the argon plasma photocoagulation. So this is another patient where laser photocoagulation was done. We can see that there was a bleeding from the bronchus intermedius. So with the laser photocoagulation, there was coagulation and devascularization of the tissues and ultimately carbonization and stopping of the bleeding. So when we talk about some other bronchoscopic interventions which are at hand with us, that is cryotherapy and brachytherapy, and then we have electrocautery. But we should remember that these kind of interventions are not of much help in patients with massive hemopsis. If the amount of hemopsis is lesser, they can be helpful. But when we are talking about massive hemopsis, these are of not much help. And procoagulants like fibrinogen and thrombin, there is a role of Trenexa. We keep on giving Trenexa, and nebulized Trenexa has also been used in the past, but it is not of much help when the patient is having massive bleed. Now coming to interventional radiology, we have the bronchial artery embolization, and that is foams, gelatins, sponges, cyanocrylates, remember, we may need to abandon the procedure because if we are not able to cannulate the vessel, we are not able to achieve a stable catheterization, or if we are visualizing a spinal artery branch arising from bronchial artery, because these patients may be landing into neurological deficits. However, with the advancements and super selective techniques which are available with us, there is a significant reduction in neurological deficits. And obviously, when we talk about complications of bronchial artery embolization, we have pyrexia, chest pain, dysphagia, groin hematomas, subintimal dissection or perforation of the arteries by the guide wires, and neurological deficits because of the spinal artery branches. So this is a diagram, this is a photograph which shows the left upper lobe bleeding and a picture of the bleed after the bronchial artery embolization, which has significantly decreased. So now the most important thing about bronchial artery embolization is the risk of recurrence in these patients. Sometimes there is incomplete embolization, sometimes there is recanalization and development of collateral circulation. There is presence of non-bronchial systemic arteries. So bronchial artery embolization is of not of much help. There is a bleeding from the pulmonary artery origin. And then when we talk about etiologies, there are high chances of recurrence in patients with bronchogenic carcinomas and aspergillomas. Now coming to the surgical interventions. So nowadays, surgical interventions are more of a salvage strategy. Emergency surgery is only used when the patient is not stable to be shifted to a bronchoscopy suite. We should remember that if the patient is hemodynamically unstable, there is a cardiopulmonary compromise, there is a need there, and such patients cannot be shifted to the bronchoscopy suite. So in such patients, emergency surgery may be required. Otherwise, with the advancements in bronchoscopy and interventional radiology procedures, surgical techniques now have gone a little back. However, there are certain conditions when surgery is the strategy choice, and these include necrotizing lung infections such as mystomas, aspergillomas, diffuse and complex AV malformations, iatrogenic pulmonary artery ruptures, chest traumas, etc. The biggest advantage with surgical intervention is that there is a negligible risk of recurrent bleeding. I have already told you that with bronchial artery embolization, there are high chances of recurrence, but with surgical interventions, there are negligible chances of recurrence. And again, talking about the definitive treatment, we have to treat the underlying cause according to the etiology. In certain patients like cystic fibrosis, we may need a lung transplant. Another important thing when the patient is massively bleeding is sometimes what happens, there is a blood clot which obstructs the airway and is a cause of asphyxia. So blood clots after massive hemopsis, they have to be removed. First, they are to be removed to improve the ventilation. But we should remember that when we are removing a blood clot, there is a chances of bleeding from the site again, because there is a compression by the blood clot on the bleeding site, and that compression we are going to remove. So we have to be very careful while we are removing the blood clot. So this is one picture which shows that there was a big blood clot in the right main bronchus, which was removed with the help of a cryoprobe. And this is after the removal of the blood clot. The airway patency was maintained. So there are various algorithms which have been proposed from time to time for the management of massive hemoptysis, depending upon the stability of the patient and the bleeding localization. So this is one of the algorithms. The detailed things I have already discussed. This is another algorithm, basically depending upon the site of bleeding, that is whether an endobronchial technique is to be used, surgery is to be resorted to, or bronchial artery embolization is to be used. Summarizing, we have to first recognize the massive bleed. We have to resuscitate our patients, preserve the airways, diagnostically evaluate our patient for the cause of bleed and the site of bleed, use various temporizing methods to temporarily control the bleed, and then go for definitive management. And remember, immediate consult with the multidisciplinary team is very, very important for management of patient in totality. Thank you so much.
Thank you, madam. Details description on management of hemoptysis. Now, any question from audience?
Sorry, very nice presentation, Dr. Kranti.
Thank you so much. Ma'am.
Regarding one question, if you have a patient with who is having a repeated hemoptysis, despite embolizing and all, so what should be your strategy to manage?
Ma'am, the best thing is surgery in such patients, because if the patient is having recurrent hemoptysis and if the various bronchoscopic techniques are basically temporizing methods, except for the ND-VAG and the laser and that argon photocoagulation, we go for bronchial artery embolization. So if the patient is having recurrent bleeding even after the source has been identified, there are because that means, as I have already told, there could be chances that collaterals are forming or there is some other cause, for example, aspergilloma or malignancy. In such patients, we have to take up the patients for surgery if possible.
Many of the cases like pulmonary artery AV malformation, some AV malformations, they are very recurrent.
So
that is
in AV malformations, surgery is the treatment of choice. We should not go for rest of the therapies. I have already given the list in which surgery is the first line treatment.
Yeah, exactly.
So AV malformation is one such condition where we should not go for rest of the management methods. We should go for surgery.
Surgery as soon as possible.
Yes. Thank you.
Any other question? Thank you, madam.
Thank you. Thank you so much.
So the next topic of discussion will be BiPAP in critical care, and on that topic, madam will speak on BiPAP. Dr. Leelavati Thakur. Madam is an experienced critical care consultant who has 27 years of experience and presently working at Narayana Multispecialty Hospital, Durgapur. Madam is a perfect person to speak on this use of BiPAP in critical care. Madam.
Thank you. There is a little change in altogether about myself. Good afternoon, everybody. I think it's a time to siesta, but let me break that siesta. It should be a little enjoyable discussion that I am going to have. It's nothing but kind of a storytelling. I had been through my 30 years of critical care experience with this BiPAP. Rather, I'd like to discuss it as a non-invasive positive pressure ventilation, or NIPPV, which is a gamut of different kind of CPAP, BiPAP, and the non-invasive ventilator from the main mechanical ventilator. So I'm going to go through it. First of all, I am the consultant in critical care in the Mission Hospital, Durgapur, right now. I was in IQ City a few years back. Definitely, I had made that ICU there. And now I am in Mission Hospital, Durgapur. Thanks, a big thanks to Dr. Partho Sarathi Bhattacharya, who has been mentoring this Pulmocon since 2002, 2003. I know him personally since probably 1996 onwards. And I'm really thankful to him, thankful to all of you audience who is still sitting over here for the last lecture of the session. So welcome all. starting from the beginning, I'm not a pulmonologist. I'm only a critical care physician, practicing critical care for last 30 years. Merely the experiential learning that I am sharing with you, I think it's going to be enjoyable. So bucket full of various modes, we all know. CPAP, BiPAP. I'm not going into greater details because all of you, the pulmonologists, know much better than me. So the respiratory failures which NIPPV is going to tackle are different types, 1, 2, 3, 4, all of us knows it. Type 1, 2 are hypoxemic and hypercarbic, 3 is mostly perioperative, and 4 is the hypoperfusion due to shock because of some cardiovascular shunt, some pulmonary shunt, or some hypoperfusion due to shock. There are different types of variety of causes for this failures, like for hypoxic failure, there are severe alveolar hypoventilation like ARDS, infection, fluid atelectasis, or anything, mucus plug sitting over there in the bronchus, bronchospasm, vascular problem like capillary leak, embolism, increased hydrostatic pressure, VQ mismatch like in ARDS, shunting, dead space, these are all. Hypercarbic failure definitely are a gamut of different types of problem in critical care patients, mostly the COPD type 2 respiratory failure with acute exacerbation of COPD, stroke, head trauma, muscular, neuromuscular disorders like paralysis, mostly quadriparesis, or otherwise hypophosphatemia. And another very important electrolyte that we miss most of the time is hypomagnesemia and hypokalemia. This is very important for all those actually practice critical care. Any patient with quadriparesis, please find out their potassium and magnesium always. Everything, be it a hypercarbic failure, be it a hypoxic failure, they actually initiate the increased work of breathing where we act upon with the BiPAP. So these are all different strategies, yes. Now BiPAP, the spontaneous mode, mostly the spontaneous mode. We fix up the IPAP, EPAP, and IPAP minus EPAP is the delta pressure support that is giving rise of the driving pressure in non-invasive ventilation. BiPAP may be better tolerated in patients complaining diffuse exhalation on CPAP. So BiPAP is a better always. But CPAP has got its own indications. Mostly the sleep disordered breathe, obstructive sleep apnea. There CPAP is the best choice. And obviously CPAP is another choice for the pulmonary edema, the cardiogenic pulmonary edema. That is CPAP has got an indication on cardiogenic pulmonary edema. Otherwise, auto BiPAP, BiPAP with NPPV and adaptive servoventilation, they are all different types of ventilation. I am not going into that details. Then there are newer modes like AVAPs and ST modes. Most of them are actually designed for the patients at home. Whenever we practice BiPAP at intensive care, we start it with the BiPAP and then follow it with, rather we start it with a ventilator associated BiPAP like NIV, whatever we say. And thereafter we scale down to smaller BiPAP, that is a portable one. And thereafter at home, we continue that as a home ventilation or home BiPAP. So many of the cases. So very, very important thing about initiation of BiPAP is the interface. What kind of interface you are going to choose finally? If the patient interface is going to tell you about the outcome of your BiPAP ventilation, because these are going to, going to be adapted by the patient, and once patient is comfortable, then only you can actually go through the whole journey of BiPAP ventilation. So interface is the main important thing that we start with. See, there are different kinds of interfaces that we use generally. Most of them are oronasal, and sometimes the nasal. Nasal is a later on, because mostly in home BiPAP, they use the nasal mask. That does not, interfere with the speech and all. There are nasal pillows, there are full face masks, and there are the helmets. Helmets have been in vogue after the COVID scenario, because prior to that, people used to be very much claustrophobic in helmet. Thereafter, with the COVID scenario, it has been now much more practiced. And another is a hybrid kind. You can see there is a nasal pillow along with a mouth oral mask. There are different features of face mask. Mostly, I'd say the important thing here is the respiratory ports, expiratory ports of the mask. Whatever mask you are using, you have to see whether whenever you are going to attach it with a mechanical ventilator, then you have to see whether it is a complete mask or not, or whether this mask has got the expiratory ports. If there is expiratory ports, do not use that on a mechanical ventilator associated NIV. Please use that with a normal BiPAP machine, smaller one. So please look at that. And for the tubings, particularly with this mask, with the NIV, the ventilator mask, that has to be, there has to be a one expiratory tubing and another is expiratory tubing. That has to be there. We have to be very careful about this. The pros and cons, we all have seen in our experience that after putting in the mask, people generally try to pull it out because they feel claustrophobic. They feel some obstruction is there. I need to remove it. So they try to move it. There should be a good sealing. A little air leak is allowed, but good sealing around the mouth and nose. Again, another thing that is very, very frequent in our part of the country, I mean, all over the country actually, there are incidences of pressure sores after putting in this BiPAP mask. And mostly what we do, I'm going to show it in a later slide, that what we do is to apply the foam, how to apply the foam, what foam we apply, we are going to show. So there are different pros and cons and everything. I'm not going into those details because everybody knows this. So what does a BiPAP do? It increases PO2 by giving a PEEP, recruiting the alveoli, increasing the ventilation and perfusion, decreased shunt, increased FRC, decreased respiratory rate and walk of breath, offsets, auto PEEP, reduce airway resistance, mostly in the obstructive sleep apnea, and improve the tidal volume and PaCO2. Once the tidal volume improves, the PaCO2 automatically improves. So what are the advantages what we see in day-to-day? That is, it's non-invasive. The correction of gas exchange occurs, improves lung mechanics. And somewhat, once the patient is comfortable enough with the ventilator, with the interface, then it's actually good for him. Patient can sleep on this ventilator also. And many of the times, once the acuteness goes off, we do it a intermittent kind of application, so that 1 hour, 2 hours off, 2 hours on, 4 hours on, 2 hours off, like that. So we generally gradually wean it off over the time once we achieve our target for the correction of the gases. Definitely this avoids the complication of intubation. Intubation, not only intubation, but along with the complications of mechanical ventilation or ventilator associated events, we can avoid. Infection like ventilator associated pneumonia, sepsis, sinusitis, these things can be avoided. It's less in cost and decreased mortality associated with respiratory failure. The last but not the least is very, very important is that if you are practicing end of life care, I don't know whether this is too much rampant in this side, but at some place of India, it's good, well practiced, because many a times the terminal cases, the terminal cancer, metastatic cancer patients, they generally want that they should die peacefully. They should die comfortably. This has got a very good indication in that also at the end of life care. They do not need, they do not want to be intubated further because they know that the end is near. So what are the candidates? The candidates must be a cooperative patient with intact gag and cough. So to aid in dyspnea, to aid in respiratory acidosis, AECOPD, cardiogenic pulmonary edema, these are the major indications. Mostly the indications, the strongest evidenced indications are acute exacerbation of COPD with respiratory acidosis. Next is cardiogenic pulmonary edema. Third is this for the immunocompromised patients who are on some chemotherapy or who has got a solid organ transplant and on immunosuppressors. They have to be on more on, non-invasive ventilation rather than the invasive ones, because they are very much prone to get hospital-acquired infections. The patients who are DNI, I have already told you, these are the patients where the majority indications stand. So this thing had been copied and pasted over here because from Dr. Martin Tobin's mechanical ventilations book. It's very, very well known, and it's really it's a rather textbook for most of us in critical care. So we read Martin Tobin for ventilation, and from there I have copied and pasted over here. So he has very, very nicely written over how to come over the discomforts of non-invasive ventilation, like discomfort on fitting, check fit, adjust straps, facial skin erythema, loosen straps, then claustrophobia, smaller mask, sedation, nasal bridge ulceration, loosen strap, artificial skin, change mask type. These are the things that he has written over here. This is one is actually a cosmetically as well as very, very, very discomforting actually to see a great ulcer on the bridge of the nose. How many of you have seen this after? Yes, most of you have seen. And with, we actually do not want that leakage to happen, isn't that? Even with the rise to wean, the leakage, some leakage happens, but we do not want that leakage because the BiPAP gives continuous alarms, leakage alarms. So that is why people go and fix it very tightly. And this happens. So these are the things. And upper airway obstruction, gastric distensions, these are the most major complications. Inhalation of gastric regurgitation. So patient may inhale or aspirate the gastric contents. Sleep fragmentation, noise, mask intolerance, and failure to ventilate. Skin breakdown necrosis, I have shown it. So OSA, CPAP, central sleep apnea, BiPAP, OSA, BiPAP again. Obesity, hypoventilation, mostly BiPAP. Chronic respiratory insufficiency due to progressive neuromuscular restrictive chest and wall disorders, CPAP. If patient with hypercapnia, use BiPAP. And when the chronic respiratory insufficiency due to progressive neuromuscular like amyotrophic lateral sclerosis, these kind of patients, muscular dystrophy, these kind of patients who need this BiPAP again, you should prefer a ST mode rather, because these are the machines which are to be used at home by them. So please use a machine with a ST mode, that is timed mode. So what are the prerequisites for successful NIV? If the patient is young enough and can control the airway and secretions, who has got adequate cough reflex, who is cooperative, who is able to coordinate, who is able to carry out your commands, they are the actual candidates. Unstable patients should be excluded. Patients with whom the GCS is less than 11, please do not ever put on non-invasive ventilation on him. Absence of unstable facial fractures. If the patient is a trauma case, do not put him on a BiPAP if he has got a facial trauma. Management of anxiety. The patient is very much anxious and repeatedly pulling out. Definitely, these patients are not a candidate. Putting on the BiPAP is a multidisciplinary approach. Who all are there to help you out? You are the physician, the nurse, the respiratory aides, the physiotherapist, others. There are many persons involved in a successful NIV outcome. So you have to choose the ventilator, which ventilator you are going to apply, choose the interface, which interface is the best for your patients, because you have to have a complete assortment of interfaces with you, and you have to pick and choose which one is good for whom. Choose the settings, work with the patient, reassess, readjust, assess for success and failure and win. But please remember what you need to see, and rather I'll tell this because you have to reassure the patient first. The patient has to understand what is going to happen and why we are putting him on our NIV. The patient has to understand. So please check with the scale that is provided in your mask packet, the exact size of the patient, exact size of the mask the patient needs. You have to check it. You can get this kind of a scale along with your BiPAP mask. So you see, this thing I was just, this is kind of a little gray area where most of us fail to provide an adequate foam to prevent the bad scars along with the mask border. You see here the patient is also wearing this kind of thing. Generally, this is alevin sacrum. I have used this alevin sacrum badly enough in the COVID time. There were so many patients using this BiPAP and having a scar left once they leave for home. I didn't like that at all. So I had use this kind of a foam, I had to cut in between, in the middle, and we just spread it out over the face, and on top of that, you place your mask, and it's beautiful. It leaves no scar at all. I had got a very good experience with this. That is why I'm showing it over here. The ventilation goals, you need know that you have to improve the gas exchange. You have to overcome the auto PEEP. So along with that, you have to titrate the pressure levels. Setting up the pressure, generally high to low. Many prefer high to low, but I generally prefer low to high. I start with the low pressure, I go up to a higher pressure. Now, few words about the high flow nasal cannula or nasal oxygen. I think most of us have been using thoroughly this kind of a machine, HFNC, in our COVID days. Actually, it started prior to COVID days. I have seen this in 2015 being used in some of the bad ARDS patients, but finally, most of them had to be intubated. But in COVID, it has been used very, very extensively. And it's really a very good machine that has actually been a messiah to us for saving the lives of people. So few studies, I'm not going into greater detail with the studies because this is not the time again to bug you with the studies. So most of the studies, they have said that NIV is definitely superior. Superior in the sense this reduces mortality even, and few studies have shown that it reduces the chance of intubation up to 62%. Now, what should we monitor if the patient is on NIV? You have to be very, very observant, and remember, if the patient is on invasive ventilator, that needs lesser attention than a patient who is on BiPAP. The patient on BiPAP needs higher attention. Please look at the GCS, look at the vitals, look at the oxygen saturation, and look at the ABG. And definitely hemodynamics. The best part, the clinical betterment, will be defined by reduction of work of breathing in that patient. What are the predictors of NIV failure? NIV fails at some point of time, and you have to catch that moment, and you have to intubate that patient at the earliest. So unable to reverse the underlying cause or disease process and unable to correct the acid-base derangement within first 2 hours is a bad predictor of NIV failure. The results like persistent hypoxemia, persistent hypercarbia, hemodynamic instability, altered mental status, patient is getting a poorer GCS, patient is edentulous. Again, this is going to, be very bad for failure. Excessive secretion, the patient is having lots of tracheal secretion. There the NIV may fail. And the patient, if patient is older age, that is it. Mostly here the GCS have been taken care of and the Apache score. Major 2 factors which are, which are responsible for NIV failure are the GCS, poorer GCS, and the Apache score. Poorer Apache score, poorer outcome.
Madam.
There are few studies. Now, one word about the immunocompromised patient that I had told you, that multiple RCTs, they have proven that most of the immunocompromised patient did well with the NIV rather than invasive ventilation. And this had trained towards better survival and no significant clinical advantage as mortality infection because patients are already suffering from some life-threatening diseases. There are again few trials. I'm not going to go into the details. The
Madam,
gist part is,
I think we're getting delayed for the next.
yeah, this is the last one. Gist of the story is, in the acute setting, evidence now supports NIPV for respiratory failure secondary to acute exacerbation of COPD, acute cardiogenic pulmonary edema, immunocompromised states, and to facilitate weaning in patients with COPD. These are the main indications. Patients to receive NIPPV must be selected carefully and monitored closely to manage. Do not hesitate to intubate and ventilate in NIV failure, and definitely should be considered as a lung protective strategy for certain forms of respiratory failure. And do not forget to provide good nutrition for a better outcome. That is my take. Thank you all.
Thank you, madam. Any question?
Any question? Yes. Yes, initial part where you are going to use a high pressure, then you have to put in a nasogastric tube, because generally we make that patient, I mean, very much comfortable because they can eat orally and they do not feel claustrophobic. That is why the NIV is mostly used. And this nasogastric tube will be needed if there is a higher pressure in the NIV, and that may cause the gastric distension. That is the only indication mostly. That is it. See, in our practice, we have not gone beyond 22 to 25. We have not gone beyond that. Many a times, many use 30 up till 30, but we do not generally go beyond 22 to 25.
Any other question?
Any other question? Yes. We do not have that. We do not have that, but they, yes. You see, it's still, the legalities are going to come very soon, because there are now, the Supreme Court has to some extent asked the medical council to make a proper pro forma for DNI DNR. So this is going to come very soon, because all over the world this is practiced for terminally ill patients where the medical treatment is futile.
Any other question? I think no question. Thank you, madam.
Thank you.
Achha, there is a small announcement. Those who join OSCE, they will collect the certificate from the registration counter, because many of the names are problem to, spelling. So we had problem understanding the spelling. So you correct your spelling and correct your spelling and spellings and collect the certificates from the counter. So now it's an award giving occasion. So may I request our senior pulmonologist, Dr. Robin Mistro, senior physician, Dr. Amarendra De, our esteemed faculty, Dr. Kranti Garg, and Dr. Lilavati Thakur onto the dais. স্যার বসুন আপনারা। So, poster. Let us come to the poster competition. The first prize goes to Rupa Ghosh from Bose Institute. May I request Dr. Misra to just hand over this prize to this prize and the certificate. Photograph. The second prize goes to this another. There are two first prizes. The other first prize goes to Dr. Priyanka Chaudhuri, Indian Institute of Technology, Kharagpur. This is on bioinformatics analysis for the screening gene biomarkers in hypoxic pulmonary hypertension. Big thing. Dr. Mondal, sir. The second prize goes to Dr. Depkanna De of the Institute of Pulmocare and Respiratory childhood factors important for predicting COPD and asthma in adulthood. Depkanna is not here. Can anybody call Depkanna? But by the time Depkanna comes, may I request Dr. Ms. Shayoni Shengupta to receive the third prize. She is also from my institute. Her work is on DSAT Max in two-chair test. DSAT Max in two-chair test based treatment of pulmonary hypertension and appraisal. So the certificate of Depkanna is left with. We'll give it to her as soon as she comes. Depkanna, please. This is a second prize in poster presentation. The certificates of the quiz are getting ready, so we'll give it to them a little later. Meanwhile, I'll ask Dr. Mondal to speak a few words about his experience and some suggestions about the next Pulmocon.
Good evening. Pulmocon is doing a great job for last 22 years. It is doing some, it is giving some experience on clinical experience, some scientific session, and doing a great job to the medical faculty. I wish it success.
So, sir, you are our esteemed guest. Would you please say a few words about how to make Pulmocon a better program in future?
Pulmocon শুরু হওয়ার পর থেকে আমি প্রায় প্রতি বছরই এটা অ্যাটেন্ড করেছি এবং অন্যান্য কনফারেন্স থেকে এর একটা যে আলাদা একটা ভাব রয়েছে তা সবসময় প্রতীয়মান হয় এবং আমাদের সময় আমরা যেটা পাইনি আমাদের টিচাররা খুবই ভালো ছিলেন কিন্তু একদম সরাসরি ফিল্ডে নামিয়ে দেওয়া রিসার্চ ওরিয়েন্টেড কাজ করানো উৎসাহ দেওয়া এটা যেমন এখন হচ্ছে এবং পালমোকনে বিশেষ করে পিজিটিদের জন্য এত নানান ধরনের সাবজেক্ট চয়েস করে প্রেজেন্টেশন করা হচ্ছে সেটা সত্যিই অভাবনীয় সমস্ত রকম কনফারেন্সে এই জিনিসটা ঠিক দেখা যায় না, সেই জন্য ডক্টর পার্থ সারথী ভট্টাচার্য আমাদের কাছ থেকে অভিনন্দন পাওয়ার যোগ্য, এবং আশা করি উত্তরোত্তর আরো উন্নতি হবে এবং ভবিষ্যতে পালমোকনের আমি আরো সাফল্য কামনা করি।
Thank you, sir. Thank you. Thank you, sir. Dr. Lilavati, this is the first time you have come and participated in Pulmocon. Please tell us your experience and how we can make it better. Is the certificates ready for quiz?
Excellent. It's actually excellent. I had already told you that the topics are very, very pertinent and I mean, up to the time where we are actually doing this Pulmocon, the burning topics are being discussed here. And it's very good that the quiz program, I was excellently, I mean, astonished to see. It's amazing. It's amazing. Very good quiz program has been organized by Parthoda and all in the Pulmocon faculty. Thank you, Dr. Partho.
Thank you very much. So before I request my other two guests to say something, may I declare the first prize of quiz. It is Dr. Devopin Chatterjee and Dr. Rohit Sringankar from AIMS Bhubaneswar. So is there Devopam and Rohit? I request. I request Sandeep to present the prize to them. Be here, be there. There is a small special prize. Please take. Now it is Rohit. Special prize also to Rohit. Nice. The second prize goes to Anirban Bhattacharya and Shubhajit Khamaru from Arjikar Medical College. Thank you. I request Dr. Kranti to just hand over this certificate to them. Anirban Bhattacharya and Shubhajit Khamaru. Shubhajit Khamaru. There's another team that scored second. So there are two teams. The next team is formed by Dr. Rahul Pal and Dr. Rahul Pal and Dr. Akhtarul Biswas. Dr. Lilavati may kindly hand over this prize to Rahul and Akhtarul. Are they here? No. Yeah. I will send it to them. And the third prize goes to Sritama Bandopadhyay and Krishnendu Mukhuti of IPGM and SSKM Hospital. Dr. Mishra, sir, please. So before I end, I have small pleasant duty to request Dr. Kranti to say a few words. I want positive criticism, and then my good friend.
It's
Sundeep.
an honor to be here, and I really thank Dr. Bhattacharya for giving me this opportunity. Criticism, it is very difficult, you know. You'll have to really think and find out a problem. Like I am completely spellbound. This is such a beautifully framed program, particularly for the student teaching and training. Like Really good one, sir.
So you are all
It's
saying good
simply
things.
impossible to find out a fault. So yes, we will definitely think about it and let you know
I
over a
will
period
welcome
of
that.
time. Yes, sir. Thank you. Thank you so much.
Sandeep, your comment. Or sincere comment how we can improve upon.
The fact that this is the 20th Pulmocon itself tells us that this is such a wonderful achievement by any standards. I think you look at it from any perspective, anybody who does a conference for 20 continuous years deserves a huge round of applause and admiration. Consistency and the quality of the scientific program, I think, have been absolutely outstanding. The success of a conference depends on two things, two major drivers. One is the quality of the scientific program, and second is the number of delegates who sit in the hall and wait right till the end. I think that's the real success. And what I've been seeing since yesterday is the halls have been full and people have been here right till the end. The fact that Dr. Partho had the courage to even organize an oscillometry, lung oscillometry workshop, perhaps being done for the first time in a meeting like this, just shows his vision and the passion towards improving science in this field. So full of criticism, Dr. Parthasarthi. I don't think there is any criticism, full of appreciation, no criticisms at all. Thank you so much.
Thank you for the kind words. I've got no words to return because you have taken so much of pain to come and have take lead in such a wonderful workshop. It will be remembered by those who have attended for a long time. So with this, we have come to the fag end of our Pulmocon 2022. It is my duty to give vote of thanks. At least is actually huge, but I may be forgetting a few names. I wish to express my heartfelt thanks to all who have helped us to hold this Pulmocon 2022. This may start with my staff members, the sponsors, the local venue and their people, the gentleman who organized our hospitality food, the audiovisual system, those who have taken care of, and finally all the delegates, and after that all my faculty members, those who have taken pain to come. I remember Ajmal Khan has come, gave his talk and went back. This is really a painstaking process. He has important business, but still he could make a small gap to come to Pulmocon, give his talk and back. Sundeep is too busy. He's one of the leading scientists of the country. He has taken 2 full days to Pulmocon. I'm obliged to him. I'm obliged to all my faculty members. I hope that if Pulmocon continues, they will be blessing us time and again. So with this, I thank you all and declare that the Pulmocon is over. Thank you very much. Let's hope that we'll be meeting again. And as a country, I will request everyone to stand up and sing our national anthem. Let us start. Pulmocon 20, please.